Hello all, I am Dr. Harmeet Goyal taking up the FMGE July 2023 OBG Recall Session, and whatever questions I have collected from the students, I have tried my best that those questions should exactly look like the way it has been asked in the exam. Hope you must have done your best in the exam. Let us just start the GYNAE Recall Session. You can keep on writing your answers in the chat box, or if there is any query you can ask. Now question number 1, what hormones are secreted by the Leydig cells and the Sertoli cells? All of you know that the Leydig cells and the Sertoli cells are present in the testis, and they start secreting the hormones in the intrauterine life around 7th week of pregnancy. Now the Leydig cells have got receptors for LH, and Sertoli cells have receptors for FSH. This FSH and LH are called as follicular stimulating hormone, and LH is luteinizing hormone. So let us read the options given to me. The options are, and they are asking this question, that which is the hormones that are being secreted by the Leydig cells and Sertoli cells in the males. So the options given to me are DHA and testosterone, testosterone and inhibin, testosterone and DHA, inhibin and testosterone. So clearly I have been teaching this in my classes that testis or undifferentiated gonad at the 7th week of pregnancy starts secreting the hormones. Sertoli cells, they secrete Mullerian inhibiting substance which inhibits the development of Mullerian duct in the males, and Leydig cells secrete testosterone. Okay, so Leydig cells, this is in the intrauterine life, secrete testosterone. Testosterone is very important for the development of male internal genital organs. Male internal genital organs are seminal vesicles, epididymis, vas deferens and ejaculatory ducts, and this testosterone in the intrauterine life is also important for development of male external genitalia. This is in the intrauterine life. Now what does Sertoli cells secrete at the time of puberty? Sertoli cells secrete the androgen binding protein, so that at the time of puberty the testosterone which has been secreted by the Leydig cells should bind to this, and it will keep the testosterone levels high in the testis so that spermatogenesis can take place. Sertoli cells also secrete a inhibin hormone. So what are the hormones secreted by Sertoli cells is Mullerian inhibiting substance, androgen binding protein and inhibin. So answer to this question is Sertoli cells secrete inhibin and Leydig cells secrete testosterone. So the correct answer is inhibin, and the correct answer is the Leydig cells secrete testosterone. Leydig cells secrete testosterone and Sertoli cells secrete inhibin. So the correct answer is B. Leydig cells secrete testosterone and Sertoli cells secretes inhibin. Fine. Next. Total spermatogenesis is complete in how much time? This is again very important, and I want you to be ready for your next upcoming PG entrance exam. Those who have to finish their internship after finishing their FMG exam. So these questions are important for that also. Spermatogenesis is finished in 74 days. Now let us quickly switch over to the next question. Which of the following is a direct cause of maternal death? There are various students sending us the different answers, so I will be discussing from every point of view. Direct cause of maternal death. First of all, you have to know maternal death. Maternal death is occurring up to 42 days of delivery. So that is the definition of maternal deaths. Now, direct cause, embolism, heart disease, anemia are the medical causes, because it is not that embolism is only seen in pregnancy, or heart disease is only seen in pregnancy, or anemia occurs only in pregnancy. So embolism, heart disease, anemia, these are the medical causes, and if the disease is not being controlled, it can lead to death. So I am not going to consider these three as the direct causes of maternal death. So according to me, preeclampsia. Preeclampsia means blood pressure plus proteinuria developing after 20 weeks of pregnancy. So the term preeclampsia means the lady is normotensive in less than 20 weeks of pregnancy. At each antenatal visit, we do check the blood pressure. So when the blood pressure is raised after 20 weeks of pregnancy, plus there is proteinuria, that is by dipstick method we check it, and 2+ is taken as significant. Although to describe the severity of preeclampsia, proteinuria has not given any significance. It is the blood pressure and the end organ damage. Okay. So the answer to this question is preeclampsia. So I am going to take this session in very crisp and concise manner. Now, few questions I want you to just revise. Most common cause of maternal mortality in India is postpartum hemorrhage. That is highly preventable cause, and the drug that is recommended by WHO to prevent postpartum hemorrhage is injection oxytocin. Now, most common indirect cause of maternal mortality in India, you can keep on writing your answers in the chat box. The answer is anemia. A lady delivered a child and went into shock. So most important cause is postpartum hemorrhage. A lady delivered a child and went into shock, that is out of proportion of blood loss. The answer is acute inversion of uterus. So I am happy that most of you are being attentive in the session and you are writing. Good afternoon everybody. Dr. Hardik, Dr. Maj, Dr. Chahal, Dr. Mithu, Dr. Abhinav, Dr. Megha, Dr. Vivek, Dr. Inder, Dr. Garg. All of you are, very impressively writing all the correct answers to the questions which I am discussing. Now, this is interactive session. If you have any doubt, you can keep on writing in the chat box. I can read your chat box in front of me. Now, a lady delivered a child and went into unexplained shock. Always students remember, this is amniotic fluid embolism, and nowadays questions are very commonly asked in amniotic fluid embolism. So what I have heard is the clinical pattern, the students have given it very perfectly, but the pre and para clinicals are being asked in the integrated manner. Doesn't matter. The long questions are always easy. You get a lot of hints in the questions. Now, a lady delivered a child, started gasping, breathless, cyanosis and collapse. This has been asked in INI CET exam and it has been asked in FMG exam. All these are been clinical questions which they have asked in the previous exams. So the answer to the last point is again amniotic fluid embolism. Okay, next. A lady, this is my question number 3. A pregnant lady with 32 weeks of pregnancy with blood pressure 140/90, pedal edema and urine proteins by dipstick method is 2 plus. Urine proteins by dipstick method is 2 plus. So what is this category? I am sure every one of you different students are writing different answers, so I will be discussing from every point of view. You are the better judge because you have given the exam and you know what type of questions have been framed in the exam. So what is the answer to this question? I can read your answers, Dr. Mithu, Dr. Vivek, Dr. Shine, Dr. Inder, Dr. Meeta. So the correct answer to this question is preeclampsia, as I have already discussed in the previous part. Now the difference between preeclampsia and chronic hypertension, basic thing is here there is blood pressure plus proteinuria developing after 20 weeks of pregnancy, whereas in chronic hypertension the blood pressure is present from the beginning of pregnancy and there is no proteinuria. Chronic hypertension, even after the delivery, the blood pressure does not come down to normal, whereas the blood pressure in cases of preeclampsia after the delivery, most of the cases comes down to normal. I want to add up something latest. I have already recorded this in my app also for Ellen, that first line antihypertensives used in pregnancy. The correct answers are labetalol, hydralazine and nifedipine. The latest recommendations are that these three antihypertensives are the one which are recommended as first line drug and they are safe. Yes. Signs of end organ damage, yes, that is a feature of severe preeclampsia. Fine. So what are the first line antihypertensives in pregnancy? Labetalol, which is alpha beta blocker, hydralazine, which is arteriolar dilator, and nifedipine, which is calcium channel blocker. In cases of hypertensive crisis, we prefer labetalol plus nifedipine or hydralazine because it can be given in the IV form. Fine. Next question. This is my question number 4. 21 weeks married pregnant female was diagnosed with fetal congenital malformation. The period of gestation is 21 weeks. At 21 weeks of pregnancy, the ultrasound has shown congenital malformations. How many doctors' opinion is required and whose consent is needed? This I have been discussing in my sessions. When there was a high yield question session or my YouTube sessions, I have already discussed this. I am sure you can write down the correct answers because this is an interactive session. I can read the answers, Dr. Mithu, Dr. Vivek, Dr. Meeta, Dr. Soumya, Dr. Tiwari. Okay. So, you have written that mother consent and opinion of 2 doctors. Yes, you are absolutely right. The correct answer is C. Okay. According to the latest MTP Amendment Act 2021, the MTP is legal and the upper limit has been increased to 24 weeks. Opinion of 1 doctor is enough if you are doing MTP up to 20 weeks, and opinion of 2 doctors is needed when MTP is done between 20 to 24 weeks. So in my question, the period of gestation given to me is 21 weeks and the MTP can be done on mother's consent. MTP can be done on mother's consent. Okay. So all of you have written the correct answers. Let me switch over to the next question. This is my question number 5. What is the other name for outlet forceps? You know, we apply outlet forceps nowadays, and the name of the outlet forceps is the Wrigley's forceps, because these are the short curved forceps without any axis traction device. These are short curved forceps without any axis traction device. Okay, and it is to be applied at outlet when the fetal head is visible in the perineum. Fetal head is visible in the perineum without separating the labia. Fetal head is visible in the perineum without separating the labia. That means the baby is at the level of outlet and crowning has already occurred. So this is the safest type of forceps. The answer to this question is A. But suppose if any other type of forceps is being asked, then what should be our answer? Okay, so for that reason I have just added up some of the images of Keeland forceps, Das forceps, Piper forceps. Although these forceps are no longer used. Okay, these are no longer used. Okay, so this axis traction device, which was the long curved forceps with axis traction device, was the Das forceps. It is not used. This Piper's forceps was used to deliver after coming head of breech. To deliver after coming head of breech. So this is again no longer preferred. And the third type of forceps is Keeland forceps. So that you can remember for the next exams you are going to write. Do not restrict yourself to MBBS. Add up a qualification to your name. We will all boost you up for your better career. So Keeland forceps was used in cases of deep transverse arrest. It is a rotational plus extraction forceps. So the outcome of the baby was poor. Hence, it has been replaced by cesarean section in case in occipito-posterior the deep transverse arrest occurs. So management for deep transverse arrest nowadays is LSCS. Deep transverse arrest is common in android pelvis. All these questions are important. Okay. So I am sure you must have marked the correct answers. Next, question number 6. In which week the diabetic screening is done in the pregnant lady? So I have got different options from different students. Now diabetic screening, we say that universal screening for diabetes is to be done in India, since the incidence of diabetes in India is high. Now, the latest guideline recommends the first antenatal visit you should do the diabetic screening, and you can repeat the test at 24 to 28 weeks of pregnancy. So you can, according to the DIPSI criteria, you give 75 grams of glucose and check the blood sugar levels, blood glucose levels after 2 hours, and the cutoff value, it should be less than 140 milligram per deciliter. This is normal. If the value comes out to be more than 140 but less than 199 milligram per deciliter, this is, like gestational diabetes. Okay. And if the value comes out to be more than 200 milligram per deciliter, then this is gestational diabetes. Now, if the first antenatal visit is not given and according to the FOGSI criteria, all the pregnant ladies should be screened according to this question, 24 to 28 weeks of pregnancy. If there's a family history, I would say first antenatal visit, you do first screening test and repeat the test at 24 to 28 weeks of pregnancy. Why 24 to 28 weeks of pregnancy? Because at 24 to 28 weeks of pregnancy, the insulin resistance is high in pregnancy, due to certain hormones like HPL, like progesterone, like cortisol. These are the hormones where there is increased insulin resistance. So the most sensitive time to do testing for diabetes is 24 to 28 weeks of pregnancy. Okay, if first antenatal visit was present in pregnancy, latest guideline says that you should be doing the test in first antenatal visit. That is our national guidelines, and you should repeat the test at 24 to 28 weeks of pregnancy. Okay. Question was pregnant lady with family history of diabetes and option had first visit. If the option says first ANC visit with family history of diabetes, I am going to mark this answer. If that is not given in the option, then the answer goes for 24 to 28 weeks. Dr. Ali, the questions which were given to me, the options were this. Okay. So, that is why the discussion is important. If the first antenatal visit was given and there is a family history of diabetes, I said I am going to mark first antenatal visit as my answer. If that is not given in the option, then I am going to mark 24 to 28 weeks of pregnancy. Detailed discussion of universal screening according to our national guidelines is first screening should be done at first antenatal visit and you should repeat at 24 to 28 weeks of pregnancy. So Dr. Ali, Dr. Pillai, Dr. Gupta, both ways I have discussed the question. So you are the better judge. If first antenatal visit with a family history of diabetes was given, then that should be the answer. Next. This is my question number 7. We can extend the MTP beyond 24 weeks in what condition? Okay. The upper limit for MTP legal is 24 weeks. Okay, MTP should be done according to the latest guidelines in less than 24 weeks. Students, you should be satisfied because both ways I am discussing the question because different set of students are sending us the different questions. So I have already discussed. Yes, Dr. Ali, I appreciate your comments. Yes, you have got it. Very correct. Okay. So I have already clarified. Now, in which condition? Is it rape? Is it contraceptive failure? Is it fetal malformation or is it a minor? In all these cases, MTP is allowed till 24 weeks. But in case of rape, if the pregnancy was unnoticed and in that case, in the rape victim, the pregnancy has crossed beyond 24 weeks, what we have to do is, now according to the latest MTP guidelines, there is a special medical board. And this case will be taken up in special medical board which consists of a gynecologist, pediatrician, a radiologist and a gazetted officer appointed by state, government or union territory. So this case will be taken up by the special medical board and their opinion is the final opinion. If they say MTP has to be done, it should be done. Now, why there was Amendment Act after 1971? Because there was certain cases like rape victim, etc., where the pregnancy is going beyond 24 weeks. There was in the Indian law, there was no provision for doing MTP in that case. But nowadays there is amendment needed, so this case should be taken up. Yes, we can do in this case. For that, contraceptive failure is always a first trimester MTP indication, but in these cases we can do MTP till 24 weeks. According to this option, I am going to select rape victim as the answer. Now, next question, in which of the following condition induction of labor is not done? This is a very straightforward question. Induction of labor is not done in which of the following condition? Is it oligohydramnios? Is it central placenta previa? Is it hypertension? Or is it premature rupture of fetal membranes? Premature rupture of fetal membranes. So what is the answer that you have marked? Yes. The correct answer to this question, is central placenta previa. For central placenta previa, you have to do an elective cesarean section. For central placenta previa, you have to do a planned cesarean section at 38 weeks. So I am sure every one of you have marked it very correctly. So the answer is central placenta previa, where in case of oligohydramnios, hypertension in pregnancy and premature rupture of membranes, you can always do augmentation of labor or induction of labor. Now, question number 9. Hyperestrogenic condition are all of the following except. Now, hyperestrogenic condition. Okay. Tamoxifen use, endometriosis, ovarian cancer, all this. Tamoxifen is an anti-cancer drug used for breast cancer, but as a side effect it causes endometrial cancer, because the reason is it is acting as an estrogen antagonist. Estrogen antagonist on breast tissue, but it acts as estrogen agonist on endometrium. So raises the risk for endometrial cancer. Endometriosis is also a hyperestrogenic state. Ovarian cancer, like endometrioid cancer, is associated with the endometrial cancer, endometrioid adenocarcinoma, and moreover, hyperestrogenic state is a polycystic ovarian disease, and if there is multiple ovulation being done, the risk of epithelial ovarian tumor is increased. So answer to this question is B, low BMI. Okay, low BMI, I hope every one of you will agree with me. Low BMI is the answer to this question, because if the patient is in normal weight or normal BMI or low BMI, then the androgen levels, the fat is less, so androgens are less. Whereas in cases of obese females, the fat is high, so fat produces androgens, and from androgens there is estrogen production. So hence obesity is a risk factor for endometrial cancer. Obesity, diabetes, hypertension. This is a risk factor for endometrial cancer. I hope this is clear to you. Now, question number 10. How many weeks of gestation age the uterus will correspond to the post-delivery? This is very simple question. So the answer to this question is 20 weeks, because after the delivery, so umbilicus level is lower border 20 weeks, middle 22, above 24 weeks. After the and symphysis pubis was 12 weeks, Xiphi sternum was 36 weeks. Now, after the delivery has occurred, the uterus will come down to the umbilicus level, so it will correspond to 20 weeks of pregnancy. Next question. Pregnant women at 32 weeks of pregnancy comes to the emergency with severe abdominal pain and bleeding, and the uterus was tender and fetal heart rate is absent. Some of the students have given me the option. It was fetus. In the question, it was fetus not palpable. But the hint in the question was severe bleeding. Hint number 1. Number 2, the main important hint in this question was tender uterus. So, which condition do you get? Severe pain abdomen, tender uterus, fetal heart rate may not be localized, or fetus not palpable. This is purely abruptio placentae. Now, they wanted to confuse you between rupture uterus and abruptio placentae, but if your preparation is logical manner, then all of you must have marked your answer as abruptio placentae, even if the blood pressure is not given. Till in the previous exam, they were mentioning the blood pressure as 150 by 100. So, that is preeclampsia or pregnancy-induced hypertension, and very important complication occurring in a preeclampsia patient in the antenatal period is abruptio placentae. Because of vasoconstriction of the umbilical cord, there is premature separation of placenta and leading to the formation of retroplacental clot. Now, why the fetus is not palpable? It is not rupture uterus. It is that there is premature separation of the placenta that has taken place, and there is formation of retroplacental clot, and if there is a blood collection in the uterus, that gives a tender swelling. If there is so much of the blood collected in the uterus, then you may not be able to palpate the fetal parts very easily, plus fetal heart rate, it will be difficult for you to localize. Blood pressure was falling, even then it is a case of abruptio placentae, because it cannot be rupture uterus unless until there is something written as in the question grand multipara or previous LSCS case and next pregnancy or previous classical caesarean scar or myomectomy scar. Nothing such history is written in this question. So, I am going to mark abruptio placentae as my answer. Now, question number 12. Question number 12. Nowadays, they have started asking question from so many topics, and Obs-Gynae is very scoring subject. Okay, you can easily score marks in this subject. I had been telling in my sessions, and most of you are writing your wonderful options. Okay, yes, Dr. Ali, you are writing everything correctly. I can read your comments in the chat box. Yes, Dr. Tiwari, you have also written very correctly. The option is, answer is B, that is abruptio placentae. Now, 3 swab test. 3 swab test is done for urinary fistulae, and this is also called as Jones dye test. And which dye you fill in the urinary bladder? Suppose this is the urinary bladder. So, you fill a methylene blue dye. This is methylene blue dye, and in the vagina you keep 3 cotton swabs. 3 cotton swabs, number 1, number 2 and number 3. Now, they said middle swab is stained of the dye. Now, let us see the options: uretrovaginal fistula, vesicovaginal fistula, urethrovaginal fistula, uretrovaginal fistula. There is no term like that. Okay, it must be something else which is written in the option. So, uretrovaginal, vesicovaginal, urethrovaginal fistula, 3 swabs. After the urinary bladder has been filled with the methylene blue dye, 3 swabs are kept in the vagina. Now, after some time, you look at the swab. If suppose first swab is wet, is not stained but wet, smelling of urine, then that is ureterovaginal fistula. If blue second swab is blue, then it is vesicovaginal fistula. In this question, they have asked about the middle swab. So the answer to this question is vesicovaginal fistula, VVF. Okay. Now, if the third swab is stained blue, for example, then it is ureterovaginal fistula, if it is stained blue. So this is Jones 3 swab test. Nowadays, VVF, most common cause of VVF in countries like India is obstructed labor, and you repair it after 3 months. Most common cause of vesicovaginal fistula in Western countries is gynecological operations like Vardhaim's hysterectomy, gynae surgeries like Vardhaim's hysterectomy. But in a country like India or developing countries like India, most common cause of vesicovaginal fistula is obstructed labor, and the symptom is true incontinence of urine or continuous dribbling of urine from vagina. The investigation done for vesicovaginal fistula is cystoscopy, and for ureteric fistula you can go for IVP. Next, this is question number 13. Hormone in molar pregnancy. Few students have given me this option: GnRH, FSH, HCG or LH. Always in the molar pregnancies or trophoblastic diseases or trophoblastic tumors, the features are happening because the trophoblastic tissue secretes the HCG, and the features of thyrotoxicosis, pregnancy-induced hypertension or hyperemesis is caused by HCG. So the correct answer to this question is HCG. Okay. Another set of students have given me question like this: molar pregnancy is usually diagnosed in early pregnancy due to bleeding and abnormal features of ultrasound higher than usual levels of the what are the hormonal levels. So again, according to this, it is HCG, and ultrasound is the investigation of choice. And what do you see in this image is snow storm appearance. For me, all the students are important, so whichever is the format of question, the answer here is HCG. Okay. So whether this way the question was asked or this way the question was asked. Now, question number 13, identify this anomaly. So this is actually not very commonly which we see in the obstetrics. This is a specimen. It is not anencephaly, it is anencephaly craniorachis. So that is the answer. So for more details, sometimes एक या दो question थोड़ा हटके भी पूछ लेते हैं. So for that reason, this you should, I think, for the malformations, it's better that you should be reading this in embryology part. Okay. Okay, in the first paper, Dr. Ali is saying the vesicular mole was given. So I am okay with that, because I have told you that this is the correct answer to this question. So question number 14, identify this maneuver. So when I have taken up the topic of normal labor, I have already shown you this image, or even the image based session which I have taken up. So this image I had already added. So this is not Lofset's, this is not Morrissey-Smiley V8, this is not Pinard's maneuver. Pinard's, Lofset's and Morrissey-Smiley V8, all that are done for breech. This is for breech. Morrissey-Smiley V8 technique is for breech. This Ridgen maneuver, answer is C. It is done in cases of you are conducting a vaginal delivery. In this case, one hand is put. So this image is a Ridgen maneuver. When you are conducting the vaginal delivery, one hand is onto the chin of the baby and another hand is on the occiput of the baby, and you conduct the delivery of the head towards the mother's abdomen. This way to avoid any perineal tear. Okay. Okay. If image was not asked in this question, Dr. Ali is writing like maneuver done to deliver the fetal head. So maneuver done to deliver the fetal head, then it is again a Ridgen maneuver. Okay, Ridgen maneuver. So you can just go through the image so that you can easily remember this. Now what is Pinard's maneuver, Lofset's maneuver, Morrissey, Smiley-Viet technique? This maneuver is a Lofset's maneuver for delivering the breech with extended arm. Okay. Now this maneuver is a Pinard's maneuver. This is to deliver breech with extended leg, and this maneuver is Morrissey Smiley-Viet technique to deliver after coming head of breech. After coming head of breech. So I hope this answer is clear to you, and other images are being added so that you can easily understand or remember the other options. This is very clear-cut image, even if the options are not being provided to me. This is Veery's needle, and this is used to create pneumoperitoneum in cases of laparoscopy. Whether laparoscopy you are doing for diagnostic purpose or you are doing for therapeutic purpose. Now carbon dioxide is the gas used to create a pneumoperitoneum. Since all of you know this, so I am not going into very details of this. Now question number 16. Which is not used as an emergency contraception? So emergency contraception, I have always discussed. Emergency contraception is a postcoital contraception. It is hormonal, which is to be given within 72 hours of unprotected coitus, and it can be IUCD to be inserted within 5 days of unprotected coitus, and only IUCD that we can insert is the copper T. Now among the hormonal, it is LNG pill which is most commonly used, and it is single dose, that is 1.25 milligram single dose. Number 2 is OCPs, that is 4 tablets after a gap of 12 hours, 4 tablets. And third one is RU486. Nowadays even ulipristal is being used as 30 milligram single dose within 5 days of unprotected coitus. Okay. So let us read the options. Ulipristal 30 milligram, this is used. LNG 7.75 and 2 divided doses, no, this is wrong answer. So the answer to our question is B. Since levonorgestrel 1.5 milligram single tablet is the one which is most commonly used in a country like India. Okay. No, Dr. Singh and Dr. Kumar, the answer is not A, answer is B. Because levonorgestrel 1.5 milligram single dose has been used. It is not given at divided doses after 24 hours interval. So if you have to give it in 2 doses, then it is 12 hours apart, otherwise the contraception will not be effective. So which is the most commonly used emergency contraception in India, whether it is married or unmarried female? So the correct answer is LNG pill 1.25 milligram single dose. Which is the best emergency contraception? Answer is copper T. Okay. Ulipristal is used in other countries. The dose is 30 milligram to be given within 5 days of unprotected coitus, and it is progesterone receptor modulator. Progesterone receptor modulator. It has only two uses. One is as a post-coital contraception and another one is fibroid uterus. Okay. So, next question. Question number 17. Drug used for chemoradiation in cervical cancer. All of you know the answer is cisplatin. Okay. So, the most commonly used drug as a radiosensitizer, chemotherapeutic drug which is used as radiosensitizer is cisplatin. This is clear cut and straightforward question. Next, question number 18. In which trimester beta HCG, unconjugated estriol, alpha fetoproteins and inhibin test is done in the antenatal screening? One set of students have sent me this question, and another set of students have sent me a question that quadruple test is done in which trimester of pregnancy. So, quadruple test is done in the second trimester of pregnancy and the timing is 16 to 18 weeks. The markers are alpha fetoproteins, beta HCG, estriol and inhibin A. Alpha fetoproteins are decreased, beta HCG rises, estriol decreases, inhibin A rises. This is for trisomy 21. In the first trimester, you do beta HCG which is increased and you do PAPA, pregnancy associated plasma protein, which is decreased. In the second trimester, you do triple test, but nowadays triple test has been replaced by quadruple test. Okay? Quadruple test. Fine. So, I am sure you must have done this question also correct. Question number 19. On 5th postpartum day. So, here you get your answer. 5th postpartum day, women presents with low mood, sadness, irritability, crying, restlessness, depression and reduced sleep. This is most of the time self-limiting. Self-limiting. And what I have read in obstetrics, even my post-graduation time, some of the patients we used to get like this, and the answer to this question is postpartum blue, and my colleague from psychiatry will be the better person to tell you the details of this question. So, it is postpartum blues. Wherever 5th postpartum day is written, sadness, irritability, crying, depression, the answer is usually postpartum blues. Next question, question number 20. Women with postpartum hemorrhage was treated with ergometrin, okay, and oxytocin. Still the bleeding has not stopped. Which prostaglandin derivative should be used? So, first line drug is oxytocin, then you can use ergometrin, okay. Then if the bleeding is not been stopped, then we use prostaglandin E1, that is misoprostol tablet, and we use it by 800 micrograms sublingual route. Vaginal route is not preferred because it is postpartum hemorrhage occurring, so it will be washed out. Okay. So, I am sure you are knowing the best answer. Dinoprost is prostaglandin E2 gel that is used for induction of labor. Carboprost is prostaglandin F2 alpha that can also be used. But if you go by the guidelines, misoprostol is the one which is preferred over the carboprost. Now, question number 21. When is the suction evacuation done? So, suction evacuation is a method for first trimester MTP. So, the correct answer to this question is 12 weeks. because if why I am not choosing the 6 weeks as my answer, because up to how many weeks of pregnancy suction evacuation can be done as a method of MTP. So the answer is 12 weeks. Even suction evacuation is being done for H molar pregnancy evacuation in young female. Okay. What is the most common complication of suction evacuation method? Answer is always bleeding due to incomplete evacuation. Number 2, what is the suction evacuation pressure? Answer is 400 to 600 millimeters of mercury. So this topic is again very important for questions. Now next is question number 22. 47xxy, what is the wrong statement? What is 47xxy? Can you mark your, can you write down in the options? What have you marked? What is 47xxy? Can you type in the chat box? Dr. Vivek, Dr. Sujata, Dr. Shogun, Dr. Pillai, Dr. Ali. Klinefelter syndrome. In Klinefelter syndrome, they are tall males with gynecomastia, hypogonadism and male infertility. They have extra X chromosome, so they have sex chromatin is present in them. Okay. So when there is hypogonadism, so FSH will be decreased. If FSH is decreased, that is why they are infertile, because spermatogenesis will be affected in this case. They are azoospermic, correct, decreased testicular size, hyalinization of Sertoli cells, all these 3 are correct. Wrong answer is decreased FSH. They are having increased FSH. So the answer to this question is A, decreased FSH. I hope it is clear to you. Yes, all of you are writing Klinefelter syndrome as the correct answer. Now next is question number 23. Male had infertility and respiratory infection. Respiratory infection and infertility, this is Carter-Jenner syndrome, and in Carter-Jenner syndrome the male has frequent respiratory infections and infertility. It is autosomal recessive disorder. So ciliary dyskinesia is the answer. Ciliary dyskinesia, because this is Carter-Jenner syndrome. Details you must have read in the pathology. Next question. Question number 24. A girl with PCOS, and what type of test is to be done? So options given to me by the students are sleep study, urine study, FSH and serum testosterone. Well, I don't understand the urine study here or the sleep study, whether they want to ask about the okay, I don't know, the students have told me, but if you take it as what is the most commonly done investigation in PCOS patient, so the answer is we check the hormonal profile where there is FSH-LH ratio, E2 to E1 ratio, fasting insulin, and the first investigation we do it is serum testosterone levels. Serum testosterone levels. Fine. So if this question is written, yes, you are writing, Dr. Tiwari, correct one. But if I take up this question, first test to be done to differentiate like PCOS from congenital adrenal hyperplasia or late onset or from the virilizing ovarian tumors, serum testosterone is the one which is done. Other investigations include LH FSH ratio. So serum testosterone in this case is more than 70 nanogram per ml but less than 200 nanogram per ml. So that is PCOS. LH to FSH ratio is increased, then E2 to E1 ratio is also decreased, and there is fasting insulin levels which is done, which is elevated, plus LH is also elevated, and inhibin is also elevated. Okay. So details you must have studied in the preparation time. Now next one, question number 25. McCall's scaldoplasty is done in. McCall's scaldoplasty is done for enterocoel repair. So it is McCall's scaldoplasty or Moskowitz repair. These are the two surgeries which are done for enterocoel. For rectocele, the surgery is posterior colpoperenniography. Okay. So urethrocoel is like repaired along with cystocele, and the surgery is anterior colporrhaphy. For vault prolapse, there are various surgeries like colpopexy, etc. Okay. So that's all from this discussion session. This question number 26, which has been given to me, but I would say this is a more of a question of dermat. So according to this image provided to me, it appears to me as condyloma acuminata, and the cause is HPV 611. Okay. Yes, I am considering all the comments, Dr. Ali, regarding the previous question. Okay. See, I have discussed the question of PCOS, like the investigation which is to be done, then answer is testosterone. If they have asked least to mark, okay, whatever you are framing the question, according to what the correct option, the students know it better because they have given the paper. So what was the exact language of the question? So like you have confidence in yourself because the questions given to us, according to that question and options provided to us, we are taking this discussion. So hope this session was useful to you, and like I switch over this like to the other faculties for the discussion of other subjects. So all the best. Sincerely hoping that all of you will come up as winners. Thank you for this session.
Okay. So hi, afternoon friends, afternoon everybody bache. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And I have especially put this slide in our recall session because pathology is always going to be your savior in the FMG exam. I am saying so because जब मैंने बच्चों से recall का पूछा था, so few of my closest friends gave the paper this time and their first response was कि सर आप तो chill करो, path के ना questions आए नहीं, there were hardly any questions from pathology. What they actually meant was कि the path questions were simple, straightforward, non-tricky, as compared to the other paper which was slightly on the trickier side. I have approximately 17 pathology questions, out of which, take my word for it, you have to be right. Seriously, thanks for the kind words. We will be seeing you have to be right in 16 of these. Firstly, simple straightforward paper tha, straightforward questions the. Dekho, last time your paper 2 was trickier. This time paper 1, especially probably biochemistry, PSM, they were much on the trickier side. Paper 2 थोड़ा सा लेंथी था, बोला जा रहा है कि थोड़ा सा ट्रिकी भी था, बट यू वर एबल टू सॉल्व इट बेटर देन पेपर 1. बट बच्चे पैथोलॉजी नहीं, कुछ नहीं, बिल्कुल डिप्रेस विप्रेस तो कुछ होना ही नहीं है दोस्त. एंड रिजल्ट वी विल बी सीइंग इट. path is going to be your savior. चाहे जो मर्जी सब्जेक्ट ट्रिकी आए, चाहे कोई सब्जेक्ट कम हो ज़्यादा हो, पैथोलॉजी इज़ कांस्टेंट एंड इट इज़ गोइंग टू बी योर सेवियर. सो फटाफट से हम लोग ख़त्म करते हैं. आई विल कीप इट एज अ शॉर्ट स्वीट सेशन, 10-15 minutes एंड वी रैप इट अप. आई वॉन्ट ऑल ऑफ यू टू कीप ऑन टेलिंग मी द आंसर्स. ब्रेस्ट लम्प दिया है. It is even, the examiner gave you the microscopy as well as it was written that it is associated with loss of E. cadherin. E. cadherin gene mutation is seen in two cancers. First is lobular carcinoma breast and it is also seen in signet ring cell adenocarcinoma GIT. Signet ring cell adenocarcinoma GIT. What do we see in microscopy? All the cells, they are present in single file pattern. The cells, they are in single file pattern. Isme, suppose there is any change in language of the question or something, please do keep on telling me, keep on writing it in the chat box. Next, amyloidosis, sabka ek favorite topic. Hemodialysis associated amyloidosis. How many kidneys do we have? I had put this question 2-3 times in the CBOT also. We have 2 kidneys now, so it is associated with beta 2 microglobulin. Hemodialysis associated amyloidosis, beta 2 microglobulin. We have one brain, so A beta Alzheimer's disease. A beta is Alzheimer's. Next, does it matter दोस्त? तन्वे, जैसे ही E. cadherin gene mutation बोला गया है या loss of E. cadherin or negative or absent, does not matter at all. The answer is lobular carcinoma breast. Next, third question. Examiner told you that the patient is a young female with respiratory discomforts and distress. Lung biopsy showed the presence of asteroid bodies. It was written in the question that asteroid bodies are present. I was always after your life, bodies are important. I mean, no double meanings. Howell Jolly bodies इतनी बार पूछ चुके थे, megaloblastic anemia, post-pnectomy thalassemia. Asteroid bodies and Schumann bodies, sarcoidosis. This is what, asteroids are something which are falling from the sky. Star-shaped inclusions in giant cells. Star-shaped inclusions in giant cells, asteroid bodies, sarcoidosis. Next question. Sjogren's syndrome पे एक simple straightforward question आया था. Dry eyes and dry mouth seen in, nothing else was written. Dry eyes and dry mouth seen in SLE, Sjogren's syndrome, systemic sclerosis. It is a feature of Sjogren's syndrome. Feature of Sjogren's. तो अपने ये 2 question भी simple straightforward हो गए. Next question. Multiple myeloma. Every time examiner used to ask you 2-3 questions on multiple myeloma. इस time एक ही पूछा, in which he gave you elderly male with low back pain. Even if you were not able to read protein electrophoresis, बच्चे कोई फर्क ही नहीं पड़ता. Elderly male with low back pain, calcium is increased, there are bony lytic lesions, craft features are present. Diagnosis, multiple myeloma. On protein electrophoresis, in this CBOT exam, I had put a double star and said, अब की बार ये वाला question आएगा, it shows the presence of M band. That was on the YouTube session, M band. This is the M band or the monoclonal band seen in multiple myeloma. Next question, pedigree chart. इसमें तो बहुत confusion है. Many students, majority of the students told me कि sir, this was the pedigree chart that was given. अब इसमें क्या हो रहा है कि there are 2 families which are involved and when 2 carriers mate with each other, that is 2 families हैं, when 2 carriers mate, then 25% children are getting affected. This was autosomal recessive. autosomal recessive diseases skip generations versus autosomal dominant which do not. इस फैमिली को देख के हमें पता है कि दिस इज नॉट ऑटोजोमल डोमिनेंट बिकॉज द चाइल्ड इज डिजीज्ड, नन ऑफ द पेरेंट्स आर डिजीज. सो ये है ऑटोजोमल रिसेसिव. Most probably this was the chart, this was the pedigree chart that was given to you. Many of the students had told me कि सर autosomal dominant का था, one parent was affected and नीचे 50% था. So it totally depends on the pedigree chart. Another question में plasma cell थे. Aditya दोस्त, I do not have that question with me. Please do give me that question. Write it right now and I will take care of it दोस्त. Next, this is again CBOT question. Pregnant female who is thalassemia trait. Thalassemia trait मतलब one allele is normal, the other is abnormal. Her husband is also thalassemia trait. In autosomal recessive diseases, both the parents are carriers. So who will be the 4 children? Beta beta, beta beta 0, beta beta 0, beta 0 beta 0. So what is the risk of child to be thal major? 25%. Srinath, perfect. Same pedigree tha those, then it was autosomal recessive pedigree chart. इसमें in autosomal recessive both the parents are carriers, so risk of child to be thal major 25%. 25%. अच्छा, one more thing, and this is a session for the juniors also. Seniors बच्चे पैथोलॉजी में बताने हैं कि कौन से क्वेश्चन में गलत गए. In my 9 years of teaching experience, this is the first time that I have written the question numbers along with it. I never write the question numbers. मैं इसलिए लिख रहा हूँ क्योंकि अब की बार का पेपर थोड़ा सा tough and tricky था. So I want to emphasize the fact that path is going to be a savior. Immune hemolytic anemia. There are four types of hypersensitivity. One is asthma allergy. 2, antibody mediated hypersensitivity. So the minute immune पूछा गया है, that is antibody mediated hypersensitivity, the answer is type 2. हर बार वो आज तक they used to give the history of a young female went to park, got bee sting injury, that is type 1 hypersensitivity, immune mediated histamine. अब की बार immune mediated type 2. Next question, which of the following is microcytic hypochromic anemia? Microcytic hypochromic anemia, most common cause iron deficiency anemia followed by thalassemia minor. So answer iron deficiency anemia. इसमें तो कुछ बताने की भी ज़रूरत नहीं है. Next, I guess this question was slightly tricky and ये वाला question इसी पेपर में 2 बार पूछा गया था. In papillary carcinoma thyroid, previous paper had asked papillary carcinoma thyroid, orphan annii nucleus and semoma bodies. वो तो तुम्हें पता ही है. Now the question was true is all except. बच्चे, calcitonin is a tumor marker of medullary carcinoma thyroid. This was a separate question also in this time FMG. So same चीज़ 2 बार पूछी गई. It is associated with risk of radiation. It is most common, good prognosis. Most common cancers usually have the good prognosis. It is seen in young individuals. Calcitonin tumor marker नहीं है. Calcitonin is a tumor marker of medullary carcinoma thyroid. Everybody, please give me a thumbs up or like the video or write it in comments if all of you are comfortable with all the questions till now. This is what we have covered. Primary effusion lymphoma, neoplasia, it is associated with HHV8. HHV8 is associated with 3 diseases, that is Kaposi sarcoma, primary effusion lymphoma and Castleman disease. That is HHV8. Which is the most common for the juniors? Which is the most common malignancy with HIV? NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. So Kaposi sarcoma is with 2 viruses, HIV and HHV8. Next, अब ये tricky question था. Patient of celiac disease, food item that he can eat. You know that he cannot eat vrob, wheat, rye, oats, barley. He cannot eat wheat, rye, oats and barley. अब उसमें I think semolina कहीं पे लिखा हुआ था या something, I don't even know. I mean, I am a guy, I don't even know what the semolina means. मुझे नहीं पता. मुझे ये पता है कि he can eat rice and maize. Plain and simple. He cannot eat. Some people remember it as bro also. I remember it as vrob. पंजाबी है ना, so wheat खाते हैं, परांठा खाते हैं. He cannot eat wheat, rye, oats, barley. Next question. A young male with history of flank pain, fatigue, urine is of red color with hematuria. there is presence of hematuria with dysmorphic RBCs. That means it is a case of nephritic syndrome. It is a case of nephritic syndrome in a young individual. Diagnosis PSGN. PSGN के ऊपर फिर से दो क्वेश्चन थे. This was one question. The second question was PSGN occurs after group A beta hemolytic streptococcal infection. It occurs after group A beta hemolytic streptococcal infection. These were the two questions on PSGN. Next, trinucleotide in Huntington's. I need not even say this. It is a trinucleotide repeat disease. Hunter keeps the animal in cage. CAG. So, Huntington's CAG versus Fragile X syndrome. Fragile X CGG. Next, firstly, SWAMI, बच्चे anemia platelet count was 5 lakh. So there is thrombocytosis is due to severe anemia. Those you need to tell me the question. You need to tell me the question slightly. Aditya, those I am totally okay. Even if red color urine की जगह, even if smoky urine, अगर smoky भी लिखा है और even cola colored urine, it is all okay. All okay because all it is signifying is the presence of hematuria. That is PSG. दोस्त कोई फ़र्क ही नहीं पड़ता, बिल्कुल फ़र्क नहीं पड़ता. स्मोकी का मतलब मुझे मतलब भी नहीं पता है. स्मोकी यूरिन, कोला कलर्ड यूरिन, सब एक ही चीज़ है. हेमाट्यूरिया और है ना 20 RBCs. वी हैव टू गो फ्रॉम पॉइंट A टू पॉइंट B straight. Next. Ikra bache, probably you are talking of a micro question. Ali, do tell me the exact question. Next, hepatocellular carcinoma. सबको पता है किससे होता है? Aspergillus, that is aflatoxins. Last time उन्होंने asbestosis का पूछा था. Asbestosis is associated with two malignancies, that is adenocarcinoma lung and mesothelioma. It is most specifically associated with mesothelioma. Most common adenocarcinoma lung, most specific mesothelioma. Aflatoxins, HCC. Aditya, perfect. Huntington's was in a different way. अच्छा, anonymous, क्या question था तो मुझे बता दो दोस्त. Huntington's का अगर trinucleotide नहीं पूछा, so tell me the question. We'll take care of it. Next. Dive. The minute an adult with recurrent gross hematuria पूछा गया है, then the answer will be IgA nephropathy. The words recurrent gross hematuria has to be there to make it as, or mesangial deposits to make it as IgA nephropathy. Next, calcitonin is a tumor marker. Same, ये question दो बार आया. PCT, which is not true, and this thing, that is calcitonin tumor marker, medullary carcinoma. Next, irreversible cell injury. The first change was asked, that is the presence of amorphous densities, amorphous flocculent densities in mitochondria. Acha, fair enough. Huntington's, the abnormal, the name Huntington's was not given. You mean ki they gave you a history of an adult who is suffering from recurrent abnormal movements. So me nahi dost, Aditya is right. The examiner, instead of writing Huntington's, gave you the clinical history of Huntington's. Acha, ek aur question tha, achondroplasia maybe. They had not given the name of the disease. They gave you a clinical history of the same and asked you the inheritance, autosomal dominant. They had given you a short stature with humped back. That is achondroplasia. So me था दोस्त, question था. देखो अगर काफ़ी लोग बोल रहे हैं तो question था. Huntington's chorea में ना, they did not write the name of the disease. Let me go back. What they gave you was adult presenting to OPD with repeated abnormal movements, which is the trinucleotide, that is CAG. Perfect, agreed. नेक्स्ट, तो वैसे भी जैसे ही ट्राईन्यूक्लियोटाइड वाला ऑप्शन दिया है तो हम दो ही मेन सोचेंगे ना. फ्रेजाइल एक्स, उसमें मेंटल रिटार्डेशन लिखना था. हंटिंगटन्स कोरिया आर एबनॉर्मल इनवॉलंटरी जर्की मूवमेंट्स. नेक्स्ट देयर वाज अ केस बेस्ड. परफेक्ट, SR परफेक्ट दोस्त. एंड आई सिंसियरली होप, मुझे ना एक बार लिख के बता दो पैथ कैसा था. वी आर ऑलमोस्ट ऑन अवर लास्ट स्लाइड. Non-caseating granulomas with bilateral hilar lymphadenopathy. ये तो मैं, I always stress this is sarcoidosis. So sarcoidosis पे दो क्वेश्चन आ गए. Asteroid bodies, non-caseating granulomas. Next, seriously, thanks for the kind words, friends. No doubt about it. Ikra, okay, amorphous नहीं था, hydropic change, nuclear condensation. So, irreversible injury is associated with nuclear condensation. That is pycnosis, karyorrhexis, karyolysis. It is hydropic change. The option that is hydropic change is reversible cell injury. Perfect, Ujita. Perfect, perfect. So, path was scoring. 18 questions ये लिखे हुए थे. 19th, dry eyes, dry mouth, Sjogren syndrome. That is why I said that pathology is going to be your savior, irrespective of बाकी subjects में जो मर्जी हो रहा है. चाहे कभी पेपर 1 टफ आ रहा है, पेपर 2 टफ आ रहा है, मुझे पता है. हाँ, विजनस ग्रेनुलोमाटोसिस देयर वाज आल्सो अ क्वेश्चन, आई एग्री. सो व्हेन यू गाइस टेल मी कि सर पैथ से क्वेश्चन कम थे, what you actually meant was कि सर questions ऐसे थे कि हम लोगों ने निकाल लिए. And take my word for it, we are in this together. Take a deep breath. Everything is going to turn out better than you expect. Guys, bestest of luck from bottom of my heart. No doubt about it. All of you are going to pass. Firstly, for the juniors, बच्चे, this is a huge learning lesson. कभी पेपर 1 टफ होता है, कभी पेपर 2 टफ होता है, एंड इफ द लक इज गुड, अगर हम लोग सब अच्छे से अच्छे काम करेंगे, यू विल गिव चॉकलेट्स टू फैकल्टीज एंड स्टफ, एवरीथिंग विल बी नाइस. बट कीप ऑन स्टडिंग, everything is gonna be all right for the juniors. Yes, questions were lengthy. 4-5 line के questions थे, clinically integrated, optha, ENT, medicine, agreed. कुछ नहीं दोस्त, अभी repeat करने का नहीं सोचना है. What you have to consider right now is कि हम इस पेपर में अच्छे से पास हो जाएं. इसलिए मैंने सोचा, इसलिए I am saying कि things are going to turn better than you expect. इस टाइम तुम्हें लग रहा है, sometimes on the basis of recall also कि मेरा काफ़ी सारा गलत हो गया, but let us actually keep our fingers crossed. Let us cross 150 and let's not even think of a repeat. एक बार रिजल्ट आ जाए, 100%, एक बार रिजल्ट आ जाए, we are going to be in touch. And for the juniors, seniors, I will actually like that you guys write something in the comment or in the chat for the juniors as a carry home, take home message. What I felt was you cannot miss out on a subject. You need to do the subjects in slightly more detail than what is normally taught in others like in LN. We always do it in more detail. You have to cover the subject extensively. Path to apni life set hai. So on this positive note, I'll be wrapping up the session and I'll be handing over this to Anupma ma'am for physio. Thank you guys. Thank you and take care. Seriously, take care.
Hello everyone, and how was your exam? I'm Dr. Anupama Chaudhary Devgan, your physiology faculty at Allen Next. And we are going to discuss the physiology questions, relatively simple questions, very, very doable, and we will go through all the options and all the answers. Now, firstly, let me see. Okay, how was the exam? That is important. So let's have a feedback from you. And meanwhile, I'll start with the first question. Now, this is a relatively simple question. So many times we have been talking about it in the PYQs, in the lectures, and that is action of thyroid hormone is mediated by which receptors? Now, firstly, remember, thyroid is one of the lipid-soluble hormones. Lipid-soluble hormones are the steroids and thyroid. And lipid-soluble hormones have either cytoplasmic or nuclear receptors. And which are the ones which have got nuclear receptors? The way to remember this, like I normally tell you, remember date. Easy to remember. So vitamin D, vitamin A, thyroid, and estrogen. These are nuclear receptors. And sometimes I'm asked this question that T could also be testosterone. And then I tell you that please remember date with a hypothyroid woman. So maybe that is a way to remember what are the ones with nuclear receptors. All the lipid-soluble hormones, all the other lipid-soluble hormones have cytoplasmic receptors. And when I talk about the other lipid-soluble hormones which have got cytoplasmic receptors, that would mean glucocorticoids, aldosterone, testosterone, and progesterone. So these are your nuclear and cytoplasmic receptors. Simple question, has been discussed a number of times, and hopefully all of you got this right. Let's go on to the next one. Two medical students are planning a trip to high altitude, to some place in high altitude. I could think of Leh Ladakh. They want to study the effects of acclimatization in high altitude. Which one of the following changes will not be seen? Will not be seen in high altitude during the process of acclimatization. Will there be an RBC increase in RBC count? Yes. So what happens is, in high altitude, there is what is known as hypoxic hypoxia because of the decrease in the atmospheric pressure. The partial pressure of oxygen reduces. There is a decrease in the partial pressure of oxygen which results in a hypoxic hypoxia. Now, whenever there is a decrease in the partial pressure of oxygen, it is a very potent stimulus for the secretion of erythropoietin from the kidney, mainly from the kidney. And what is the role of erythropoietin? Erythropoietin increases the red cell mass. Erythropoietin acts on the committed stem cell stage and it decreases what is known as apoptosis. If it reduces the apoptosis, what is apoptosis? Programmed cell death. It reduces or suppresses the apoptosis. So committed stem cells produce more and more RBCs. So it increases the red cell mass. And remember, what is a very important stimulus for the secretion of erythropoietin? Decrease in PO2. So there will be an increase in RBC count. Second option is there going to be increase in capillary density, which is also true. Because there is less PO2, because there's a fall in PO2, this stimulates angiogenesis. That means formation of new capillaries. So it increases the capillary density. What is the advantage? Advantage means a better blood flow to the tissues, so that tissues can utilize more oxygen, or tissues can get more oxygen. Is there going to be increase in myoglobin? Which is also true. What is myoglobin? Myoglobin is a pigment present in muscles. It is a storehouse of oxygen. In conditions where there is less oxygen, I will increase myoglobin in the muscles so that I have more oxygen stored in the muscles. Is there going to be a hypoventilation? Absolutely not. In fact, what is going to happen in high altitude is a hyperventilation. Whenever there is a decrease in PO2, it will stimulate the peripheral chemoreceptors. Which are the peripheral chemoreceptors? The carotid and the aortic bodies, and these will increase the rate as well as the depth of ventilation, and this results in an increase in the total or pulmonary ventilation and increase in the alveolar ventilation. And whenever there is increase in the rate and depth of ventilation, we call it hyperventilation. So what you're going to see in high altitude is a hyperventilation, right? So the answer to this question is going to be D. Let's look at the next question. Now there are two versions of this question. I will tackle both. One recall says that glucose is mainly transported by GLUT2 in which of the following sites? Now, GLUT2 will be present in the small intestine, in the kidney, in the liver. So it's present in all the three areas. So then how do I choose which is the correct answer? Now, in the small intestine and the kidney, the GLUT2 is present on the basolateral membrane. So let's try and understand what is the basolateral membrane. So if this is the PCT, as well as the intestinal epithelial cells have a brush border, microvilli, present towards the lumen. The glucose transporter on the luminal side in the PCT is mainly SGLT2, sodium glucose linked transport 2. Sodium glucose linked transport 2, which is an example of secondary active co-transport. And on the basal side, the glucose will leave the cell via GLUT2. 90% of glucose is absorbed in the PCT in this fashion. Secondary active co-transport on the luminal side, and once the glucose reaches the cell, it leaves the basal side via GLUT2. In the case of the intestine, similar mechanism for absorption. So you have the SGLT1 on the luminal side, again a secondary active co-transport, and on the basal side you have GLUT2. But what about the hepatocytes? As far as the hepatocytes are concerned, they have only GLUT2. There is no SGLT there, they have GLUT2. Glucose will enter from the blood into the hepatocytes via GLUT2. So the best answer in this case is the liver. Liver has only GLUT2, whereas in the case of the PCT and the small intestine or the enterocyte, on the luminal side, there is the sodium glucose linked transport. Now, there is another version of this question. It says, which of the following glucose transporter is present on the basolateral membrane of the intestinal epithelial cell? In that case, it's a very simple, straightforward. The answer is GLUT2. So there are two versions of this question. I'm not sure which is the one which has been asked, because two sets of people have given these two different questions. If it says, which is the glucose transporter present, then your answer is SG on the basolateral membrane, or also sometimes called the contraluminal membrane. That means opposite to the luminal membrane, and that will be GLUT2. If one of you could tell me which was the version of the question, the first one or this one, then probably we will be in a better place. All right. Let's see. In the adjacent graph, phase 1b represents which one of the following properties of smooth muscle of the urinary bladder? Now, this is a cystometrogram, which we do in all our classes. All right. So, cystometrogram. Okay, so Vivek has given me a answer saying it is the second. It is this question which was asked. So this is a straightforward question. Basolateral membrane, GLUT2. I hope you got it right, Vivek. All right. So let us look at the cystometrogram, and you've got the intravesical volume on the x-axis and the intravesical pressure on the y-axis. And we find that initially, as the bladder fills up, there is an increase in the intravesical pressure. Then in phase 1b, what is happening is there is an increase in the intravesical volume, but no or relatively less increase in the, or almost no increase in the intravesical pressure. This is because as the bladder is getting filled up, it tends to distend. Now, which is the property of the smooth muscle which is reflected in phase 1b? This is plasticity. Smooth muscle is a plastic structure, moldable structure. You know, it's something like plasticine. So that is what is it's a plastic structure. As it is getting as the urinary bladder is getting filled up with urine, it tends to, the smooth muscle of the urinary bladder, the detrusor, tends to relax. So that is what is known as plasticity. And in phase 1b, which is the law which is applicable, that is called the Laplace's law. So this is 1b is plasticity. Now what happens in phase 2 when the bladder volume reaches 400 ml, now there is a contraction of the detrusor muscle, and this is what is responsible for the evacuation of the bladder. So phase 2 will represent contractility. So this is your the answer to this question is plasticity. So Vivek says, why not elasticity? Now what is elasticity is? Elasticity is, for example, elastic will be like a rubber band. You stretch it, there is a tension which is generated, and then it will tend to recoil to its original size and shape. Like for instance, when we talk in terms of blood vessels, like the aorta, the large arteries, these are elastic vessels. In systole, they tend to expand, but during diastole, they tend to, because of the elastic recoil, they will squeeze the blood and push it forward. Now, the smooth muscle shows the property of plasticity rather than elasticity, right? So this was the answer will be plasticity. Okay. Remember this, the urinary bladder has plenty of smooth muscle, not elastic tissue, right? So the answer to this question is plasticity. Now, Dr. Ikra says, another question was nerve of pain conduction. This, if the question says nerve of pain conduction, which is it going to be? The options were A alpha, A beta, A delta, and C. Then my answer is C. Of course, then I can be asked this question that A delta is meant for fast pain, C is meant for slow pain. Please understand that A delta, even though it carries fast pain, what is the role of fast pain? Withdrawal reflex. You touch something hot, there is a sharp pain which you feel, which is carried by A delta fibers, which makes you withdraw your hand. So that is fast pain. But pain due to tissue injury, because your hand has got burnt, the pain is carried by C fibers. So the pain that you feel is because of the C fibers. So better answer will be C. If this was a question, Dr. Ikra, then your answer is C. Fantastic. A delta, Pavan, will be for fast pain. If the question said fast pain, then A delta. But if it says only pain, then my answer, better answer is C. Okay, let's see the next question. Serosa is not present in which of the following? Now this is actually more of an anatomy question, more of a histology question, but the answer is esophagus. Esophagus, right? Okay. All right. Identify the hormones A and B responsible for negative feedback on hypothalamus pituitary axis. Again, a question that we discuss very frequently. So let's try and see this. Now, remember LH and the receptors for LH are present on the Leydig cells, and Leydig cells are responsible for the secretion of testosterone. FSH receptors are present on Sertoli cells. FSH in FSH and Sertoli cells. And Sertoli cells will secrete inhibin. Inhibin has a negative feedback effect on the secretion of FSH. Testosterone has a negative feedback effect on the secretion of LH and GnRH. What about testosterone will in fact has a stimulatory effect on the Sertoli cells. So this is the regulation of the male sex hormones. So the answer here, if A is given on the right side, so this was inhibin and B is testosterone. So this is my answer, inhibin and testosterone, right? Remember, LH receptors on Leydig cells, FSH receptors on the Sertoli cells. Sertoli cells secrete inhibin and the Leydig cells will secrete testosterone. All right. Let's look at the next question. Again, something which has been covered in all the lectures. On IV injection of an irritant substance, there is bradycardia, there is hypotension and apnea. This represents which of the following reflexes? Now, this is the Bujold-Jarisch reflex, or also known as the coronary chemo reflex. That means, and what is this reflex? Whenever there are irritant substances such as serotonin, capsaicin, veratridine, phenyl biguanides, when these are injected, into the coronary arteries, okay, into the coronary arteries, or this will result in a hypotension, bradycardia and apnea. Here the receptors are present in the left ventricle, right? So this is what is known as the Bujold-Jarisch reflex. There is a bradycardia and a hypotension along with an apnea. Now, what is a Bainbridge reflex? Bainbridge reflex is whenever there is a sudden increase in blood volume. This causes an increase in heart rate, not a bradycardia, it increases heart rate. And which are the receptors which are responsible for the Bainbridge reflex are what are known as the atrial stretch receptors. And what is the Cushing's reflex? Cushing's reflex is seen whenever there is an increase in the intracranial pressure, which causes a, whenever, let's say, if there is a head injury or some sort of a intracerebral hemorrhage which has increased the intracranial pressure, it compresses the cerebral blood vessels, it causes a CNS ischemia, and there is an increase in sympathetic discharge, which causes an increase in blood pressure, but because of an intact baroreceptor mechanism, there is a bradycardia associated with it. This is called a reflex bradycardia. So there is an increase in blood pressure and a reflex bradycardia. It will also be associated with irregular respiration. This is also known as the Cushing's triad: increase in blood pressure, bradycardia and irregular respiration. This is what you see in the Cushing's reflex. So my answer is, if there is a bradycardia, hypotension and apnea, then my answer is the Bujold-Jarisch reflex. Okay. All right. So this is as far as the questions are concerned. Any clarification, any question from your side, anything that I can help you with? All right, so these are the ones which were recalled. There must be more questions on physiology as I gather, but generally must have been easy, and that is why probably there are not too many recalls that are available for me, available to me. So any questions from your side? Anything from your side? Vivek, Cortex user? Anything from your side? Somi Ali, anything that you would like to ask? If not, then I'd like to wind up, and with my best wishes, with my blessings, I just hope each one of you does well in the exam. My best wishes for you to attain all your dreams. Yes, Nadeem? Nadeem? Okay, so these were the hard ones. Yes, these were but the other ones, the others which have not been recalled, must have been relatively easy. Yes, thank you, Cortex, for all your interaction. Thank you, Vivek, Nadeem, thank you very much. Thank you. And if there are no questions, I would like to wind up and see you all soon. Okay, with the news of some great results. Yes, okay. Thank you very much. Thank you.
अब वापस अटक गया देखो एक सेकेंड Hello everyone, good afternoon. So welcome to the recall session of FMGE July 2023. Okay, so I am your pediatrics faculty at Analyse, Dr. Dipali Gupta. So let's get going. Pediatrics के सारे सवाल बहुत ही हलवा आए थे, straight from the textbook. I hope किसी को problem नहीं हुई. So let us discuss. जो भी recall में हमें मिल सके. A child has presented with a birth defect as shown in the image. What is the diagnosis? So coincidentally, this was the question which was discussed by me in the Allen videos. You can see this was it, this was described by me, this was discussed with me, and this was nothing but craniorachiasis, where you have a combination of anencephaly with the absence of meninges covering the spinal cord. So, आप देख सकते हो there was anencephaly as well as, just a minute. Yes, there was anencephaly and there was absence of meninges in this region, and this is known as craniorachiasis. In fact, you don't need to write anencephaly with it, it includes anencephaly in it, right? And the other options, they were very much obvious, they were not the correct options. The correct option was the option A, right? Okay, then let us come to the second question. So the second question was, So before that, this is a list of all the neural tube defects that has been discussed in our Next videos, and you can see that craniorachis was the first in this, and then usually used to have a question on anencephaly in all your FMG examinations, but this time they chose craniorachis as the part of this. Okay, and these are all the list. You can see encephalocele, there is herniation of the meninges along with the herniation of the brain. In encephaly, there is a extreme retroflexion of the neck along with the occipital skull and spine defects. And then meningocele, where there is herniation of the meninges, that is it. And then meningomyelocele, where there is herniation of not only meninges but also spinal cord along with it. While spina bifida occulta would involve a defect in the vertebral arches, the posterior usually seen in the level of L5 and S1, right. So these were the common neural tube defects which are usually asked, and what this was, this time they asked you about craniorachis. Okay, let us move on to the next question. What is the amount of milk given to a term baby in the first 24 hours after delivery? So this was also discussed in the fluid and electrolyte section in our Next videos. You can see, so this was discussed by me, and usually how do we go about giving the fluid, or for that matter breast milk. Remember, it was less than 1500 grams and more than 1500 grams, and usually what we consider over here is preterms. This is referring to preterms who are less than 32 weeks, yes, and here usually we consider preterms who are more than 32 weeks plus the term baby. So here what was asked from you was the more for a term baby was asked, and here what we give in preterms more than 32 weeks or more than 1500 grams or the term babies is 60 ml per kg is started on day 1 and then gradually increased, while in this case we could have started with 80 ml per kg, but here clearly it was given term baby and that also in the first 24 hours. So yes, the correct option, very good, Dr. Ujita Pillai is correct. The answer is C, that is 60 ml per kg was the answer, right. Okay, then so this is again the tabular form of how the fluid increases are done, but yes, you can see on day 1 60 ml per kg, and usually these are the children who are more than 1500 grams, or as we call them term neonates or preterms more than 32 weeks. That is how we go about giving them fluid or for that matter breast milk on day 1 of life. Okay, then next question was a total halwa question. Ye to sabko pata hai, we have discussed this umpteen number of times. A child with celiac disease can be given what? So we know this child is sensitive to gluten and cannot be given anything which contains gluten, and that is, we know the mnemonic BROW, right. So B stands for barley, R stands for rye, O stands for oats, and W stands for wheat, and for that matter any form of wheat. So what they gave this time was they gave suji. So suji is also, we know, it is derived from wheat. Again, your broken wheat or dalia is nothing but, broken wheat is nothing but dalia, that is what we call it. So that is also a form of wheat, and of course the whole grain wheat can also not be given. So here the only correct answer was the option B, that is rice. So rice was the answer, right. So this was the correct answer which can be given to children with celiac disease, right. Okay, so let us move forward. So these are all the gluten-free grains. We always emphasize giving you this slide that these are the ones which can be taken, and these are the ones which cannot be taken. And in this, oats is there, rice is there, and all form of wheat. It can be bulgur wheat, it can be durum wheat, it can be semolina, which is also known as suji, which was one of the options as told to us by the students who gave us the recall questions. Okay, so let us move forward. Next question was, a child presented in the pediatric OPD with fever for past 5 days along with cough, coryza, conjunctivitis. The mother also complained of a non-itchy rash that appeared just a day back, starting from behind the ears, involving the face and spreading to the trunk, and also involving palms and soles. what is the most likely diagnosis? So what recall we could collect was that there was some question like this, and it was a very long question, around 5 to 6 sentences, and it was suggestive of, you know, if the rash is, you know, starting from behind the ears or from the, let us say, periphery of the face or from the neck towards the face, we know that, and along with it we have cuff coryza conjunctivitis, we know that we are dealing with measles. So the most obvious answer to this question would be measles, right? Right, yes, the Dr. Ujeta is right, it is the option A, that is measles. What about dengue? Dengue we know is a biphasic illness. The child would have a rash, and then with fever the rash would be there, a generalized macular rash, and then there is a gap of 1 or 2 days, the afebrile phase comes, and then again the child has high grade fever. So that is a biphasic fever, and along with it there's a lot of prostration in form of, you know, pain in the bony areas, and that is why it is known as break bone fever. And usually the rash, apart from the macular rash, we also see petechial rash if the child has associated thrombocytopenia. So that was not clearly the case given in the question. What about rubella? You should know in rubella, you know, postnatal rubella, if we talk about postnatal rubella, usually it has rash as the prominent symptom. It is macular rash, and then it coalesces, and you know, it starts from the face and then moves to the centrifugally to the trunk and the proximal limbs, and then very importantly, you know, there it does not coalesce and it is associated with lymphadenopathy. So post-auricular lymphnopathy can be there. There can be, you know, suboccipital lymphnopathy, and anterior cervical lymph nodes are also enlarged. So that would be the characteristic presentation of rubella if they wanted to ask you about rubella. So the fourth option we could not gather. So the most likely option with this kind of scenario would be measles, right? Okay, then the next question was, a child presented to the clinic with complaints of recurrent infection. Physical examination showed height for age less than -2 standard deviation. What is the most appropriate term for this condition? So I was just seeing this question. So very clearly this was again a straightforward halwa question, you know, discussed so many times in our discussion of PEM. You know this, when the height for age is less than -2 standard deviation, we are talking about stunting. Had they given you something like weight for height less than -2 standard deviation, then the answer would have been wasting, right? And if they would have given weight for height less than -3 standard deviation, you know that is one of the feature of defining severe acute malnutrition. And of course with Kwashiorkor you need to have, you know, other features of Kwashiorkor also accompanying in the question should have been there, something like, you know, protuberant abdomen or you know, bipedal edema, apart from the lower anthropometric parameters, right? So again in this it was a straightforward question, height for age less than -2 standard deviation, this is stunting, and wasting, and rest of the parameters we have already discussed, right? Okay, yes, so the correct answer was A. Good, yeah, everybody is telling me stunting. Dr. Vivek, Dr. Wasim, very good, good going. So let us move forward. Again, one of the straightforward questions from your protein energy malnutrition. What is the mid-arm circumference for severe acute malnutrition? We have done umpteen number of times. There are 3 criteria, of which they asked you one of the criteria. I had told you, you know, in all the CBOT discussions and the mock test discussions, you have to, you know, remember the magical figure of 11.5 centimeters. So that was a straightforward question. And apart from this, you know, there are 2 other parameters. The second parameter would be presence of bipedal edema, right? And the third parameter would be something like weight for height less than -3 standard deviations. We know these 3 parameters are the way we define severe acute malnutrition, and they had asked you about one other parameter, right? So yes, 11.5 centimeters is the correct answer. Okay, good going, everyone is answering me correctly. Okay, then a neonate presents with post-feed vomiting and hypoglycemia in the first week of life. Urine was positive for reducing substances, but there was no glucose, and urine also gave positive reaction with Benedict's reagent. So what are they trying to convey to you? That there is a reducing sugar, but it is a non-glucose reducing sugar. That is very much obvious. The neonate also had reversible oil drop cataract. That's what I could gather, although I found it very strange for the neonate to develop this cataract. So there was something something amiss in the question. If you can correct me, I would be very happy to listen to the original version of the question, but gathering the information which we could have got, what we could infer was that what was this referring to. So which of the following is the most likely diagnosis? Is it classical galactosemia? Is it essential fructosuria? Is it galactokinase deficiency? Or is it uridine diphosphate galactose 4 epimerase deficiency? Please correct me if I am wrong at any of the options given, because you people had attempted the questions, so you know it better, and whatever we could get from the recall activity, this was the final product which I am presenting in front of you. So anyways, let us coming back to the question. So we know galactosemia is a broad term and it encompasses 3 enzyme deficiencies. The first enzyme deficiency, which is the most common, is galactose 1-phosphate uridyl transferase deficiency, and that galactose 1-phosphate uridyl transferase deficiency is referred to as classic galactosemia. The second enzyme deficiency is the galactokinase deficiency, and the third enzyme deficiency is uridine diphosphate galactose 4 epimerase deficiency, right? So these are the 3 enzyme deficiencies which are which come under the umbrella term of galactosemia, but of course the most common enzyme deficiency is referred to as classical galactosemia, and it has a typical presentation which was there in your question, that usually the neonates, when they are started on breastfeed or for that matter any formula feed, they start having vomitings and they suffer from hypoglycemia, because the lactose of the milk is composed of glucose and galactose, and there is an enzyme deficiency which cannot metabolize galactose, and that is the culprit. The child lands up with hypoglycemia. Not only this, the child can have hepatomegaly, can go on to have jaundice and irritability, seizures because of hypoglycemia, failure to thrive, and may go on to develop problems of liver, kidney and brain. These are the 3 organ systems which are mainly affected, and most of it they are also prone to develop sepsis, and sepsis specifically because of E. coli, very very important, which you should have known by now. And if the galactose restriction is not done in the diet, then what happens is that these children go on to develop liver cirrhosis and developmental delay, and slowly the changes, they become irreversible. So initially they are reversible. So what they had written, that reversible oil drop cataract, yes, oil drop cataract is a feature of galactosemia, and it is very much reversible if the usual milk is substituted with lactose free formulas like casein hydrolysate and or soy formulas, soy milk formula if it is used. So that is why it was written reversible oil drop cataract. So that is all about. So the correct answer was classical galactosemia. What about essential fructosuria? We all should know that essential fructosuria is because of the fructokinase deficiency, because of which the levels of fructose are very high in blood, and of course there is no renal threshold for fructose, so it gets fully filtered in the kidney. It could fully and it comes in the urine and it is excreted out into the urine and does not cause any problems. For that matter, remember, fructosuria, diagnosis of essential fructosuria is accidental when you get to measure, when you detect reducing substances in the urine which are non-glucose reducing substances, and then it is shown on the chromatography that is actually fructose. It does not cause any problem, and prognosis is excellent and no treatment is required. So that is essential fructosuria for you, and it will never present in such a way as the case scenario was given in the question. What about the galactokinase deficiency, the second enzyme deficiency of the galactosemia? Remember, it is essentially asymptomatic. Only and only the classical presentation is with the cataract. It presents with cataract. Pre-senile cataracts are common. Why? Because there is accumulation of galactitol. So accumulation of galactitol would tell you is the main culprit over here, which causes the cataract formation in the in these children, and that is the sole manifestation. No other features are seen, no other clinical features are seen, as we saw in the given question. Moreover, in this case, you know, there is a single line written that pseudotumor cerebri may be rarely found. So that is other feature that would be seen, although you must remember that pseudotumor cerebri again is a feature very commonly seen in the classical galactosemia, that is due to galactose 1-phosphate uridyl transferase deficiency, right. Coming to the third enzyme deficiency, that is the uridine diphosphate galactose 4 epimerase deficiency, that is the third enzyme that comes under the umbrella term of galactosemia. So in this case, again there are two varieties. There is a milder variety which is again more or less asymptomatic, and there is a severe variety. Now severe variety of this enzyme deficiency has a presentation exactly similar to what was mentioned in your question. So tell me, then could D be the answer? ये तो कहानी ही बदल गई, you know. D could be the answer because it has the presentation exactly similar to what was given in your question, but a big but, it has associated nerve deafness and hypotonia. Remember that. So if the same scenario comes, you know, next time when you people, you know, you must have passed your FMG and you are preparing for your NEET PG now, you know, maybe not today, maybe not tomorrow, maybe in another 1 week or so you will start preparation for your NEET PG after the results of your FMG comes, and I'm sure everybody of you will get through. So in that case, when you prepare for your NEET PG, always keep in mind the same classical scenario of galactosemia but associated nerve deafness or hypotonia. If mentioned in the question, your diagnosis changes. It is not the usual galactose 1-phosphate uridyl transferase deficiency, that is the classical galactosemia, but the diagnosis becomes uridine diphosphate galactose 4 epimerase deficiency, right. So again, this time you were correct. The answer is A only and not D. So always keep that in mind, right. Okay, then the next question was, a child presented to the clinic with complaints of malnutrition and severe dehydration. What would be the choice of IV fluid for this patient? So this question was discussed umpteen number of times. You know, I had put it in my CBOT also. Twice it came in your mock test, FMG mock test, which was organized by Ellen Next, and I had put that you know, twice over then. You know, in the repeated mock test I had put this question. I had some intuition that this question will definitely come, and this question was here from your previous year question. So this has repeated again this time. So let us see what was the question all about. So what were the options? ORS, NS, RL or DNS. In fact, somebody said that RL in 5%. The original question had RL in 5% dextrose, but this time they had, you know, omitted. Okay, so Dr. Ojita is saying that in this case the child had acute gastroenteritis. Okay, but was severe malnutrition there? Because if there's severe malnutrition, you know, then severe acute malnutrition, then definitely the answer would be similar. So if the child had gastroenteritis, definitely the child, that would lead to severe dehydration if that was the scenario, and along with it malnutrition, then definitely remember, we do not resuscitate the child. If we are talking about the IV fluid, then we never resuscitate the child with ORS. So ORS would never be used as IV fluid, and among the IV fluids for resuscitation, again DNS is never used for resuscitation. So we are left with either NS or ringer lactate, and it was very clearly explained to you that in children with severe acute malnutrition was there. So in severe RL in 5% dextrose for severe dehydration in SAM children na. Yes. So that is what is used. So only gastroenteritis and severe dehydration was there. So what we recall what was given to us was that there was definitely severe malnutrition also in that case, and if that was there, then ringer lactate would be a better choice. Because if we go by your question that only gastroenteritis and severe dehydration was there, then either ringer lactate or NS can be used for resuscitation. Remember, there cannot be a choice between ringer lactate and normal saline. But of course, if you are dealing with a child who is a case of severe acute malnutrition, in that case, remember, we cannot give NS. Why we cannot give NS? Because we know that in children with SAM, the total body sodium is high, number one. And number two, the potassium is on the lower side. So we need to give a fluid which has comparatively lower sodium and has potassium in it. And that for that, ringer lactate is an ideal fluid, because we know in NS the 154 milliequivalent per liter would be there of sodium, and chloride also would be 154 54 milliequivalent per liter, right. So, that is what is in NS, that is the composition of NS, while in RL we would find this as something like 130, that is sodium is decreased and chloride is 110, and it also has additional potassium which is missing over here. So, potassium would also be there. Okay, so answer में malnutrition was not present, answer में RL 1000 ml था. So, अगर 10 kgs का बच्चा है and they are asking you about severe dehydration, then of course the calculation would be 100 ml per kg, and then RL 1000 ml would be the correct answer. Sorry if we got the recall wrong, but if we go by your what is, yes, what is being given over here is NS something ml in 6 hours was option in it, and RL is the okay. Okay, so what I am getting from the recall is that this child was a child of 10 kgs, let us say, and had severe dehydration, okay, because of acute gastroenteritis. Now, what is the fluid of choice? That is what, I am getting it from the, okay, so Dr. Nadeem is saying that was the question. Okay, so in this case, of course, with severe dehydration, you should know it is the plan C where you go for IV resuscitation, and the fluid to be given is at the rate of 100 ml per kg. Yes, so very true, 100 ml per kg fluid was required, and that is given in, in 3 hours has to be given, while in the smaller children it has to be given over prolonged period, that is over 6 hours. So, in 3 hours, let us say in 1.5 hours you will give 30 ml per kg, and then in the remaining 2.5 hours you will give 70 ml per kg. So, that is what okay. Chalo, anyways, we can still work upon the recall, and if at all we get a more better question, we will discuss that again, don't worry. Okay? So, if there was 10 kgs, 10 kgs severe dehydration, acute gastroenteritis, then 10 ml per kg के हिसाब से 1000 ml per kg of ringer lactate would be ideal, right. So, that should be the ideal question over there. Okay, let us move on to the next question. Enzyme deficient in homocystinuria, that was all I could collect. This was again a straightforward question. If there was anything else, you can correct me. Cystathionine beta synthase. Yes, so cystathionine beta synthase is the enzyme, which is deficient in homocystinuria. So, this was again a straightforward question. So, this was what was given to me in recall, right. Okay, then there was one question like this, simian crease was given, and it was asked what was the karyotype for this. So, we know this is straight away related to Down syndrome. So, for Down syndrome means trisomy 21. So, 47XY, this was what I could collect, that is because of trisomy 21. Anything anybody else would like to add? No such question was given. So, this was very much discussed with that. There was a question on Down syndrome, maybe the sets were different, and maybe you got a separate question. There was no such question in your set. That could have been the reason. So, that is why you people are not agreeing with it. Yes, so 47XY, it was there. So, Dr. Shoaib Ansari is saying it was there. So, maybe the sets were different, and that is why somebody is saying the language is different. So, please remember, since the sets are different, there are different sets of questions. You might be having this question in one of the sets. So, please don't think that it is not an accurate recall. Whatever we could recall from you people, we are discussing this, right. Yes, ma'am. Dr. Priyanka is also saying yes, ma'am, it was there. So, good going. I think this was a total halwa question, Down syndrome question. Straight away they gave you a simian palmar crease, a pic of simian palmar crease, and they asked you that what was the karyotyping for it. We know that this is a classic feature of Down syndrome. Other options which I could gather was maybe the Turner was given, then the trisomy 18, that is Edwards syndrome, and then trisomy 13. Image was different. Of course, Dr. Wasim, it is very difficult for me to retrieve the same image when I have not seen the question, but what I could get was that there was an image of simian crease, and that is what I have tried to put over here, just for your recall. Anything else? Same question, same options. Thank you, Dr. Tanuj. That was really very encouraging, Okay, so that is what we got. So, yeah, so recall is not bad. Everything is halwa, ma'am, but questions nahi hote exam mein. हो जाएंगे, कोई नहीं, आप पढ़ोगे तो बहुत अच्छे से हो जाएंगे क्वेश्चंस. ऑल द बेस्ट, सी यू ऑन द अदर साइड. आई एम श्योर यू ऑल विल पास विथ फ्लाइंग कलर्स. एटलीस्ट पीडियाट्रिक्स के क्वेश्चंस तो एक्चुअली हलवा आए थे और आप सबसे हो गए होंगे. ठीक है, विशिंग द वेरी बेस्ट ऑफ luck for your upcoming results and see you on the other side. Thank you, best of luck.
Hello dear friends. So this time the paper was a bit difficult, they are telling up the first paper was difficult, the students only, and the second paper was okay. And in that the microbiology, as I have already told up, that it will form the core of the questions like around 20 to 25 or 25 to 30, and the same is being done, that number of questions are a lot, but actually the recall obviously could not be able to be made in the proper sense. So I don't have all the options of all the questions, but yes, you are here, and hi to all. First of all, you are all here, and you can tell me up that this was there, that was not there. Okay, we can discuss upon according to the options also, and I have got a number of what do you say topics I should say, because the options are could not able to get in proper. Okay, so yeah, all of you are requested to tell up that what was the exact question and what was there in the options. I have those things which I got up from various students itself. So let's start up, guys. This was told by the students that this was there. Hi, am I audible to everybody? Hello friends, am I audible to everybody? Because nothing is coming in the comment section. Yes, please. So let's start up with the first question. The father with the traumatic ulcer in the eye and the septate hyphae seen, the causative organism is. So was this the question, or some other stuffs were there in the this particular question? Can you tell up in the comment section this particular thing? Yes, anybody? Yes, please. Anybody? Was this the question, or I should tell up from this itself that this was there? So guys, if this was there in the exam, then obviously the answer to this question is what? Aspergillus. Okay. We already have told up that the septate hyphae dichotomous branching, okay, that is what you tell acute angled 45 degree or 60 degree. This particular stuff is a feature of what? Aspergillus. It is having those septate hyphae, and obviously it happens because Aspergillus is ubiquitous everywhere it is. So if it is a traumatic ulcer in the, okay, now Pawan have written up B. Fine. So now we are coming up. Fine. So this particular one, B, yes, B is the answer, Pawan. And the traumatic ulcer in eye, because Aspergillus is ubiquitous everywhere it is. So this might have entered up into that traumatic ulcer of the eye. And because of that only, in fact, because of the trauma, if this particular fungus have entered up and it causes up this ulcer formation, basically this particular thing which you get on the tissue biopsy when you stain it up, septate hyphae dichotomous branching, is typical of what? Aspergillus, whereas mucor, it is having aseptate one, right angled or obtuse angled stuff. Okay, right angle or obtuse angled stuff. So this you need to know in this particular question, if it would have been in this framework with this particular one. Okay. So is it fine to everybody? Was it in this particular sense only, which I am telling up? Now another one, the pencil shaped macroconidia. From this particular FMG exam, one thing was very clear, that the questions were asked of the NEET PG standards, and because the board is same, they have the same collection of questions which they put up for the NEET PG, and this time a lot of questions are there which are there in the NEET PG. And I've already told up also that this particular thing will be done by them because the board is same, and some questions of the NEET PG recall definitely will be asked in the FMG exam also, and this time they have done that. So pencil shaped macroconidia, okay, pencil shaped macroconidia, that was there, and these are the images which I have given up just for the reference, and you know that is observed in what? Trichophyton. Okay, that particular thing is observed in what? Trichophyton, and you know that three dermatophytes are there: Trichophyton, Microsporum and Epidermophyton. The Trichophyton is having cylindrical as well as pencil shaped stuff. Okay, that is the macroconidia. We are talking about what? Macroconidia. And what about the microconidia? The microconidia are numerous in that. Okay, and regarding microsporum, we have spindle shaped stuff. Okay, spindle, this particular one, spindle shaped. And regarding the microconidia, they are less. Besides the epidermophyton, we have club shaped, this macroconidia or board shape, and there is no microconidia in that. Okay, there is no microconidia in that. So obviously the answer here is Trichophyton, and for the NEET PG stuff, I like to tell up that this was a repeat from the INICT. The Trichophyton rubrum was asked there, and along with that, what they have asked in the that INICT, the Trichophyton rubrum is producing which type of pigment? So it produces red color pigment and pencil shaped macroconidia. So it will be repeated again. So you should know regarding it that which one is having a pencil shape or cylindrical macroconidia. The answer is this Trichophyton. Okay, answer is this Trichophyton. Okay. Now this particular question was there: a patient with prosthetic valve implantation presented after 6 months with features of endocarditis. Okay, with features of endocarditis, what could be the cause of it? So as you already know that this particular stuff is divided up in this way, the early onset prosthetic valve endocarditis and late onset prosthetic valve endocarditis. Okay, if it is below 1 year, that is termed as early, and if it is beyond 1 year, that is termed as late onset prosthetic valve endocarditis. Okay. So guys, am I audible? Because in the chat I am not seeing up any of you responding anything. Okay, down you are there. Okay, that was not running. Okay. Okay, I was thinking that nobody is in the chat. The chat is coming down. Okay. So guys, what you have marked answer of this one? Staph aureus was not there in the option. Okay, Priyanka. Now I got to know. Otherwise, it was stuck up there itself. Fine. Okay. So a patient with prosthetic valve implantation, and if staph aureus is not in the option, the answer definitely would have been is what? Epidermidis, which is a cons. Okay, the epidermidis is what? Cons. Yeah. Fine. The answer is A, no doubt in that. Otherwise, if staph aureus would have been there, then the answer would have been what? Then the answer would have been staph aureus. Okay, remember this also for the future one. Okay. Now we have come to the another one, this particular prosthetic valve. So answer to this particular one is obviously epidermidis, that is there, which is a cons, coagulase negative staph, and any sort of intervention whenever it is there, this particular individual will does the prosthetic valve endocarditis. Okay. So answer to this question is A. If staph aureus is not there, if the staph aureus is one of the options, then the answer would go in the favor of what? Staph aureus. Is it fine? And more than 12 months, if somebody asks you, here only you remember that is Streptococcus viridans. If IV drug abuser is being asked, that is staph aureus again. Okay, IV drug abuser, staph aureus, native valve endocarditis, this is also staph aureus. And what about SABE, subacute bacterial endocarditis? So that is viridans. So all these in this particular way it will go. Tanuj, then it's fine. Then the answer is epidermidis, no doubt in that. Okay. Fine. Coming to the next one. Was this there? The type 2 lepra reaction. The type 2 lepra reaction is which type of hypersensitivity? Is it lepra reaction or lepromin? Yes. Dr. Modi, Dr. Priyanka, can you tell me up? Was it a lepra reaction type 2 or type 1? What was asked? Is it the lepromin test it was asked or what was asked? Okay, bacitracin resistant one was a question. So bacitracin resistant, if that would have been a question. So bacitracin resistant is observed in GBS. And what is GBS? Group B strepto. That is Streptococcus egalectia. And I suppose this was the question which the students were telling regarding neonatal meningitis. Okay. Is it that way the question? Neonatal meningitis? Achha, lepromin test was asked, not the lepra reaction. Lepromin test was asked, and the lepromin test, you know guys, is type 4 hypersensitivity. Like tuberculin, achha, Aditya is telling type 1 was asked. So, okay Tanuj, then the question is done. That is Streptococcus egalectia. It is found to be bacitracin resistant, and this is a causal, most common agent of neonatal meningitis worldwide. Okay. So if it is type 1 also, that is also type 4, and if it is regarding lepromin test also, that is also type 4. That is delayed type of hypersensitivity. And you already know that lepromin is of two types, early and late. Early is Fernandez, late is Mitsuda. Okay. One you read in 3 and one you read in 3 weeks. 3 days, and one is very right, Amol. So it's done. It's a good question then. It's like see this correlation. You can put this into pedia, but this particular thing is making it obviously a microbiology question. Okay, bacillus resistant is used. This particular testing is used to find out the group B strepto. Okay, because bacillus sensitive is which one? Streptococcus pyogenes. That is group A. Okay. That I have, Pavan. That hemolytic one, na? That I have. You can tell there. So lepromin test is sorted. Lepromin test is a type of what? It's a prognostic test, not a diagnostic test. Okay, and it will be coming negative in what? Lepromatous type of leprosy for sure. Okay, it will be coming negative in the lepromatous type of leprosy. Okay. Now, somebody was telling that penicillin induced hypersensitivity or hemolytic anemia, or what sort of question is there? Can you tell me regarding this? That there was a question regarding hypersensitivity induced by penicillin. What sort of question it was? Yes, anybody? Dr. Modi, Dr. Priyanka, any sort of question which you think was there of that sort? Was it like hemolytic stuff, drug-induced hemolytic anemia, or what? What was asked? Yes. Penicillin-induced hemolytic anemia. So guys, you already know that in the type 2, it's all about the autoimmune hemolytic anemias. Okay, in type 2, it's all about what? Autoimmune hemolytic anemias. And autoimmune hemolytic anemias, they are type 2, you already know that. All blood transfusion reactions, all sorts of these particular ones, they are the part of what? Type 2 hypersensitivity. Along with that, if you have seen my lecture of hypersensitivity, I have told up there was a mnemonic like date palm, the drug-induced hemolytic anemia. The penicillin is the drug, and that particular one obviously is which type of hypersensitivity? Type 2, which is which one? Cytotoxic one. Okay, so you know you have done it wonderfully. Yes, it's type 2 hypersensitivity, right? And other than that, we have that B blood group is mine. So according to that also you can take up the various particular things which are there in the type 2. Type 1 is all about the hypersensitivities which are like anaphylaxis, atopy, okay, bronchial asthma, Skulls-Dale's phenomena, okay. So PK reactions, Theobald-Smith phenomena, they are all type 1. Type 2, this particular one you already know, okay. So this was asked. So and one more thing I like to tell you regarding penicillin. Penicillin can cause any sort of hypersensitivity, okay. It can cause type 1, it can cause type 2, even it can cause type 3, and even it can cause type 4. So this is the drug which can induce up any sort of hypersensitivity. But here it was asked regarding hemolytic stuff. So obviously the answer is towards the type 2, okay. So no problem in that. Some other question was also there regarding the hypersensitivity. Can you tell me up, guys? Some other question was also there regarding the hypersensitivity. Acha, the question about the lepra test, there was a theory given, the patients having a nerve involvement, okay, 4+ bacillary index, and lepra test was asked. Okay. See the difference now, what have come, what is being interpreted, and what have been told in the recall is totally different one. I know that what is being recalled and what is being told here, a number of things are lot different. Achha, only 2 questions were there from the hypersensitivity. Okay. Now tell me about this particular one, guys. Was there a question regarding it that there is a case of diarrhea after eating up the seafoods, oysters? Okay, and was this also written, Kanagawa phenomena? A child having peanut allergy. The peanut allergy is obviously that particular one, type 1 hypersensitivity. The questions were good. That suggests this way. Your languages are telling up that way. So this question was there. And have they mentioned of this Kanagawa phenomena? This I want to ask. Dr. Priyanka, can you tell me up that Kanagawa phenomena was asked up in this? They have written this Kanagawa. This question was there, it's fine. But have they mentioned of this Kanagawa? Okay, somebody's told yes. So guys, if you see up the lecture of mine, in that I've told of this. And the students used to tell me, sir, you tell everything. Like, will it come in FMG exam? Now it have come. So one thing is for sure, that you can't leave anything for there. Okay, like NEET, PG and FMG, I teach up in the same way. Okay, and in the future also when the next is coming off, that will remain same. And I suppose any sort of discrimination that this topic will come or this topic will not come, that is not correct. Okay. So Kanagawa phenomena, if you remember up, it is observed on Vegetsuma agar, and this Vegetsuma agar is a high salt content agar, and it is shown by this Vibrio parahemolyticus. Vibrio parahemolyticus is a 7% halophilic organism. Okay, and in fact for this in the class we have made a mnemonic that Kanagawa is Ganagawa. गाना गाया कहाँ गाया वाघा बॉर्डर पे तो वागत्सुमा गा the next question might be what that on which media you use it that is a high salt content agar Vagatsuма agar in that this particular fellow shows what Kanagawa phenomena. Is it fine guys? Very good. Can you tell me how much percent it is? 7% halophilic, and we have made this also like next time the question might come in this fashion that this is a bipolar stained organism. Okay, this is a bipolar stained organism. It is capsulated and it is found to be 7% halophilic, and it shows this particular phenomena Kanagawa on the Vegutsuma agar, and obviously they will give up this seafood poisoning stuff also. Okay, so answer is yes, answer is B, Vibrio parahemolyticus. And can you tell me in the comment section some other halophilic vibrios which you know, some other halophilic vibrios which you know, that what are the other ones? Some other halophilic vibrios. Yeah, anybody? Some other ones? Vibrio vulnificus, Vibrio alginolyticus, that sort of thing, they all are the features of halophilic vibrios. Okay. Future question I told up, okay. The future question I also told up that in this way the question can be asked in future. And when I tell na, most of the times it comes. The diarrhea, falling leaf-like motility. If somebody is having a diarrhea, okay, this particular diarrhea, it can be a, what do you say, traveler's diarrhea, because traveler's diarrhea cause, this might be the future question. Giardia lamblia is a cause of traveler's diarrhea, and you have done the hanging drop, and in the hanging drop you find a falling leaf-like motility. Okay, this I have already discussed up. Giardia giradia, so that is falling leaf-like motility. How many pairs of flagella? 4 pairs of flagella are there in this, and it is having a tennis racket appearance. Okay, tennis racket appearance, that is there in this particular one, and in between you have this exostyle, and it is having 2 nuclei. It is having 2 nuclei like this, and it is also termed as spear-shaped, teardrop or tennis racket stuff. So all of them, they are the features of what? Giardia lamblia. They are the features of what? Giardia lamblia. Okay. Listeria, last time they have asked up, and the recent ANAESTHESIA also they asked up. Listeria shows tumbling motility, and along with that the question which might come in the future is, it shows differential motility based on temperature. So that also you need to remember. Trichomonas, it shows twitching motility, that is characteristic of this Trichomonas vaginalis, and this is a protozoa which does not have a cystic stage. Ballontidium coli. Ballontidium coli is the largest intestinal protozoa which leads to diarrhea, and it is having a rotatory type of motility. So these particular ones you also should know. Okay. Okay. What was this question? I have mentioned up in the next pages regarding wheel phalanx one. like what they really want to ask up in that rickettsia typhi, rickettsia provozaki, they both have OX19 and OX2 both positive. They mentioned motility. They mentioned motility in that question. Okay. So Pavan, can you tell me up what was written regarding Weil-Felix test? This particular Weil-Felix test, what was written? OX19 it was written, OX2 was written, both are positive. What sort of question it was? Because actually you can't differentiate between epidemic and endemic typhus based on the Weil-Felix test. What they want to ask this thing in this? Because Weil-Felix test, which is the heterophile agglutination, you can't differentiate between epidemic and endemic typhus based on this Weil-Felix one. Yes, Pavan, can you tell me up? In this Weil-Felix test, was these antigens titers was also being mentioned up, OX19 and 2. What they actually want to ask up in the options? Yes. Can you tell up, please? Because you have recalled this, that Weil-Felix, somebody have told them, they given both are positive. Okay, OX19 and OX2. So for this now, actually we do a reaction, Pavan, that is termed as Neal-Moser's reaction. Okay, we put up a picture of Giemsa stain and cycles were there, masses, neutrophil, multinucleated. Or was it having a clue cells? They asked rickettsial species. What sort of rickettsial species? Just the Weil-Felix, no titers. Okay. So let me tell you this, epidemic typhus, endemic typhus, you can't differentiate on the basis of Weil-Felix, and that's why we do a Neal-Moser's reaction, which is coming positive in endemic typhus. Okay, that comes positive in endemic typhus. So we can research on this question, you can tell up. Okay. Now this, I suppose you already mentioned up neonatal meningitis, and along with that they have like told up regarding the bezitracin resistant stuff. Okay, so this was mentioned up, bezitracin resistant along with neonatal meningitis, and answer is obviously what? Streptococcus ehrlichia. Okay, Streptococcus ehrlichia. मोदी जी बोल रहे टाइटस थे. So this is like we already have discussed of this one. Now guys, tell me this, was it there, the post-streptococcal glomerulonephritis and rheumatic heart disease, was this being asked? Because this is my favorite topic also. I used to tell up that one question will definitely come, that non-suppurative complications of streptococcus pyogenes. One is rheumatic heart disease and one is glomerulonephritis, acute glomerulonephritis. Was it there? And obviously they are the non-suppurative complications of it. And you have a history of sore throat in the case of rheumatic heart disease, and in the case of acute glomerulonephritis, there is a history of any skin infections, purulent skin infections. Yes, please. Yeah, Aditya, it was there? Like directly they have asked up, or like in what sort it have come in the exam? Okay, Navya is also telling up, Aditya is also telling up, this was there. So these are the non-suppurative complications. As you know, we already discussed of them, that in one there is a history of sore throat in which the immune response is marked and the complement levels remains normal in the case of rheumatic heart disease, and you need a lifelong prophylaxis as per the valval involvement and all of penicillin in the case of rheumatic heart disease, where in the post-streptococcal stuff they are having a very good prognosis. So that is having what do you say, spontaneous resolution, spontaneous remission is there, and you look out for anti-DNase B titers in this particular one, and this particular rheumatic heart disease you look out for ASO titers, more than 200 Todd units. And the concept here is regarding the molecular mimicry. Because of the molecular mimicry, the various organs are being damaged off. Okay, yeah, RF with carditis symptoms was asked. Now, a neat PG recall, the Vibrio cholerae binds to which particular receptor? Okay, And recently I concluded a class also. In that we have made a mnemonic also for this, GM1. Ganglioside receptor 1, GM1. So this GM1 ganglioside receptors, like how to remember this? Remember, Vibrio cholerae happens to the general manager, who is the number 1 post in the company. So remember like that, GM1 ganglioside receptor, that is being to this it binds up, and after that there is a ADP ribosylation of G stimulatory protein. Guys, this is the next question which is coming off. Okay, G stimulatory protein, that is, this is involved up in this, and because of that there is increase in annihilate cyclase activity, increase in cyclic AMP, and intracellular water comes into the lumen. Okay, so that is there. Okay, Pawan, I got that. Fine. So answer to this question is obviously what? GM1. Another thing is like which particular junctions it acts upon, that is the tight junctions or zonoocular dense ones. Okay guys, so remember this particular one also. So answer to this is GM1. And this particular Vibrio cholerae diarrhea mimics up which particular thing, you know? It particularly mimics up which metal poisoning? Arsenic metal poisoning. You know that? It mimics what? Arsenic metal poisoning. Yes. Live stream. Acute hepatitis B is characterized by, this was one of the questions, and in the comments can you tell me up, was it there that acute hepatitis B is characterized by what? Yes, please. Was it there? Acute hepatitis B is characterized by what? HBsAg along with IgM anti-HBC. These were there in the option. Yes, anybody? Dr. Navya, Ash, Modi ji, tell me. Was it there? Pre-core mutant. Okay. So pre-core mutant पूछा था. It was not like that. Reverse question they have given up markers and to diagnose. Okay. So pre-core mutant is HBS is absent. So it was absent there. Now what they actually want to ask, that like Aditya told up, that it was mentioned IgM positive, but HBS was not there. Huh? So it is a pre-core mutant. It's a Amol, then it is a pre-core mutant. No. Acha. HBS was not there because pre-core is not regarding that. HBE, right. So was this also written up? Escape mutant? Was this also written up? Escape mutant? Acha Pavan, escape mutant was also there. So if HBS is not mentioned up, then that it was about escape mutant was written. Okay. And the options were IgM only was written, HBS was not there. Huh? This you are telling. Okay. So was pre-core is that in which HBeAg is absent, Dr. Navya is telling that way. Okay. And escape mutant is that in which HBsAg is not there. Dr. Ikra, yours is right. If HBsAg was not there in the option, then it is escape mutant. In hemophilic only that happens. True. That history comes, Amol. SK mutant tha answer. Okay. So if you see up the lecture of mine, I have told up this escape and pre-core stuff. IgM antibody रहेगी. IgM HBsAg was present. Aditya is telling HBsAg was written there. But how can then HBs be positive? If it is SK mutant, then how come it can be positive? So confusion from your side only. If it is antibody only, IgM anti-HBC, then it's fine. Otherwise, ऐसा क्वेश्चन नहीं था सर. अच्छा ठीक है अदिति, आई गॉट योर पॉइंट. ऐसा क्वेश्चन नहीं था. चलो जो भी था, मतलब मैंने मोटा मोटा बता दिया कि अगर ऐसा था तो इस तरह से आंसर है और ये था तो ये आंसर है. ठीक है. Was absent. Yusita is telling HBsAg was absent in the options. So if it is absent, then SK mutant answer. Okay. Now somebody was telling that this was their healthcare worker needs to be protected against, and option was early acute hepatitis B. Yes, answer is SK mutant, guys. If it is like from this, I am getting up this thing. HBsAg negative, HBeAg positive. Acha. Okay. चलो देखते हैं इसको और डाटा इकट्ठा करते हैं इस पे. हेल्थ केयर वर्कर नीड्स टू बी प्रोटेक्टेड अगेंस्ट. वॉज देयर दिस टाइप ऑफ अ क्वेश्चन? एंड ऑब्वियसली द आंसर टू दिस क्वेश्चन इज दैट दे शुड बी गिवन hepatitis B vaccine and their anti-HBs titers before doing work should be more than this. That is more than 10 milliinternational units per ml. That is the anti-HBs titers. Okay, was there this question? अच्छा मीजल्स वाज ऑप्शन. मीजल्स तो कोई लॉजिक नहीं है उसकी वैक्सीनेशन का. हेल्थ केयर वर्कर के लिए हेपेटाइटिस बी की वैक्सीन लेना इज इम्पॉर्टेंट. सो दिस शुड बी देयर. मीजल्स, कॉलरा, HPV. ओके. मीजल्स, कॉलरा, HPV and one is hepatitis B. Huh? Ujita, one is hepatitis B also, na? Tell me. Question asked in disaster. Okay. Then the question is like all. Achha, it was asked in disaster stuff. Okay. ठीक है, फिर तो उसके हिसाब से चेंज होगा मामला. अच्छा, like somebody told me hepatitis B was there. Aditya, okay then. Okay, fine, no problem. Acha, tell me about this also, that was it asked that exotoxin production was asked in the exam? Typhoid is answer. Acha, now somebody is saying no typhoid is there. अच्छा, ऑप्शंस में था. ओके. और डिजास्टर के साथ था. एग्जैक्टली बताओ भाई. चलो, एक्सोटॉक्सिन प्रोडक्शन का बताओ. टेल मी रिगार्डिंग दिस एक्सोटॉक्सिन प्रोडक्शन. वाज इट देयर एंड वाज इट मेंशन्ड अप द स्टैफ ऑरियस दिस पर्टिकुलर टॉक्सिन TSST, टॉक्सिक शॉक सिंड्रोम टॉक्सिन? was it there in the exam? Yes, anybody? Exotoxin production. This sort of a question was there. Achha, it was one of the options for sure. Okay. If it is related to like except पूछा था exotoxin में, is not produced on the following condition. Okay, Aditya. So can you tell me up the options here in this particular one? All are exotoxin mediated except options were TTS, HUS, and two other options were there. Okay. Toxic disasters, bacillus entericis. Acha, one like Pawan have told na. This was also asked na, category A bioterrorist weapon. Category A bioterrorist weapon, that was asked na. Okay, question was like that, except, all produce exotoxin except. Fine. Somi, tell me now, which all are other options? One was HUS you're telling, and what were the other options? So this I have also told up na, category A bioterrorist weapon it is. You have to play with small bat in this, the mnemonic for this, the play with small bat. So Bacillus anthracis is a category A. Tularemia comes in this. Okay, yes, category A. Exotoxin was except pseudomembranous colitis. Okay. Got that. So this was wheel Felix you already told. Somebody told regarding lymphatic filariasis. This was there, that it's a disease of lymphatics. It was regarding what? Elephantiasis. They have shown the picture of elephantiasis. Somebody was telling image they have shown up, and they asked up which system is involved. Lymphatics. Was it like that? HUS, meningitis, pseudomembrane colitis, toxic shock. Okay. Acha. Fine. The image was there and lymphatics answer. Lymphatics is answer, Dr. Abhishek. No problem in that. Somebody told something related to monkeypox was also asked. Monkeypox question was also there. Yes, anybody? Yes, tell me. Dr. Somi, Priyanka, Aditya, can you tell me regarding this, that was there any question regarding monkeypox? Monkeypox was there with a rash on palms and soles. Okay. What was the exact question? What they want to ask up in that? History diya tha, like chicken pox rash wala. And what was there? Zoonotic infection and all that. Okay. Well, what they have asked, the diagnosis of it. So it can present with any sort of rash like chicken pox, na? A boy who has rash on face and trunk, a brother had a similar complaint. Okay. Yujita को सब याद है, एकदम perfect foreign visit history था, options में monkey pox था. Okay, Africa गया था आदित्य. That will have gone to the Africa. From Africa only this have come, na? अच्छा, Africa था. Okay. So this was also there, one of them, है ना? So you yourself can see up that how many questions have come. So this you already told up, Bacillus anthracis was category A. Rash spread to lead to the whole body and diagnosis was asked. Okay. Okay. Regarding clue cells, something was asked regarding clue cells. Clue cells, that is bacterial vaginosis. Was the question regarding bacterial vaginosis or what they have in this? Any picture sort or what? Okay, Dr. Abhishek, most likely everybody was telling regarding monkeypox only. If the description is fine, then it's towards monkeypox. Foreign history also there. Can you tell me what other options were there in that question? That monkeypox one? Achha, Dr. Navya, that clue cells was like a picture or what? And image was there. Dr. Abhishek is telling the image was there regarding it. and clue cell image was there, and you already know clue cells are what? Epithelial cells on which Gardnerella vaginalis is there. Yojita rocks. Dr. Deve, you also rock, don't worry. Somebody is telling that this sort of question was also there. HIV, TB. Acha, a picture was there and a big history. FMGE 2023 I told. HIV, TB diagnosis, the best is made by. These were the options there? CB, NAT, culture, PCR. AMSELS criteria, हाँ fine, वो तो सब सही है, अब आगे बताओ. Was this there? HIV, TB diagnosis? Yes, it was there. Okay, okay. Tell me this also, if CB, NAT and PCR both were there in the options. Both were there in the option, CB, NAT and PCR. First investigation in HIV with TB. यही आंसर, ठीक है, यही आंसर. डॉक्टर देवी, यू आर राइट. डॉक्टर प्रियंका, यू आर ऑल्सो राइट. डॉक्टर लाई, यू आर ऑल्सो राइट. आंसर इज CB, NAT here. Okay. Somebody told that something was asked regarding SDA also. SDA, culture media and like fungus and all. हाँ तो जैंक स्मीयर पूछा होगा भाई, जाइंट सेल. अच्छा स्वामी, ओके. अच्छा CD count is less than 35. Less than 35? For first investigation you are telling up. Dr. Abhishek, that particular answer is only when like the way you told up. Okay, like what was the diagnosis? Now somebody is telling CD4 count is less than this. Something regarding SDA was there or not? Like fungal culture media. This one, CMV retinitis was something there of this particular sort. CMV retinitis, and what was the exact question regarding CMV retinitis? CMV पूछा था, तो regarding what, like it was a history based or like case based or what they want to ask? Cottage and cheese retinopathy, what they want, like AIDS patient less than 100, the organism in options MAC was given. नहीं, less than 35 तो नहीं दिया था. Okay, देखो अब तुमने खुद ही questions बदल दिए. अच्छा, CMV retinitis was asked and the CD4 count is less than 50, around 35. This was the question of CMV retinitis. So something regarding rabies was also asked, guys. Rabies diagnosis. Can you tell me up regarding rabies stuff? Was like rabies diagnosis was also being asked. Direct immunofluorescence, indirect immunofluorescence, RT-PCR, something related to corneal smear. Drugs asked. Dr. Abhishek is saying drug is asked. One on diagnosis, one on treatment. Okay. So that's a straightforward one. I suppose you must have done. Was there a question on rabies diagnosis? Navya is telling yes. Amol is telling no. Amol कर नहीं पाए, दिखा नहीं क्वेश्चन, या था या नहीं था. Dr. Abhishek is telling yes. Pawan is telling no rabies. Dr. Neena is telling yes. Rudraksh is telling yes. FMG 2023 is also telling yes. Tetanus पूछा था, एक tetanus भी बोल रहा है कि tetanus was asked, and what was asked in tetanus, you can tell me up. So it if these would have been the options, the best nowadays is obviously RT-PCR from this particular sample. Okay, if this would have been in the options, then you should go for RT-PCR because that will amplify this particular thing, because yield is less from the corneal smear, and that can be amplified with the help of this real-time PCR. And if it is being asked in that way, a tetanus was asked. Okay. So what was asked in tetanus, Pawan and Aditya? Can you tell me regarding that? What was asked in that? 7 years ago, what was the treatment? Okay. So this table is there in the notes if you have seen up. It comes in the category B, single dose toxoid. Single dose toxoid is the answer, Dr. Neena. Ujita, if that would have been there. Okay, only tetanus toxoid because it is 7 years now, so that comes in immunized 7 years ago, so it comes in category B. So for that, single dose toxoid is there. Okay guys, so we have discussed up and you have wonderfully told me a lot of options and wonderfully told me up the real language of the question. Thank you so much Ujita, and thank you everybody who is there in this chat box. And I wish all you should pass with the flying colors. Obviously, I wish that more than 200, and nothing is impossible. Yes, single dose is answer. Ujita, you're right. And you all will pass with wonderful colors. That's my wish. And this particular thing proves up that not a single question is out of question bank or the notes of mine. So if you, and one thing I like to tell you, there is no shortcut to success. You have to read up the things and you have to revise up again and again, then only you'll able to build up a wonderful stuff for yourself. Okay. अभी तो बच्चा था, अभी एडल्ट हो गया सोमी, चलो देख लेते हैं क्या है, ठीक है. So Dr. Priyanka, thank you so much, and best of luck to everybody. And I suppose 150 is your demand, and you have done wonderful well. Second paper was good, even though the first paper was a bit difficult, but obviously you have marked up, and that too you have marked up by reasoning. So most likely from that also, that which you think now very difficult and all, a lot of questions you would able to answer up from there on. Okay, so very best of luck. And this particular thing shows up that yes, microbiology is not like confined of 13-14 questions and all. It is around 30 to 35 stuff, and I suppose if medicine and all properly is being inculcated in that, it amounts to 40 above. So basic knowledge is always important. Infectious disease, all of Harrison is all about microbiology. From my side, bye bye, take care, see you, and very best of luck. Thank you.
Hello and welcome to the recall session for this July 2023 FMGE examination. Here we are going to have a discussion on the orthopedic recall questions. You know, the paper was lengthy, the paper was tricky but as far as this orthopedic section is concerned, all the questions were relatively easier and just in a single line, you might have come up with the answers. Alright. So in this recall, what we are going to talk about means how you have identified the question in particular. Like there was a question which was mentioning that there is a history of injury to the arm with resultant fracture in the mid 1/3 of the humerus and the patient was not able to extend the wrist. Now everything was provided to you in the question. You just have to sum that up, that what is the name of the nerve which is likely to get injured and what is the name of the nerve injury that has resulted in this kind of the outcome. All right. Now all of us means this is not for the first time we are talking about it. Like if this is the humerus bone, the name of the nerve which is lying in closed approximation to this humerus in its entire length, right from the medial aspect up to the lateral aspect before its division into two of its terminal branch, the name of the nerve is radial nerve. Now this is something which we already know about, right? It is radial nerve. Then if there is a fracture in this mid 1/3 segment, and because the nerve is passing from the spiral through the spiral groove, right? So there is always a possibility of impingement of this nerve at this level. And once there is an impingement of this nerve at this level, that is in between, that is mid 1/3 of the humerus, then it will result in a high type of a radial nerve injury, as a result of which there will be inability to extend the wrist, as well as there will be inability to extend the metacarpophalangeal joint. So straight away means all of you must have answered this question right. Like if mid 1/3 of the humerus fracture is provided to you, they are asking about the name of the nerve which is likely to get injured, the name of the nerve which is likely to get impinged in this segment, that is a spiral groove, all right, is the radial nerve. So this means it is something, this is the kind of the question which all of you must have marked correctly, all right. Coming on to the next question. Now this is the kind of the question which we have discussed multiple of the times with a hint. You know, whenever we have talked about a scaphoid fracture, I told you 3 points that you have to remember. Point number 1 is the hint which will always be provided to you in the question clinically if they are asking this question, and that is there is a tenderness in anatomical snuff box. That means anatomical snuff box tenderness. All right. Now all of you are aware that this anatomical snuff box tenderness, there are 3 differential diagnoses. All right. One of the differential diagnoses is obviously the scaphoid fracture. The second differential diagnosis is D. querventino-synovitis. You already know what is D. querventino-synovitis. It is the impingement of abductor pollicis longus and extensor pollicis brevis in the first compartment of extensor retinaculum, as a result of which there will be a pain and tenderness which is elicited over the first this anatomical snuff box. So D. querventino-synovitis. Then apart from this is the fracture of the radial styloid. All right. Now, what are the things which are provided to you in this question? They gave you a mechanism of injury, fall on outstretched hand. Also, scaphoid is fractured when there is a fall on ulnarly deviated arm or ulnarly deviated wrist. So it can also result in a scaphoid fracture. But there is an anatomical snuff box tenderness. Now, once it is provided to you in the question that the patient is having an anatomical snuff box tenderness, you are ready with these 3 differentials. As far as options are concerned, in the options they are providing you the name of the carpal bones, and then they are asking what is the name of the bone which is likely to get injured. So the name of the bone, obvious answer for this question is scaphoid. It is a scaphoid fracture. Now, as I told you, 3 points that you have to remember. One is anatomical snuff box tenderness. The second point that you always have to remember related to this particular topic are the complications. All right. The complications are avascular necrosis, also the osteonecrosis, means one and the same thing. So osteonecrosis of the proximal pole, which is far more common compared to the distal pole. That means one of the complication is osteonecrosis in the body of the scaphoid, and the second one is the non-union at the fracture site. All right. And the third point that you have to remember is related to the management. Management means if there is an undisplaced fracture of the scaphoid, then there is a peculiar cast, a particular cast is provided in order to immobilize this scaphoid fracture for the elongated or extended period of 8 weeks. The name of the cast is scaphoid cast, and it is also known by the name of handshaking cast. But this is not the treatment for displaced fractures of the scaphoid. It is for the undisplaced fractures of the scaphoid, alright? Not for the displaced fracture. It is glass holding cast. It is glass holding cast. So everything we have already talked about, like why is it called by the name of glass holding cast? Because of the immobilization of the wrist in dorsiflexion, immobilization of the thumb in abduction. So it gives it a position, it gives it a shape of as if you are holding a glass, all right? Undisplaced fracture of the scaphoid, the complications you should be knowing about, and the most important fact, that is anatomical snuff box tenderness. So everything is provided to you in the question. You just have to mark the correct answer for the purpose of its identification. All right. Next question. Now, this is the kind of the question which is considered to be new. All right. Possibly the first time ever asked question. Now, they are asking that what is the name of the nerve which is likely injured, resulting in this kind of a deformity or abnormality. So, first of all, you have to identify the abnormality. When this is a kind of the image where the back is revealed, then majority of the time, the first thing that you try to sort out is look at the level of the scapulae, because one of the condition that you are aware of is a Sprengel shoulder. Sprengel shoulder is high-lying scapulae, one of the scapulae which is incompletely descended scapulae, and as a result of it, there will be asymmetry of the scapular margins or the scapular borders. But here, there is no such asymmetry. That means one of the differentials that you tend to see on the back or region, one of the differential is Sprengel shoulder. But here, because Sprengel shoulder is identified by asymmetry of the scapulae, here there is no such asymmetry which is observed. So Sprengel shoulder obviously is not the answer for this question, because both the scapulae are at the same level. Now, the second thing that you tend to see when these kind of the images are provided to you is the winging of scapula. And how this winging of scapula is identified? It is the medial border of the scapulae on the affected side will be more prominent in comparison to the normal side. But there has to be an observable push which should be provided in the question. As if the patient is trying to push the wall, then only there will be an over prominence of the medial border of the scapula on the affected side. But here, there is no such over prominence of the medial border of the scapula on the affected side. So possibly this winging of scapula is also not the answer, where this back is studied. Then the third one is scoliosis. What happens in scoliosis? It is a lateral curvature of the vertebrae. It is a lateral bending of the vertebrae. Now, in this case, the vertebral column is exactly in the center. All right. There is no such deviation, no such lateral deviations which are observed in this back also. So, scoliotic deformity is also not there. There is no such scoliosis observed. Then, what is the abnormality which is obvious in this case? The abnormality is that if you look on the left side of the patient, all right, this shoulder border, the posterior border of the shoulder, that means the trapezial border of the shoulder on the left side is asymmetrical in comparison to that of the right side. On the right side, there is a lower level of the trapezial border compared to that of the left side. And in the question, there was a history of stab injury in and around the neck also provided. And this thing happens that the 11th cranial nerve, that is spinal accessory nerve, is likely to get injured under the influence of either compression or because of the stab wounds, leading to the paralysis or the palsy of the trapezius on the affected side, as well as that of the sternocleidomastoid on the affected side. As a result of which, the contour of this trapezius is lost over a period of time, and there will be an asymmetry observed at the level of the shoulder. All right. So, one of the shoulder is sunken down just because the trapezius on the affected side is not functional or might be paralyzed because of the injury to the spinal accessory nerve. So, what is the fourth thing that, as a fourth differential that is important for you to identify, is that the trapezius on the affected side or the trapezial border on the affected side is lower. There is asymmetry on the posterior border of the shoulders, all right, right from the neck. And this asymmetry, the reason for this asymmetry is the spinal accessory nerve injury. All right. Now, although the question is concised, like which structure is most likely to get damaged, but the language of the question which was provided in the paper was that there was a history of a stab wound also. All right. stab injury, and as I told you that the mechanism for these spinal accessory nerve injuries possibly is because of either a stab or a compression injury. So answer for this question goes in the favor of spinal accessory nerve, that is 11th cranial nerve. You already know that 11th cranial nerve is responsible for the supply to the trapezius and sternocleidomastoid muscle, right? And here in this case, the trapezius on the right side is paralyzed, as a result of which it is responsible for creating this asymmetry. Yes, an important question for future. And whenever there is an image of this sort is provided to you, then these are the 4 differentials that you have to rule them out one by one. The one thing is winging of scapula, but for winging of scapula, there has to be a push movement like this, all right? And this entire thing has to be captured in the picture. Second is spranger shoulder, where the shoulder level has to be, or the scapula level has to be higher in comparison to the other. The third one is the scoliotic deformity, where there is a lateral curvature of the vertebrae. And the fourth one obviously is the trapezial palsy, or you can say the spinal accessory nerve injuries, all right, asymmetry of the shoulder. So hopefully you have marked this answer correctly. Out of all the questions which were asked in orthopedics, it is a kind of the question which was considered to be a new one. Otherwise, every other question was a repeat one of the sort. All right. Now, this is something which we have talked multiple of the times, and there has to be no confusion as such in order to identify these lateral deviational abnormalities at the level of the elbow, right? Normally, all of you are aware of the fact that if this is the trunk of the individual, this is the arm of the individual, this is forearm of the individual. So we are having the axis of long axis of the arm, long axis of the forearm. Now within normal limits, there is a deviation, and this deviation is known as carrying angle. But on the other hand, if this carrying angle is increased in comparison to the normal, all right, that means there is more deviation towards the medial aspect, that the apex which is being created is more inclined towards the medial aspect, then this abnormality is known as valgus, cubitus valgus, where the apex is pointing towards the midline of the body, more towards the midline of the body. So normally also there is an apex which is created at the level of the elbow by the carrying angle, and this apex is pointing towards the body, but here the carrying angle is more than normal, so it goes in the favor of valgus. Exactly opposite would have been a varus deformity. If this is the trunk of the individual, all right, then if this is the arm, this is the forearm, if this kind of the condition is happening where the axis or the apex of this angle is pointing away from the midline of the body, then it would have been a varus deformity at the level of the elbow, that is cubitus varus. All right. Now, what is cubitus rectus? One of the options was cubitus rectus. So, what is cubitus rectus? When the axis of the forearm and axis of the arm is one line. That means there is no carrying angle which is created in between the two. The carrying angle is 0. That is cubitus rectus. All right. Now, this is something which you already are aware of. It is just the point of identification. Like in this image in particular, on the right side, we can very clearly see that this is the axis deviation, but on the left side, the axis deviation is slightly more. So, the carrying angle which is created at the level of the left elbow is higher in comparison to the right one. So, the left one is suffering from the cubitus valgus deformity. So, answer for this question is obvious, that is cubitus valgus deformity. Now, one thing which I have been quoting right from the beginning is that, both these varus or valgus abnormality at the level of elbow can only be demonstrated with the extended elbow. If the elbow is flexed to any degree, 5 degree, 10 degree, 20 degree, and there is an apical angulation or there is an apical deformity, then it is inconclusive until and unless the elbows are kept completely extended. So here also in this case, you can only say that it has moved into varus or valgus because the elbow is completely extended. All right. So one prerequisite which is required in order to identify the abnormality as varus or valgus or tag the abnormality as varus or valgus, that it has to be demonstrated only with the extended elbow. All right. If the elbow is slight amount of flexed, if there is a flexion deformity of the elbow and there is a apical deformity like this, no, you cannot jump onto the conclusion and can say that this is the cubitus varus or valgus deformity respectively. Hopefully everything is clear related to this question. Now, I hope that all of you have marked this answer correctly. All right. Next, Now, this is the kind of the question which we have talked in the short form, like every time we are talking about the soft tissue injuries in the upper limb. Now, this is one thing which is very, very much obvious in any of the provided image, and there is a strong reason behind this abnormality too. So, as you can very clearly see, the topic that we are talking about, one is pop eye sign. The name of this sign is pop eye sign. All right. Point number two. What is this injury over here which is happening? It is injury to the biceps tendon. Actually, it is the rupture of the biceps tendon. Now, what happens? You know, when there is a rupture of the long head of the biceps tendon from the coracoid process, as a result of which the entire biceps gets accumulated. The entire biceps muscle gets accumulated in the arm. And when the patient is asked to flex the elbow, then this accumulated biceps will be more prominent in comparison to the normal one. So, there will be an abnormal prominence of this biceps bulk on flexion of the elbow. Why we are correlating it with the cartoon character Popeye? Because in Popeye cartoon, on the intake of the spinach, there was over prominence of the biceps muscles. So, this is how the things are getting correlated. Alright. So, here we are having, or we can witness the abnormal prominence of the biceps bulk. This is the abnormal prominence of the biceps bulk on flexion of the elbow. Alright. It is because the long head of the biceps is ruptured, the tendon of the long head of the biceps is ruptured, and all the biceps is getting accumulated over there in the arm. Alright. So, this kind of a question is a straightforward question, like there is nothing which is required in the sort of a background. Alright. And this is the question which was asked for the first time in All India Examination 2019. It certainly got repeated after 1 or 2 years also. But in FMGE examination, I think it is for the first time or the second time this question has been asked. Alright. We always used to talk about this particular topic along with the mallet and the gamekeeper thumb. Alright. That is pop eye sign. Because there is always a strong reason for these kind of the questions to become apparent in your paper. Because these are a kind of the question which are going to have a certain answers without any confusion. Okay. So, hopefully everything is clear related to this pop eye sign and the biceps tendon injury. Then there was a question where, you know, a diagrammatic representation of the patella was there. Then there was a patellar tendon, that obviously it is going to be on the lower pole of the patella. Then we had the quadriceps over here in the proximal aspect, and there was a marking onto the superior pole of the patella that there is a pain and tenderness in the superior pole of the patella. What is the name of the bursitis over here? Obviously, it is pre-patellar bursitis. Alright, that is suprapatellar bursitis, and the suprapatellar or the prepatellar bursitis is the feature of the housemaid knee. Now, you know, these are the kind of one-liners, bursitis are the kind of one-liners that we talk about, because these are the kind of the questions which are always going to be kept in your examination, either in the form of the one-liner or in the form of a diagrammatic representation as is being asked this time. Alright, like bursitis means like if there is a lateral epicondylitis, then this lateral epicondylitis is known by the name of tennis elbow. Lateral epicondylitis of the humerus. So, it is known by the name of tennis elbow. So, this is one thing. Second is medial epicondylitis of the elbow is known by the name of golfer elbow. Alright. The third one is student elbow. Now, student elbow is olecranon bursitis. Actually, this is the table where all the bursitis are being accumulated. Then there is pre-patellar bursitis, or you can say suprapatellar bursitis, and this pre-patellar bursitis is the feature, or it is known by the name of housemaid knee. Then it is often confused with infrapatellar bursitis. Alright, this infrapatellar bursitis is actually known by the name of clergyman knee. You know, all these bursitis is the result of a repeated frictional assault or repeated frictional abuse to the surface of the tendon or the surface of the muscle, resulting in the formation of the bursa, which is getting inflamed, which gets swollen up and resulting in this painful condition known by the name of bursitis. Similarly, we have Weaver bottom. weaver bottom, which is ischial bursitis, and talar ankle. This is TAI, talar ankle, which is lateral malleolar bursitis. Lateral malleolar bursitis. Alright. So, hopefully you have marked this answer also correctly. We are not getting what exactly the kind of the question, but there was a image which was provided where the arrow was placed in the prepatellar region, and they have asked that what is the name of the bursitis which is responsible for the pain and tenderness in this particular region. It could have been asked in the form of either a simple prepatellar bursitis or in the form of a housemaid knee. Alright. So, this much about the orthopedic recall, which has been asked in the form of the question in this July 2023 examination for FMGE. The questions were relatively simple, except for the single one question, that is about the trapezius abnormality. All the questions were the repeat questions. Out of 6, the questions that we have collected directly or indirectly related to the orthopedics, the 5 were direct repeats. Alright, the 5 were the kind of the question which has been asked multiple of the time previously. So, all the best for your future endeavors. Thank you so much for attendance.
So, hello my dear students, hope you have done your exam well, and here we are with discussion of dermatology questions which were asked in FMG exam. So, there was one question. In that question they showed one image, and in that image there were few erythematous plaques, that is solid raised areas, and they were red in color and they were having silvery white scaling. Okay, so here you can read this question. They are saying 50-year-old man came with the lesions as shown in the image below. Now, what you can make out? Yes, so this is a case of psoriasis. So, in psoriasis, such erythematous plaque with silvery white scaling are generally seen over extensors. On examination, painful and swollen finger were noted along with inflamed wrist joints. So, joints, fingers were painful, swollen and inflamed. So, all these are pointing towards inflammation in the joints, in the finger joints, and this is most likely a case of, so this is a case of psoriasis, and if a patient suffering from psoriasis develop this inflamed joints, which are very commonly the smaller joint, like the most common joint involved in psoriasis is DIP, that is distal interphalangeal joint. So, fingers are inflamed, that is, it is suggestive of psoriatic arthritis. So, answer here is psoriatic arthritis, which is involvement of joint in a patient who is already suffering from psoriasis. So, from the image it is clear it is psoriasis, and because the patient is having joint involvement, this is psoriatic arthritis. Now, remember that in these cases, if you do X-ray, pencil in cup deformity is seen, and the most common type of psoriatic arthritis is asymmetrical oligoarticular type. Moving on to the next question, they are saying that a patient presented with these lesions as shown in the image, where you can see one round, that is annular lesion, and if you see the central portion, there is appearing as if it is having normal skin. So, there is central clearing and was treated with topical steroids. Okay, so central clearing with annular lesion is suggestive of tinea. So, this is a case of tinea because the lesion is present over face. This is facialis or fasciae. Now, if over tinea lesion, if you apply steroids, what will happen? The inflammation subsides, that is redness, itching subsides, but the infection is still there and it is spreading, and such type of tinea is known as tinea incognito. Incognito means hidden. So, this is a hidden tinea. Why? Because the symptoms are absent due to application of steroids. Moving on to the next question, here they are saying that identify the condition, and here if you see the second image, the growths are present and these growths are rough. So, such rough growths are present. Rough means verrucous. So, verrucous or wart-like growths are seen, and warts, when they are present over anal and genital areas, these are known as anogenital warts. And anogenital warts are caused by human papilloma virus 6 and 11, and they are also known as condyloma acuminata, not condyloma lata, which are seen in secondary syphilis. Now, one of the option is hemorrhoids, and if you see the first image, hemorrhoids look something like this. Okay, so remember that these growths which are present here, because they are having rough surface, verrucous, that's why these are what? These are anogenital warts. So the answer here is condyloma acuminata. Then identify this condition. Now in this condition, what you can see? You can see that if you draw a line in between, the lesion is asymmetrical, isn't it? And if you look at the borders are not even or round, borders are irregular. And if you look at the color of the lesion, the color is variable. Why? Because it is very dark here, it is slightly pinkish here, slightly brownish here. So different colors are seen, variable color are seen. If you ask the patient will give you history that initially the lesion was small, but gradually it is increasing in size. So diameter is increasing. And gradually these lesions are evolving. There is evolution of the lesion. That is, initially the growth was not there, but now different types of growths can be seen, like this one and this one. All these are the features which are suggestive of malignant melanoma, and you can very easily remember all these features by the A, B, C, D, E of malignant melanoma. That is, asymmetrical lesions, borders are irregular, color is variable, diameter is increasing, and there is evolution of the lesion. Moving on to the next question, they are saying that which of the following deficiency is associated with poor wound healing, dermatitis, diarrhea, and alopecia? And all of you know the answer to this question is acrodermatitis enteropathica, which is due to zinc deficiency. Yes. See, if it is written dermatitis, diarrhea, dementia, then it is niacin deficiency. But here the answer is not niacin. Why? Because it is zinc deficiency, because zinc deficiency is also associated with non-scarring type of alopecia. Here there is enteropathica, that is intestinal involvement leading to diarrhea. Patient have dermatitis, as it is very obvious from the name itself. Commonly acral parts are involved, like hand, foot, along with face and diaper areas. And because zinc deficiency, it is required for wound healing along with vitamin C, so it can lead to poor wound healing as well. So all these are the features suggestive of zinc deficiency. Now remember that poor wound healing is also feature of vitamin C, but the answer here is not vitamin C. Why? Because vitamin C deficiency can lead to scurvy, poor wound healing, but not dermatitis or alopecia. Then slow wound healing after a minor surgery is due to deficiency of, I told you that slow wound healing or poor wound healing is feature of zinc deficiency as well as vitamin C deficiency. Here vitamin C is there in the option, so answer is vitamin C deficiency. As you all know that in scurvy, which is due to vitamin C deficiency, what happens? That patient have recurrent bleeding from the gums, epistaxis. Why? Because of the blood do not stop. There is no proper healing. Okay, so that's why vitamin C deficiency is related to slow wound healing. So answer here is vitamin C. Now history of burn 3 years before. So there is a burn scar which was there for last 3 years, and now what happened? The patient presented with below condition, and what you can see in the below condition, you can see lot of granulation tissue at the base of the ulcer. So there is granulation tissue, there is one ulcer present, and this ulcer is over scar. Which scar? Burn scar. So 3 years back there was burn which led to burn scar, and now what is happening? A ulcer is developing which is having lot of granulation tissue, and because this is lot of granulation tissue, if you touch this it will easily bleed. All these are the features which are suggestive of ulcerative squamous cell carcinoma, which commonly occur over burn scar, trophic scar, or any injury, past injury is there, and then these lesions start developing. This ulcerative squamous cell carcinoma is also known as Marjolin's ulcer. So answer here is A. Moving on to the next question, they are saying a patient presented with hypopigmented lesions, that is light colored lesions associated with loss of sensation over the lesions. So do you know any condition where there is light colored lesions with hypoanesthesia, that is loss of sensation? Yes, all of you are correct. The answer is leprosy or Hansen's disease, which is associated with hypopigmented, hypoanesthetic skin patches along with nerve involvement. Then a child comes and presented with generalized vesicular eruptions. So there are vesicles, that is fluid filled lesions involving body, trunk area. What is the diagnosis? The age of the patient is 3 years. And you can type in the chat box that I think some students told me that there was also history that the brother of this child is also suffering from the same condition. So all of you know that this is a case of chicken pox, which is due to varicella infection, varicella zoster virus infection, and because this is a communicable disease, it can spread from one person to another. So another child in the same family is also suffering from the disease. All these are suggestive of chicken pox, which is due to varicella zoster virus. And in chicken pox, such clear fluid filled vesicles start developing with a reddish halo around it. So these are also known as dewdrop on rose petal. So such appearance is seen and any part of the body can get involved. Then which system is involved in this condition? Now all of you know that what is happening here, there is elephantiasis. So this is a patient suffering from elephantiasis, and elephantiasis occurs due to filariasis, which is due to lymphatic obstruction. So this is lymphatic filariasis. So which system is involved? Lymphatic system is involved, and due to obstruction of that, there is accumulation of the lymph, and this leads to this elephantiasis or large size of the leg, which is being shown here in the image. So this was again a clear-cut answer. Now, there was one more question. Some of the students were saying that there was a question on trichobezoar. So I didn't get that question. So if you can just type that what was that question and what were the options there, and I hope you must have marked that question also correctly. That is trichobezoar, where the patient have impulse control disorder and they pull the hair follicles and they start eating them, and this collection of the hair follicles in the intestine causes trichobezoar. Okay, so all the very best from my side. Hope all of you pass. Thank you very much.
Hello students, I hope you had a good exam. There were 4 questions which I received for anesthesia, and all 4 were quite simple. Out of 4, I would say just one was little twisted and required a bit proper visualization of the image which was asked. And rest 3 were very simple questions, right? So I hope you have done all the questions correct. Now let us start with the first question. Identify this image. So this classification. So a classification was given in which oral cavity was open and the structures of oral cavity was visible. And it was classified into class 1, class 2, class 3, class 4. And it was asked, what is this classification? Now, what were the options? Let us see. Mallampati classification, Brodsky classification, Friedman classification, and Kohn-Maclehane classification. Now, what is Mallampati classification? Mallampati classification is pre-anesthetic evaluation of predicting difficulty in intubation. And how do we do it? So many times in my video lectures, I have discussed the video lecture on pre-anesthetic evaluation, in which I discussed the airway evaluation. I told you how to assess the Mallampati. We sit in front of the patient. We ask the patient to open his mouth and take the tongue out, and then we peep inside his oral cavity and try to see the structures of oral cavity. If I'm able to see all the structures, I write Mallampati grade 1, class 1. If I miss 1 or 2 structures, class 2. if I don't see the tip of uvula, only the base of uvula, class 3, and only, let's say, hard palate, class 4, right? And 1 and 2, no difficulty because tongue is small in size, and 3 and 4, there's a difficulty because tongue is bigger. So in first look, this image seems the Malampati classification. But guys, I told you, how do we assess Malampati? We ask the patient to open his mouth and take the tongue out. So this tongue has to come out of the oral cavity. Yes, this tongue has to protrude out of the oral cavity, and then we have to see the structures of oral cavity. So I don't know what exactly was in the image which is asked in the question. If the image had the tongue protruded out, how would we know the tongue is protruded out? By seeing whether the lower teeth are visible or not. Lower jaw, teeth of the lower jaw is visible or not. If the teeth of the lower jaw is not visible, then the tongue is out, right? If the teeth of the lower jaw is visible, the tongue is in. If teeth is not visible, the tongue is out. So if tongue is out, then it is Malampati classification, same. But if tongue is in, then it is not Malampati classification. Then it would change. So then what would it become? It would become the third option, that is Friedman classification. You can see this. This is Friedman classification. Friedman classification. Where do we do Friedman classification? We do it in obstructive sleep apnea. We do it to grade whether the patient would have the obstructive sleep apnea or not, right? So it is done in the same way. The only difference in the Friedman classification is the tongue is not protruded outward. The tongue is not out. The tongue is not out. Okay. So if you see this image, comparing the Malampati and the Friedman, the above one is Malampati, class 1, class 2, class 3, class 4. This one is the Malampati classification. Malampati, right? Why? The tongue is out. And the lower one is Friedman classification. So guys, if the question would have been very simple and Friedman classification would not have been in the option, then it was a very simple question, Malampati classification. But when Friedman classification is in the option, then you have to see the position of tongue. And if tongue is inside, then it is Friedman. And if it is protruding outside the oral cavity, then it is Malampati. Got my point? And Friedman classification is done in obstructive sleep apnea. Obstructive sleep apnea. Okay? The second option was Brodsky classification. What is Brodsky classification? The tonsil, how much when we see the oral, inside the oral cavity, when we peep inside the oral cavity, how much the tonsil is visible, that is classified in Brodsky classification. Brodsky classification, right? You can see in the figure, let's say class 0, tonsil has been surgically removed, no tonsil. In class 1, the tonsil is visible, but it is hidden by the tonsillar pillars. Class 2, the tonsil is just up to tonsillar pillars. Class 3, the tonsil is, let's say, crossing the tonsillar pillars. And class 4, tonsil extend to midline. Okay. Now, this is done to see the tonsillar hypertrophy. Tonsillar classify the tonsillar hypertrophy. Okay. And this is also used in obstructive sleep apnea. Obstructive sleep apnea to predict the risk associated with obstructive sleep apnea. If tonsil is hypertrophied, again there would be a risk of obstructive sleep apnea. If tongue is big, again there would be a risk of obstructive sleep apnea. So Brodsky classification and the Friedman classification is used in obstructive sleep apnea. Friedman to see the size of tongue and Brodsky to see the tonsillar hypertrophy. And Malampati classification is, so many times we have discussed, pre-anesthetic evaluation. Pre-anesthetic evaluation for predicting difficulty in intubation. Difficulty in intubation. Okay? Okay, guys. You know, Malampati classification has also been used in obstructive sleep apnea, right? To see the risk of obstructive sleep apnea. Got my point? The only thing, the difference image of the two classification, the Malampati and the Friedman, is the position of tongue. Tongue out, it is Malampati. Tongue inside oral cavity, it is Friedman classification. So I am leaving to you what was the image. If the image was the above one, it would be Malampati. the answer. And if the image was the below one, that is the tongue inside the oral cavity, it would be Friedman classification. And the last option, Konmak-Lehane. Konmak-Lehane is the classification to predict difficulty in intubation. It is laryngoscopic view of glottic opening. So it is not the view of oral cavity. Rather, when we put laryngoscope inside the oral cavity and how much the glottic opening is visible, that is Konmak-Lehane grading. So it is laryngoscopic view of glottic opening, right? That is Konmak-Lehane grading. Okay, this was our first question. An answer I have left to you. Whether it is Mallampati or Friedman depends upon the position of tongue. Okay. Now, next question. What is the fluid of choice for surgery? Well, in my chapter, that is intraoperative fluid or perioperative fluid, in the chapter perioperative fluid, I discussed two types of fluid, colloid and crystalloid, right? And colloid, I told you, we have natural, which is blood and blood product, and we have artificial, okay? And crystalloid, we discussed, is hypotonic, isotonic and hypertonic, right? This is how the crystalloid is divided. So this question was a very, very basic and a simple question. I told you in that chapter that it is nothing which is a better fluid, colloid or crystalloid. We always start with crystalloid, and once enough crystalloid is given, then we switch to colloid. So what is the fluid of choice for surgery? So we always start with crystalloid. There is no question of starting with colloid. We always start with crystalloid. And when a substantial amount of crystalloid has been given, then we go to colloid. So answer has to be crystalloid. Blood is a colloid. Now colloid is a colloid. And FFP is a natural colloid. Got my point? So answer has to be crystalloid. Well, if this question would have been a little more difficult, if they would have tried to make it more difficult, they would have, let's say, asked in which crystalloid, which is the best fluid of choice for surgery. So I told you the crystalloids are divided into hypotonic, isotonic and hypertonic. The hypotonic crystalloid, that is 5% dextrose, etc., they are not used in perioperative period or intraoperative period because let's say the dextrose gets metabolized and then it becomes free water, does not remain in intravascular space. So it cannot be used to maintaining the volume, intravascular volume, etc. So it's not used. Hypertonic, that is 3% normal saline or 6% normal saline, they can be used because they are hypertonic, so they can pull the interstitial fluid into intravascular space, but they are not used routinely. Well, when the patient is in shock or something like that, then we can use them, but not routinely. What is routinely used? Isotonic. Isotonic fluids like normal saline, right? Normal saline, and isotonic fluid like Ringer's lactate. Ringer's lactate. See, Ringer's lactate, if they ask the best fluid to be used in intraop condition, I would go for isotonic crystalloid, and an isotonic crystalloid also Ringer's lactate. This is most physiological fluid, and this is the fluid of choice, right? Fluid of choice, and this is the fluid we start with. If this is not in the option, I would go for normal saline, right? So remember, isotonic crystalloid is the first fluid which we always use in intraop, during surgery or during perioperative condition or in wards, right? So this is the best fluid to maintain the intravascular volume. Okay, now coming on the third question, again a very simple question which I have discussed so many times in my topic ACLS. Which of the following is not used in advanced cardiac life support system? They have this time asked on drug. They are always asking one question on ACLS, and this time they had asked on drug. Which of the following is not a drug of ACLS? Now option A, adrenaline, option B, amiodarone, option C, soda bicarb, and option D, high voltage defibrillator, right? So let us talk about ACLS, advanced cardiac life support. I told you, management of cardiac arrest in advanced cardiac life support system is divided into two, depending upon the type of rhythm, shockable and non-shockable. So we discussed in our topic ACLS in detail that shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. and non-shockable rhythms are asystole and pulseless electrical activity. So what are the intervention which we do in shockable rhythm apart from compression and ventilation? So we do compression and ventilation, that we give high quality compression ventilation, and apart from, in both we give compression and ventilation, right? What is the other thing apart from this we do? In shockable rhythm, the best thing, the fastest thing which we can give, which we can do, is we can give a shock. We can defibrillate. So we can give a shock. So we start with 120 joules, we go up to 200 joules, even more than that, right? So we defibrillate the heart and try to make this rhythm into normal. I mean, we try to stop the heart by defibrillating the heart, and then the heart will resume its normal rhythm. It may become normal sinus rhythm. Apart from this compression, ventilation and defibrillation, the emergency drugs we use emergency drugs. What are the emergency drugs which we use in shockable rhythm? Two important drugs, adrenaline and amiodarone, right? Adrenaline and amiodarone. Adrenaline always 10 milligram, 1 in 10,000 dilution. We repeat every 3 to 5 minutes. Amiodarone only 2 doses. First 300 milligram followed by 150 milligram, only 2 doses. So these are the two emergency drugs we use. If I don't have amiodarone, then I can use, instead of amiodarone, as an alternative, I can use lidocaine in dose 1 to 1.5 milligram per kg body weight, and then the half dose, okay? And if I see the rhythm as torsades de pointis, right? I see the rhythm of the cardiac arrest, that is pulseless ventricular tachycardia, as torsades de pointis, then we can give magnesium sulfate, right? Which is the definitive management of that kind of rhythm. Now, this two, lidocaine and magnesium sulfate, these are used only in specific condition. If amiodarone is not there, then lidocaine, and magnesium sulfate in specific condition. What are the two most important drugs of managing the shockable rhythm? Adrenaline and amiodarone, okay? What about non-shockable rhythm, apart from compression and ventilation? In non-shockable rhythm, we never defibrillate. Defibrillation is not done. And in emergency drug, the only one drug which we use is adrenaline, only adrenaline. No amiodarone, no any other drug. Got my point? So, only adrenaline is what we are using in non-shockable rhythm as the emergency drug. Got my point? So, in this question, sodium bicarbonate is there. The sodium bicarbonate is not a routine emergency drug of ACLS, right? So, it has to be in the answer. Previously, when the patient used to go into cardiac arrest, people used to give all kind of drugs like calcium gluconate, sodium bicarbonate, and whatever used to, atropine, whatever used to come in their mind. No, nowadays the management is very specific and you have to follow the guideline. And in the guideline, there is no role of sodium bicarbonate. Okay, so sodium bicarbonate is not used, let's say, in ACLS management. It's not used in ACLS management. Adrenaline is used, amiodarone is used, and defibrillation is used, as we have discussed. So answer has to be sodium bicarbonate. Got it? Now coming on the last question, image-based question. What is this device used for? So they gave the image of this device, and what is this device used for? Spinal anesthesia, epidural anesthesia, to create pneumoperitoneum, lumbar puncture. Well, I have shown you the image of spinal needle. This is the image of spinal needle. You can see there is a very thin needle with a stellate which is color coded. Okay, we have needle and stellate, right, which is color coded, and this is the hub, and it is divided into two types, dura cutting or dura splitting, depending upon the end of the needle, right? That is pencil tip, that is dura splitting, this is dura splitting, and the very sharp end, that is dura cutting. So this is the spinal needle. This is used for spinal anesthesia. This is epidural needle. Again, we have a needle which is marked 1 centimeter gradation on it, and we have a stellate and we have a hub. Okay, this needle is used for epidural anesthesia. Through this needle, this is the most common one which we use is Tooheys needle. Okay, through this needle we can put catheter. Okay, this is epidural needle. Okay, now this is lumbar puncture needle. This is full steel needle with a steel stellate inside it. This was the older version of lumbar puncture needle. Today we use a spinal needle for lumbar puncture. So again there is a needle and there is a stylet. There is a stylet. Got it? So what was the needle asked in question? This was the needle. Now does not this needle seem different from the 3 needle which I showed you for the 3 option, that is A, B and D? This needle you can see is a steel needle which has a trocar. This is coming. This is not stellate. This is coming out of the let's say the outer portion of the needle. This is trocar. This is trocar needle. Okay, trocar needle. So this trocar needle, we go in the peritoneum, then we take the stellate out, and this is the point where we attach tubing and we give gas from the cylinder and we create a pneumoperitoneum. This is called Verey's needle. You can see this. This is trocar with a stellate inside it. We attach the tubing, for giving the gas. This is called Verey's needle. Verey's needle, and this is used to create pneumoperitoneum. Got it? So this was asked in the exam. What is this device used for? This device is used to create pneumoperitoneum for laparoscopic surgery. For lap surgery. Got my point? Spinal anesthesia. This is the spinal needle. This is the spinal needle. A needle with a stylet. It is not trocar, right? Needle with a stylet. This is epidural needle, thin needle with markings on it. Okay. This is needle with a stylet. And this is lumbar puncture needle. They don't have any port for insufflating the air. It doesn't have any port for insufflating the air. This also doesn't have any port for insufflating the air. This also does not have any port for insufflating air. But this Verey's needle, it has a port for insufflating the air. So this is how we recognize it. So this is our Verey's needle to create pneumoperitoneum for laparoscopic surgery. So these were the 4 questions. So very quickly, I would just tell you the answers of all the 4 questions. So first question was, identify this classification. Now depending upon the tongue in or tongue out. Malampatti if tongue is out. Friedman if tongue is inside. Got it? Okay. Next, what is the fluid of choice for the surgery? Answer has to be crystalloid. If they want to be more specific, best crystalloid is Ringer's lactate, RL, the most physiological fluid. Okay. Then, which of the following is not used for ACLS? The answer is sodium bicarbonate, adrenaline amiodarone and defibrillation. All 3 used for your shockable rhythm of cardiac arrest, and adrenaline only as the emergency drug used for non-shockable rhythm of cardiac arrest. But sodium bicarbonate as such has no indication in managing cardiac arrest. And the 4th, what is this device used for? This device is used, this is a Verey's needle used to create pneumoperitoneum for the laparoscopic surgery. So these were the 4 simple questions which was asked from anesthesia. I hope you have done good and marked all 4 right, all 4 correct. See, if you see, the last question was from my clinical video in which I showed different type of needles. I very particularly showed you the spinal and the epidural needle. So definitely this image, that there were 3 options. If you have not seen a Verey's needle also, the spinal needle, you know how it looks, the epidural needle, you know how it looks, and the lumbar puncture needle is same as the spinal needle. So it would have been a simple question if you could have played the odd man out and you could have answered this needle to create pneumoperitoneum for laparoscopic surgery. Then in ACLS, in our topic ACLS, we have discussed the drugs which we use specifically for ACLS management, advanced cardiac life support, managing a cardiac arrest patient. And then we have already discussed in perioperative fluid, what is the fluid we use initially for any in perioperative period, that is crystalloid. And of course, Malampati classification, that was little twisted question. Well, you have to be very specifically look for the position of the tongue. It would have been a simple question if Friedman would not have been in the option, but Friedman classification was in the option. Then little bit question became complicated, right? So these were the 4 questions. Thank you.
Hello, hi everyone. Welcome to FMGE 2023 Solutions. So I'm Dr. Saurabh Dikshit and I'll be discussing the surgery paper. This time surgery paper was super easy for me. If I say majority of the things were very easy and conceptual, there was nothing like Tom, Dick, Harry syndrome. It was straightforward questions. But yeah, I have tried to just recall all these questions. Students, a disclaimer before I start my discussion. These are the questions which have been collected from the students. They are not my own questions because I have not given the exam. It is based on the memory. So there may be some questions which might have been incorrectly reported or some options which might have been incorrectly reported. So I'll try to do the justice as much as possible. So the first question is a straightforward question from triage. You know, triage is where we have a scenario where the demand and the supply is not meeting. So we have to maximize the treatment output. And triage, when we talk about triage, the patient priority is done by the color coding system. So red, the question says which of the following is correct about the triage. Red is given the maximum priority, then we have the yellow, then we have the green, and then we have the black. So black includes either dead or moribund people. So if you read this, this is absolutely wrong. Yeah. Green includes ambulatory patients. So who are these ambulatory patients? They have minor injuries, so they just require a first aid management or first aid intervention. So they are the one who don't require any admission. So this green is also wrong because either the green is ambulatory or when you talk about life threatening, yeah, it is immediately life threatening is what is red. When we talk about red, it is immediate life threatening, and when something is immediately or you can say potentially life threatening, you need to take these patients ASAP for the intervention. So red is ambulatory? No, they are the one where you cannot deny and you cannot even delay. Now yellow are the patients who require intervention. So they are the patients who require intervention but not life saving. Now this is what is very, very, very important. So in this case, I would say amongst the option given below, the best option is yellow is a stable patient, but they need observation, and that is why they should be sent to the hospital. Next is you have a patient. This is a very easy question. Can you see near the medial malleolus you have an ulcerative growth? Patient came to OPD with a history of burn with a such kind of image. What is the answer? This is well differentiated SCC, and this is also known as Marzolin ulcer. So what is a Marzolin ulcer? This is well differentiated SCC arising from a long standing either venous ulcer or a burn wound. So in this case, this is. Now why it couldn't be you can say a venous ulcer? It could have been, but the location would have been this Gator zone. So this is what is very, 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 very important. So this is a classical Marzolin ulcer that we have. An infected burn wound will not be like this. So you can see a growth here. So the option A is the best option amongst the things given. Elderly patient with dysphagia, halitosis and regurgitation. So why dysphagia, why halitosis and why regurgitation? You need to understand that around the Killian's dehiscence, basically Killian's triangle we have. Killian's triangle, there is a dehiscence which is known as Zenker's diverticulum. It's a pulsion diverticulum. Try to understand, this time they have not mentioned the word Zenker's diverticulum. Diverticulum or diverticulosis. So they are of two types. One is true. The true one is known as traction, and one is the pseudo. The pseudo one is known as pulsion. So what are the two pseudo pulsion or you can say defects that we have in esophagus. Either it could be a Zenker's diverticulum, which is also known as cricopharyngeal eclasia, or students, the another one is epiphrenic. When we talk about the pulsion diverticulums, what are the pulsion diverticulum that we have? We had parabronchial, or the another term that we use for this is mid-esophageal. So if you see why there is halitosis, because the food enters here. Why the food enters here? Because this is upper esophageal sphincter. Whenever you eat anything, there is first relaxation of this upper esophageal sphincter. So normally if this sphincter is closed, the food often enters here. When the food often enters here, what happens? The sac becomes heavy and it intends on the posterior wall, resulting in the same concept of dysphagia. So dysphagia, regurgitation, and by halitosis, the putrefaction of the food in the sac. So this is a pulsion diverticulum. This is what is very important. Students, always remember achalasia cardia and CA esophagus and GERD, they have both dysphagia and regurgitation, but halitosis is not written. Halitosis is not mentioned. Had halitosis not been there, students, you would have required lot of things like a CT to confirm esophagus, like pH monitoring to confirm, or MII pH monitoring to confirm the GERD, and a manometric assessment for the achalasia. Gone are the days when just on the clinical presentation you used to suspect the esophageal lesion. To confirm them, you have your different investigations that we have. Next is patient after Billrod 2 gastrectomy operation. So patient has undergone Billrod 2. What is Billrod 2? Either you can go for the post gastrectomy if you talk about, this is loop gastrojejunostomy, or students, you can also have it like this. So what is this? These are two loop anterior gastrojejunostomy. So patient presents to you with diarrhea within the 15 minutes. Why this happens? Because now the food directly enters into the, you can say, intestine. Along with that, the acid is going directly into the intestine, neutralizing the pancreatic juices. So the first thing that we have to understand, there are two concepts. One is you are looking at the dumping syndrome, and one is you are looking at the post-gastrectomy diarrhea. So post-gastrectomy diarrheas are either because of dumping syndrome or because of the acid neutralization. Both of them will improve with the time if you do some lifestyle changes. So we will not convert this Billrod 1 to Billrod 2 to Billrod 1 and Roux-en-Y gastrojejunostomy. No. Insulin is not required here. What is one very important thing? Small frequent meal is and low carb diet. Students, increased protein in the diet is not going to change the thing. It's a low carb, small protein diet. Rifaximin, if it doesn't work, injection octreotide is also given. So option A is very important. If it fails, then only you will go for option B. So small, you can say frequent meals with low carb content, PPIs. The third is, yes, if that doesn't work, you have to go for one very important thing, that is injection octreotide. If that also fails, then you will have to either go for a bronze procedure, that is conversion of those loop gastrojejunostomy. Along with that, you will do a side-to-side jejunostomy. That is what is a bronze, or if still, then you will have to convert it into Roux-en-Y gastrojejunostomy. So option A is right in this. Delayed wound healing in a minor surgery is due to deficiency. You know, zinc and silver are very important agents for healing, and it is zinc which is the answer here. So zinc is very important than D. So vitamin C is important, vitamin A is important, vitamin D is important, but yes, right now zinc is very important. So zinc is the answer that is required here. Now the gas used in abdominal laparotomy, no, it is not. Someone who has recalled this, it should be laparoscopy, and we don't require an abdominal to be written here. Why? Because lapro itself means abdomen and tomy means to open, and scopy means to explore it with an endoscope. So remember the word laparotomy, we don't require any gas. If it is laparoscopy, yes, what is the gas of choice? CO2 is the preferred gas of the choice. Students, all of them are used. So CO2 is preferred. Why CO2 is preferred? Because it is cheap. The second is it is odorless. The third is it is non-combustible. Students, when you talk about the nitrous oxide, yes, it is preferred for diagnostic purpose. Why it is preferred for diagnostic purpose? Again, it is cheap, it is odorless. I would say with respect to CO2, it is mid costly, but the drawback is it is combustible. One advantage is that Since it's a nitrous, it has that analgesic effect. Now when you talk about oxygen, it is not used. Why? Because oxygen can cause, yes, explosions when you use what? Classical diathermy. Whenever you use energy instrument, oxygen is not used. Helium is the most inert gas, and nowadays it is preferred for oncosurgery. So it is preferred for cancer. So lap oncosurgery, nowadays we prefer this. So don't think, if I have to ask this question, I can change this question to which gas is not used during this laparotomy. So I would have marked oxygen. So nitrogen is also not used. Nitrogen and oxygen are not used. You can use even room air. You know, all the new generation insufflators, they have a sensor. So if the gas, imagine you are doing a surgery and the gas goes off, then what you will do? You will cry and convert it into open. So they have an automatic sensor which will take the air from the, you can say, external air. That is, you can attach a supply also of the air, or they will take the room air also and help you actually buy some time to finish the OT, or plan a change the cylinder. Or if you have asked your assistant, okay, get it from my car, or get it, you made a call to the gas agency that quickly send it within 10-15 minutes, you can manage this way. So this is what is. So even room air can be used in such cases. A patient came with pain in the right iliac fossa. So this is the site of the pain. Palpable lump in the right iliac fossa. So there is a lump and pain. Blood investigation shows increase in TLC. Increase in TLC, what is the management? So you are heading towards acute appendicitis. Now along with this, you have a substantial evidence that there is a lump. Now whenever there is a lump, why this lump happens? Because of the conglomeration of what, students? Bowel. So acute appendicitis, the next thing is there any palpable lump? So when there is palpable lump, if it is yes, then you will have to go for a conservative management. What is conservative management? Broad spectrum antibiotics, fluid and supportive care. And this regimen is known as Ochsner-Sherin regimen. This is what is very, very, very important. Now this doesn't mean that, okay, if the patient doesn't get improved with the symptoms, you will continue with this. So when you do this, you have to reassess after 48 hours. When you do the reassessment after 48 hours, what is the next thing that we need to do? If the patient improves, what is the next thing, students? Yes, discharge the patient. And if the patient improves, I am talking about, discharge the patient. If the patient worsens, then you will have to plan a midline laparotomy, because you might require even a, you can say, right hemicolectomy in this case. If there is no palpable lump, yes, you can jolly well go for laparoscopic appendicectomy. Laparoscopic or open appendicectomy. Nowadays, open appendicectomy is a curse. No one is doing, students. So it's an Ochsner-Sherin regimen. Alvado's regimen, there is no such regimen. It's a, you can say, a criteria. Alvado's criteria is a criteria for diagnosing the acute appendicitis clinically and based on the biochemical investigation, not the radiological evidence. Getting? So we have pain in the right iliac fossa, we have fever, we have you can say patient presenting to you with anorexia or nausea, vomiting. So all these terms are kept. Then elevated TLC and a left shift of the neutrophil curve, or maybe the increase in CRP, which is modified Alvado's now. Next is what is the site for insertion of the needle in the thoracocentesis? Always remember, along the lower margin of the rib, there are intercostal nerve bundles. So whenever you want to plan it, you always have to plan it along the grazing along the upper margin of the rib. So it is upper border of the lower rib. This is what is the answer. So upper border of the lower rib is the right answer. Why? Because if you go too high in the middle or in the upper border, if you go more up, higher up, so you will catch the lower border of the consequent upper rib. So always remember, grazing along the surface of the rib on the upper border. This is what is very, 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 very important. Next is a patient came to you with bleeding in the lungs. So there is basically, this is a RTA patient with the hemothorax. So when you talk about hemothorax, the next thing is, okay, what to do now? 1800 ml of the blood was lost in the chest tube. So whenever we have a hemothorax, the next strategy is tube thoracostomy. So when we talk about tube thoracostomy, the very next thing that we need to understand is what is the output. So if the output is more than 1500 ml, in case of blunt trauma. So here it's not mentioned whether it's blunt or penetrating, or more than 1000 ml in penetrating trauma, or students more than 200 ml per hour for 3 consecutive hours. This is what is an indication for urgent thoracotomy, not thoracostomy. So thoracotomy should be the answer here, because God has already taken a call for this patient. If you don't take a call, you will lose the patient. Now, investigation of choice for a varicose vein, it's a very important. So whenever we talk about venous system and when we talk about lower limb venous system, so what is an ideal investigation? So it's a Doppler scan. So Doppler scan, this is what is, so duplex or Doppler, plethysmography is not required here, MR venography shall be over investigation for this case. So Doppler scan is having high sensitivity, specificity and accuracy. Next is, what is the material used for Lichtenstein mesh? So what is a Lichtenstein mesh graph? I have very commonly taught this topic. Hernia is one of my favorite topic. I teach laparoscopic hernia. So be it lap hernia, inguinal hernia, be it open inguinal hernia, the quality of mesh that we use is polypropylene. So polypropylene, proline mesh, that is what is proline mesh. Why it is used? Because first of all, it is hydrophobic mesh. What is hydrophobic? It will, like when you have polyglycolic is the suture that is absorbable. So you need a non-absorbable mesh. Ideal mesh is non-absorbable. So polygalactin is also absorbable. So there is no such use. However, in composite mesh that we use for the ventral hernias, we use a complex mesh or composite mesh where we incorporate polygalactin, like Vipro we have, or we have polyglycapron also. We have polyglycapron. The polyglycapron is monocryl along with the proline. So at least you need a non-absorbable material. So either it's a proline, that is polypropylene, or it is a polyester. Both the meshes are non-absorbable, but the drawback with polyester is, this is what is very important, that polyester meshes, they are hydrophilic, and when something is hydrophilic, students, the problem is that the chances of contamination are high. I forgot to read the comments. Okay, so fever was also there, na? So yes, Pawan, Vivek, if the patient is having the fever in that last question also, it is acute appendicitis. I hope, sorry for ignoring your comments. Okay, no, it's not recorded, I am live. I just forgot to see the comments. Okay, I just forgot to see the comments. Okay. So I will be looking at the comments also right now. Okay. So did you get this question? So the answer for this is polypropylene mesh. So polypropylene or proline mesh, this is what is ideal. Always remember, because I was not looking at the comments, that is why you people must be assuming that it is recorded. And then one added thing to this is, what should be the ideal size of the mesh? So whenever we talk about the ideal size for any mesh, defect plus 8 to 10 centimeters, this is for open hernia, and for laparoscopic hernia, it should be defect plus 10 to 12 centimeters. Why? At least 4 to 6 centimeters of area around the mesh should be, around the defect should be covered, because as the healing happens, there will be fibrosis. So now I will be just looking at your comments. Sorry, sincere apologies for that. Next is, if you have any doubt in the previous question also, you can ask me. Okay. Patient had RTA and brought with bradycardia along with high BP. The GCS came to be less than 8. Student, forget everything. When we talk about the classification of head injury on the basis of the GCS, so what are the important things that we need to understand? We have mild, we have moderate, we have severe, and there is one more category, that is minor. So when we talk about minor, it is defined as GCS 15 out of 15. Then mild is GCS 14 to 15 out of 15. Now you must be thinking, sir, what is 15? So always remember, 15 by 15, if there is association, if it is associated with history of loss of consciousness. So if the patient says, okay, right now he's telling you everything, but he told that when this happened, I lost the consciousness, I couldn't get it, what happened for next 10-15 minutes. So this is what is a mild. Then we have moderate, GCS 9 to 13 by 15, and what is severe? GCS less than equal to 8, that is 3 to 8. What is this question? What is this GCS less than 8 meaning? Always remember, any severe head injury, the patients are considered to be the patients in coma. What do you mean by coma? Coma is a state when you cannot support spontaneous ventilation, and that is the reason why any patient less than 8, they require urgent intubation and ventilation. Of course, other things are okay, but CT can be done only when the patient is hemodynamically stable. So intubate the patient. This is what is very, very, very important. Tanay, you can just text me, or you can just text at the end what were the questions, because Tanay, I have not given the paper, so practically I might have not been able to justify this thing. So yes, based on the questions I got, I am just recording it for you. Now, a patient presents to you with blisters which has a woody surface and is extremely painful. This is a classical case, looking like all these things are kept in a what you can say, in a differential diagnosis, but it cannot be a DVT, because in DVT we generally don't see such kind of presentation. Blisters are not there, but yes, in the late stages, when we talk about phlegmasia cerulea dolens, you might have, when the patient has developed a gangrene, then this patient might develop. When we talk about a gangrene, if you talk about gangrene, there will be some, you can say, some line of demarcation in the gangrene. So it would not be like healthy part here and dead part here. It would have been dead here also, because this is the most distal part. Yeah. The next thing that we need to understand, woody. This is what is very, very, very important. This woody presentation is the classical that we get to see in cellulitis also and necrotizing fasciitis. But in necrotizing fasciitis, we have this boggy swelling also. So cellulitis, clinically, since the information is not provided, cellulitis is far better option than necrotizing fasciitis. Necrotizing fasciitis starts with a deeper layer and there will be pus. So this woody tendency was not there. So this image was there? No, Tanay, this was not there. So okay, so this is what is, B is better than C. B is better than C. I hope that's clear to everyone. Yeah. Was this image there or no? Okay. Next is, a patient with aortic dissection involves the hiccups. This is due to what irritation? So first of all, bache, aorta, if it is irritated, why will you have hiccups? It is because of the irritation to phrenic nerve. This is what is, spinal accessory is going to supply to your trapezius. That will be a different thing. That will be a pain radiating to the scapula or tip of the shoulder. But it is a very easy question. It's a phrenic nerve which is going to cause this. Best investigation to understand the renal perfusion, students, MAC3. So we have MAC3. This is what is very, very, very important. So DMSA is for the structural assessment, and MAC3 or DTPA scan, MAC3 or DTPA scan. Oh, I'm glad that thought, okay, cellulitis is right for this. So MAC3 and DTPA scan are for the renal perfusion. DMSA scan is for the structural assessment. Retrograde RGU, this is for the urethral injury, and CT urography is for bladder trauma. So I hope you know that the answer here is A. Bladder trauma is going to be related to CT urography. Next is, a patient with cystic swelling in the floor of the mouth, in the, you can say, in the capsule which we have revised, the AIMS ATS series, that INICT, I'm saying INICT, that FMGE ATS series. There I have shown this image, floor of the mouth with bluish red, transillumination is positive. What are you looking for? Ranula. And remember, dermoid cyst, it is non-transilluminant. It is non-transilluminant, point number 1. The second point is, it is also whitish. Are you getting this? So it is not a sublingual cyst or sublingual, basically sublingual cyst is a broader term which you can say. Okay. So Mr. Lal was saying, sir, for the cellulitis question it was mentioned, swelling goes beyond the red. Students, it's a ranule. In this case, it is more of what? Cellulitis than necrotizing fasciitis in this case. However, students, they are all interconnected things. Cellulitis is a superficial presentation. Necrotizing fasciitis starts with the lower surface. So there, the edema is below, or you can say the abscess formation is there.
So the tissues are doughy and boggy. They are not woody. The word woody with such kind of blister-like presentation means that it is starting from the superficial part. Next is, so kidney stones removed, the patient, now I want to ask you about the correct options for this. So kidney stones were removed, patient presents with flank pain after 4 to 5 years. Now 4 to 5 years the patient is having flank pain with a foreign body on the imaging. So this is a DJ stent, I don't know this was the image or no, with a foreign body here. So what you have to go for, it should not be cystoscopy, it should be URS. So ureteroscopic retrieval. Yeah, remember, why will you go for laparotomy and why will you go for cystoscopic removal? So this option is, I think this option is itself doubtful. So someone who has recorded this doesn't know that the laparotomy is open and cystoscopy is the conservative version, is the endoscopic version. So this option doesn't mean. RGU is the diagnostic test. Why will we leave a foreign body inside? Try to understand. So if this was the image, you will have to go for ureteroscopic removal or a rhinoscopic removal, nothing other. So I think it should be endoscopy, not cystoscopy, because if you talk about cystoscopy, it will only go to bladder. It will not be able to go to the ureteric level. So this is at the level of PUJ or maybe the just proximal 1/3 of the ureter. So if this was the image, it should be endoscopic removal of the foreign body. This would be the most probable answer. I have corrected this. Yes. So I hope you understood the concept. What should be? I don't know about the correct options. I have just corrected it for you people. So next is, what are you getting this? Again, a bladder with benzidine exposure. This is an increase. There is an increased risk of what? Carcinoma, bladder, and this is nothing but urothelial cancer. So when you talk about urothelial cancer, what is the next step? You are going to go into the bladder, resect it off. Why we resect it a bit deep? Why we resect it deep? Because we want to know the diagnosis. Not only diagnosis, we want to know the grade, and along with this, we also want to know the status of muscle invasion, and that is why we go right up to the junction of urothelium with the muscle, and this is what is known as TURBT, transurethral resection of bladder tumor. Cystoscopy was mentioned in both the options. So, bache, how will you remove this with cystoscopy? Cystoscopy is not the, okay. So now just try to understand. So if this is the cystoscopy, then this image is wrong. Why? Because this is a patient underwent the kidney stones. Now you are looking at the what? DJ stent. So if the options, now I have the confidence since you people have told. Now this is an incidental stone. Don't look at the stone. If this is there, so incidental stone, there is an incidental stone. So if there is an incidental stone, you will go for ureteroscopic removal for the stone, And when you talk about the foreign body, it is the DJ stent. So you will go for cystoscopy and removal of the stent also. But had I got this image, I would have also looked, okay, there is a stent, that is different. But there is a remnant of the stone also. So I would have gone for URS. When doing a ureteroscopic removal, I would have removed the stone also and I pulled out the stent also. Are you getting? This is what is. But anyways, if you have confirmed that this was the image, so DJ stent was there, patient might have not returned back, because many a times once you do a PCNL, you don't, many of the times the patient doesn't turn up to you. You have put a stent to avoid the post-operative edema related obstruction of the urinary tract. And the rule is you have to call the patient after 10 days and say, okay, come, and in OPD only we'll insert a cystoscope and take out this tube, that is DJ stent. Patient might have missed it. So in this case, yes, Tane, if this was the option, then cystoscopic removal of the foreign body. So yes, it is right, cystoscopic removal if this was the image. And if you are saying that, okay, endoscopy word is not written or ureteroscopy is not written, so cystoscopic removal of the foreign body means that you will pull with a cystoscope, you will pull out the classical DJ stent which has been left over. I hope you got, so I was just waiting for you people to tell me the right options. So when you talk about this, you will go for transurethral resection of the bladder tumor. This is what is very, very, very important. Students, radical cystectomy will be done only once the diagnosis is there. Here you don't have anything. So it should be TURBT, not TURP. Why? Either you write TUR, transurethral resection. If you are writing TURP, that means for prostate. So this is a bladder tumor, that is not. IV BCG will be given, intravenous BCG will never be, or intravesical BCG will be given when you have post TURBT high grade or maybe carcinoma in situ. Do refer to my lectures on ANAESTHESIA for the bladder tumors. I have beautifully described the correct regimen that we follow. So whenever we have a suspected patient with painless hematuria, we go for the cystoscopic evaluation of that, along with that urine for cytology. Once we see something, we have to go and resect it off to check what it is, whether it is muscle invasive or not. If it is muscle invasive, then you will have to go for cystectomy. If it is not, then you have to plan intravesical chemotherapy or intravesical BCG. So intravesical BCG will only be done once you have the diagnosis that it's a grade 3 or a carcinoma in situ. Are you getting me? This is what is very, very, very simple. Next is a patient with thyroid malignancy, serum calcitonin was found to be very high. Leave everything. The answer is medullary thyroid cancer. It's a very easy question. Now 6-year-old came with midline swelling which moves with protrusion of the tongue. Protrusion of the tongue. So midline swelling which moves with deglutition, Answer is the thyroid swelling can also move with this, and the thyroglossal duct can also move with this. But when it comes to protrusion of the tongue, it is the thyroglossal duct which is connected, or its remnants are connected by a fibrous cord with the base of the tongue, because the origin of the medial enlarge and thyroglossal duct is same. So what is the surgery? En-bloc cystectomy. En-bloc cystectomy. What is en-bloc cystectomy? This is what is very, very, very important. Yes, that is cystoscopy with the removal of tumor. Okay. So if students, if let me tell you, if it is TURP and cystoscopy, these two are the options. B will be the answer, not the C, because it should be TURBT. I hope, Somi, was it TURP written or TURBT written? If TURP was written, then TURP will never be the answer. It is, then the best answer would be cystoscopy and removal. Had it been TURBT, so it should be TURBT either. So I hope you people will tell me, because you people have given, was TURBT given? If that was given, that should have been the answer. So what is en-bloc cystectomy? Removal of the cyst, and along with that, along thyroglossal duct cyst, and along with that you will also remove the central part of the hyoid. Are you getting this? This is what is very, very, very simple. So you people will tell me whether TURBT was there or no. In esophageal cancer, the post-radiation weight loss is due to esophageal fibrosis. And why? Because this is going to lead to loss of peristalsis. Loss of peristalsis due to fibrosis will cause dysphagia, and this is very, 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 very important. Again, so all of them can happen, but GERD is not the reason. So it is A which is very important answer here. No other answer can justify. So if TURP Mr. Lai was there, so then this should be, the option should be B, cystoscopy with the removal of the bladder, that is bladder tumor, that is known as TURBT. In intraoperative blood loss, if there is intraoperative blood loss, what is the fluid that should be given? Already remember, during the surgery you are giving the saline, so now already the patient is losing the blood. The best replacement is blood with blood. This is what is very, 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 very important. What is this salt solution? It's not lemon water, lemon soda. So it is A in this case. It's a very easy question. Now what is the layer which is not there? So esophagus, you know, it is having submucosa and mucosa. So submucosa is there, then muscularis is there. So mucosa, submucosa, muscle, and after muscle they have adventitia. But what is not there? Serosa is not there. Since serosa is not there, that is why esophageal tumors go first initially outside, and by the time they grow into the lumen and occlude the lumen, they are considered to be late. Had serosa been there, that's a packing that would have contained this tumor growth or restrained this tumor growth outside. So dysphagia would have been early feature if serosa would have been there. Serosa is not there, that is the reason. So serosa. Next is a patient on RTA presents with unconscious says BP is normal, NCCT. I hope I couldn't get this image, but I have heard that the image which I have seen from various social medias, students have shared it on various social medias. It was an EDH image that was there. So epidural biconvex. Now you people can put your input in that. Was it epidural or no? So was it biconvex? Elderly male with urine hesitancy and retention of urine. So retention of urine and urine hesitancy. What are they? Lower urinary tract symptoms. with AUR, acute urinary retention. Ultrasound shows residual urine. So, this is sufficient to understand that this patient is having something like BPH or maybe CA prostate. This is what is very important. What should be the next line of action? The next line of action should be urgent Foley's catheterization. So, that is not there. And along with that, you have to start with the classical 5-alpha reductase. Along with this, 5-alpha reductase is not going to give that immediate relief. You have to go for alpha blockers. So, alpha blockers are not there in the option. So, if this was a scenario, 5-alpha reductase inhibitor, that is maybe dutasteride, maybe finasteride, along with that, the sildosin, aldosin, alfuzosin, these are the classical drugs that will go for. So, this would have been a better answer in this case. But I don't know, maybe the options are incomplete, but yes, 5-alpha reductase is not going to give you the immediate, you can say, solution with respect to the urine retention, because BPH is nothing but is a stromoglandular disease where there is a mechanical adynamic obstruction because of the tumor, and dynamic obstruction is because of the increased alpha receptors. So, if you need to have a quick relief, you have to add the tamsulosin. So, this is important. But if you have to have that sustainable relief, you have to have 5-alpha reductase, which will reduce DHA, and DHA will reduce the stimulation on the prostate. This is what is very important. Lady with the breast lump with PUD orange occupying more than 2/3, try to understand. PUD orange means what? Skin invasion? Yes, it is a skin invasion. That is because of the, so what is PUD orange all about? So, these are the dermal lymphatics. So, dermal lymphatics are blocked with the tumor cells, and that is why you have subcutaneous edema, and that is what is T4B. Now, T4B includes edema, T4B includes the word ulcer, or T4B includes the word satellite nodule. So, they are very important. This is what is B. Next is lady with nipple discharge with duct ectasia. So, what is duct ectasia? It is nothing but involvement or inflammation of multiple ducts, and radial excision or cone excision is done. So, what is this cone excision better known as? So, cone excision, Hatfield cone excision, Hatfield cone excision. This is what is very important. Microdocectomy is done for single duct. Try to understand duct ectasia usually involves multiple ducts. Even if it is not involving, it will involve. So, that is why the correct treatment is Hatfield duct ectasia, radial excision with shaving of the undersurface of the nipple, so that it doesn't occur, because it's a chronic subareolar abscess also in certain cases, but a mastectomy is not done for these patients. Next is, so image of a patient showing you a Gray Turner sign. So, Gray Turner or maybe Cullen sign, they are all, so Gray Turner, Cullen sign, along with that we have the Fox sign. They are all the signs of hemoperitoneum, and they may be associated with lot of conditions, but one very important abdominal pathology is acute pancreatitis, not the pancreatic cancer, it is acute pancreatitis. Portal hypertension, you will have that caput medusae. Cancer of the stomach, you will have Chester Mary Joseph. You don't get to see this, you get to see migratory superficial thrombophlebitis, but not hemoperitoneum. So, hemoperitoneum is seen in this. Next is, okay, so patient with head trauma with CT brain showing EDH with mass effect. Yeah, I think that was. If that is kya? No sir, niche tak tha kya? What is that? Which question? Modi ji? Oh, hi Modi ji, hi. Bache, bloody discharge, okay, Ujjwal, Ujita Pillai. If it is bloody discharge from a single duct, it would have been microdocectomy. So, if we talk about, if you are saying, देखो, I am just telling one thing. If you say that the question says bloody discharge from the single duct, if this is the scenario, students, always remember this is intraductal papilloma, which is the most common reason, and in that case microdocectomy should have been answered. Sir, ACE inhibitors or beta blockers is good for DM nephropathy induced hypertension, but beta blockers are contraindicated in diabetes. But we will take that question, medicine people, ask medicine people. I am not going to that, but yes, Dr. Dai, flank pain may be because of the hemoperitoneum developing. Now, if the patient has developed the Cullen sign or the Gray Turner, Cullen is around the umbilicus, Gray Turner is along the flank, so the answer is same. Because of the subcutaneous edema, there might be pain. Yeah, okay. there was clot near the urinary bladder and the groin area. Yes, bache, that is fox. Near the inguinal region. If it is near the inguinal region also, it's a fox sign. They are all related. Are you getting me? Anonymous, are you getting this? So fox, Cullen's, greater, they are all related with acute pancreatitis. Okay. और pancreatitis का option ही नहीं था. Then you will have to type the right question. If that was not there, yeah. So you will have to type the right question. So there could be, then this option is not right. So please, you have to mention the question again. I will check it out. Okay. I'll check it with the students. You people can type the right question. I'll come back to that also. No, now the question is CT brain showing EDH with mass effect. The next thing is you will have to do craniotomy. I think someone was suggesting me craniotomy option. This is immediate craniotomy. What are the indications for conservative management? The answer is clot less than 1.5 centimeter in EDH or less than 30 cc in volume, point number 1. The second is the midline, the clot, this is about the clot volume. Either the volume should be less or the size should be less, and the GCS of the patient should be more than 8. This is what is important. Now here the patient is having mass effect. So that is where you will always write the answer as craniotomy, not observation. 34-year-old with palpitation, headache, episodic hypertension. So what are you looking at? This is pheochromocytoma, suspected pheochromocytoma. Bache in pheo will have the classical thing of palpitation, headache, diaphoresis and episodic hypertension. Now you will go for urine assessment and plasma metanephrin first. If it is found to be related, you will go for a confirmatory test with 24-hour urine metanephrin. Adrenal adenoma will not have this because most of them are non-functional in this. So palpitation, headache with episodic hypertension, because in migraine hypertension cannot be you can say related. So this is B. B is the answer. What is this image all about? If you see, this is a classical image of lymph edema. Why it is lymph edema? Just see this. So the foot is involved. If it is venous edema, the foot is not involved. So this is what is a classical buffalo's hump. We have a buffalo's hump. What else? We have a tree trunk limb. So this is a lymphatic disorder. This is what is very important. So hemorrhagic Chetan, if the hemorrhagic pancreatitis was the option, then that's right. That's the same thing, severe acute pancreatitis or hemorrhagic pancreatitis. So you can understand that had it been something like this, you could have said that it could be venous edema. But say the foot is involved, that is lymphatic edema. This is what is very important. Patient had a surgery and post procedure there is a scar. Now if you see the boundaries of the scar, this is the site of the surgery. The scar or the tissue, this is a hypergranulation defect. So this is going above the margin also and beyond the margin. So this is a hypergranulation tissue, hypergranulation you can say disorder, where you have two things. Hypertrophic scar will never go, if you talk about hypertrophic scar, it grows above but it will not go beyond. This is what is very important. But if it is a keloid, it will always go above also and beyond. So this is what is a classical what scar? Keloid scar. Are you getting me? Second is, most of the time the hypertrophic scar do regress. So here they regress in 6 to 8, they start to regress in 6 to 8 weeks, since it has a long history of you can say a procedure, seeing the nature of the scar going above and beyond the boundaries. This is a keloid. Are you getting this point? This is, so option B is far better than C in this case. You know what is this? This is a Virus needle. So if you want to see Virus needle, you can always come to my center. You can go to my YouTube channel, see every day I do laparoscopic surgery. This is a classical Virus needle with an air inlet with a beveled end, so that yes, the bowel injury, once the needle goes inside the abdomen, is minimum. How we hold it like a dart. What is the advantage? It is a very fine lumen, so 1 liter per minute is the maximum gas rate that it can go into, that it can push into the abdomen. So the chances of rapid pneumoperitoneum induced stretching of vagal and vagal bradycardia, this is minimized. So this is where the virus is, and the chances of concomitant bowel injuries are also very less. What is this procedure? You know that this is known as a Pringles maneuver. What is a Pringles maneuver? It is nothing but occlusion of portal structure. So you are going to occlude the CBD, you are going to occlude the portal vein and hepatic vein. So whenever you have a patient with liver bleed, yes, either it could be hepatic vein, hepatic artery or portal vein. Do a Pringles. If the on Pringles the bleeding doesn't stop, because out of them you have occluded hepatic vein, hepatic artery and portal vein, it should have been hepatic vein in that case. Now hepatic vein, you can ligate that side. If the bleeding stopped, that means either the hepatic artery is there or portal vein this time release a hepatic artery. If the bleeding continues, that means it is hepatic artery ligated. If it is portal vein, always you need to repair. So you are seeing something which is known as a Pringles maneuver. So preferred, please answer this question, preferred fluid intraoperatively. Options were blood, NS, colloid. Okay. So that is very good. That is very good. I was also looking. If you say, if you see this question, intraoperative requirement of fluid, intraoperative fluid requirement. So if the colloid is the, you can say, is given in the option, always remember it is the first line fluid. Why it is first line fluid? Because it is going to counter the sudden intraoperative hypotension, because in every patient we don't take the blood. Try to understand, we don't keep the blood. So intraoperative fluid loss, what fluid has to be given? So already saline is crystalloid is being given. You have to, the first line fluid is always and always colloid, but yes, the best replacement has to be blood. So if the option says, if the question says the next line fluid, it should have been colloid, because blood will require some time to be cross-meshed to be readied. Are you getting? So according to sir it is blood, but I still think it was NS according to scenario. Try to understand, already the patient, whenever you try to use your brain, dealing, try to understand, whenever you are doing a surgery, the patient is already on salines, already on crystalloid. Are you getting me or no? So once the intraoperative bleeding starts, you have to replace it with something. Because saline is already, it's not like a normal scenario where the patient is having bleeding and you bring him to the hospital, the first line fluid will be crystalloid. Are you getting me? So intraoperative scenario is different, and a patient brought to ER is different. Already the patient is on the fluids. So now what to do? In that case, whenever you are doing a surgery, whenever I am doing a surgery, if there is intraoperative sudden bleeding, already the saline is on. It's not because without fluid. Have you seen anyone performing a surgery without fluid going on? Yes or no? And if it is superficial surgery, you will never require. If you are doing an abdominal surgery or any procedure, fluid will always be there. So try to understand. It was, so no question was preferred language. No, it's not about sorry, but you people, I am there to help you visualize that window. So in ER, if the patient is brought with history of RTI, with bleeding, the first line fluid will be crystalloid NS. Are you getting? If the patient is in the OT, already the patient is on crystalloid. So now you have to replace something to create that voluminous effect, and meanwhile you'll say, okay, boss, arrange for the blood leke aao fatafat. So there you have to rely on this colloid for that time. Okay? So till then, if it is most preferred fluid, it will always be nothing other than blood. Are you getting? So I hope you enjoyed the surgery session. Do continue watching the LN Next channel for the other recalls also. So exams are done, whatever has been done, leave it, enjoy your day, enjoy your life. Your life is very important, because this life, one life, and this will never come back. Till then, bye-bye.
Hi, welcome students to the next session of our discussion. और इससे पहले कि हम लोग आगे बढ़े, there are a lot of students which are with us right now. I just want to first of all congratulate you कि ultimately जिस एग्ज़ाम के लिए पिछले कुछ समय से बहुत सारी preparations चल रही थी, you are through with that exam now. And सेकेंड इज़ कि हाँ एंटिसिपेशन है कि रिज़ल्ट कैसा आएगा, और वो एंटिसिपेशन इसलिए भी है बिकॉज देर इज़ काइंड ऑफ अ मिक्स्ड रिएक्शन रिगार्डिंग द एग्ज़ाम. मैनी ऑफ द स्टूडेंट्स से पार्ट 1 बहुत लेंदी था, और शायद था भी बिकॉज द क्वेश्चंस वर मोर क्लिनिकली ओरिएंटेड, सो बिगर क्वेश्चंस टू रीड फ्रॉम. बट पार्ट 2 रिलेटिवली सेफ था. ओके, बट फ्रैंकली स्पीकिंग एग्जामिनेशंस में ये चीज़ें हमेशा ही रहेंगी. राइट नाउ व्हाट आई वांट टू डू इज़ वेलकम यू ऑल फॉर दिस सेशन. एंड इस सेशन में हम लोग बात करने वाले हैं क्वेश्चंस विच हैव कम अप इन द एग्जामिनेशंस इन फोरेंसिक मेडिसिन. नाउ फोरेंसिक मेडिसिन किसी भी एग्ज़ाम में एक हाईली स्कोरिंग सब्जेक्ट रहता है हमेशा, चाहे वो FMGE एग्ज़ाम हो, चाहे वो INICT का एग्ज़ाम हो, चाहे वो नीट PG का एग्ज़ाम है. एंड फ्रैंकली स्पीकिंग इस साल का जो एग्ज़ाम था FMG का अभी अपना परसों वाला, दैट वाजंट मच डिफरेंट. काफ़ी स्टैंडर्ड सेफ स्ट्रेट क्वेश्चंस थे. एक दो क्वेश्चंस जो आए हैं व्हाट आई हैव सीन फ्रॉम रिकॉल, वो काफ़ी अच्छे क्वेश्चंस भी हैं, हम उनके बारे में भी बात करेंगे. सो लेट्स बिगिन दिस सेशन. एंड बिफोर वी बिगिन दिस सेशन लेट मी टेल यू दैट क्वेश्चंस आर एंटायरली बेस्ड ऑन द रिकॉल्स, राइट. सो रिकॉल्स पे हो सकता है किसी क्वेश्चन की कुछ फॉर्मेटिंग या आपको स्टेम जो है वो ऐसा लगे कि नहीं ऐसा नहीं था, मे बी समथिंग डिफरेंट. दैट इज़ समथिंग दैट वी कैन एड्रेस इन द चैट बॉक्स. सो अगर ऐसे कुछ रहे तो प्लीज़ आप अपने कमेंट्स चैट बॉक्स पे लिख करके बताते रहें. ओके, सो लेट्स बिगिन विद फर्स्ट क्वेश्चन. द क्वेश्चन सेज ए 10-year-old बॉय विल हैव डैश परमानेंट एंड डैश टेम्पररी टीथ. ओके, नाउ जब हम पढ़ते हैं तो हम इसके लिए एक बड़ी सिंपल सी इक्वेशन याद रखते हैं, एंड द इक्वेशन इज एज -5 into 4 is equal to number of permanent teeth in mixed dentition. Right? Now इस क्वेश्चन को आंसर करने के लिए the one thing that we need to know is what is mixed dentition. And what is mixed dentition? Mixed dentition is the time period when both temporary and permanent teeth are present in the oral cavity. और वो time period कब से कब तक होता है? वो होता है 6 years to as early as 11 years. 6 years पे mixed dentition शुरू होता है जब पहला permanent teeth इरप्ट होता है, और वो होता है फर्स्ट परमानेंट मोलर. 11 साल पे मिक्स डेंटिशन ख़त्म होता है. वो कब ख़त्म होता है? जब लास्ट परमानेंट टूथ लास्ट टेम्पररी टीथ रिप्लेस होता है लास्ट परमानेंट टीथ से, और आखिरी टेम्पररी टीथ रिप्लेस होने वाला होता है कैनाइन एट द एज ऑफ 11. ओके, सो इफ वी लुक एट द क्वेश्चन, द एज ऑफ द बॉय विच इज गिवन इन द क्वेश्चन इज 10 years, right? Which means the boy falls within the age of mixed dentition. और mixed dentition में एक सबसे अच्छी बात क्या होती है? mixed dentition में total number of teeth remains same, और ये होते हैं 24. सो 6 से लेकर के 11 साल तक जो बच्चा है उसकी ओरल कैविटी में 24 टीथ रहेंगे. इट रिमेन्स सेम 24, which means if we use this equation, the equation which is written on the top, age minus 5, which is 10 minus 5 into 4, which is equal to 20, यानी कि 10 साल की एज में ओरल कैविटी में एक बच्चे के 20 परमानेंट डेंटिशन होंगे और टोटल कितना है 24, तो टेम्पररी डेंटिशन कितने बचे 4, राइट. 24 minus 20 is 4, which means correct answer is option A, which means correct answer is option A. अगर आप लोगों में ये क्वेश्चन का करेक्ट आंसर है तो प्लीज़ अपने चैट बॉक्स पे लिख करके बताएं. लेट्स टेक अप सेकंड क्वेश्चन. सेकंड क्वेश्चन वाज अ पिक्चर बेस्ड क्वेश्चन. हो सकता है एग्जामिनेशन में ये फोटोग्राफ शो करी गई हो सकता है इस फोटोग्राफ के साथ में रिलेटेड देयर मे बी सम मोर इनपुट इन द क्वेश्चन, बट फ्रॉम द रिकॉल्स दैट वी हैव हैड, the photograph was there. It showed this kind of a yellow bell shaped flower, as you can see, yellow bell shaped flower. And what else do we see in the photograph? If you look at the leaves which are present, the leaves are thin and slender and long. These are called as lanceolate appearance और lanceolate shape of leaf. lance की तरह, lance क्या होता है, एक बड़ा सा भाला. so lanceolate kind of appearance of leaves. This plant belongs to a very special category of cardiac poison. In common language it is called as yellow oleander. In common language it is called as yellow oleander, and the botanical name for this plant is Cerbera thievetia. It is Cerbera thievetia. Now there are two more plants which are given in the option. If you look at option number A, which is Neeram odorum, and option number D, which is Cerbera odolum, ये दोनों प्लांट भी कार्डियक पॉइजन कैटेगरी में आते हैं. प्लांट पॉइजन विच आर कार्डियक, ओके. और इनके ऊपर इनके पिक्चर्स पे भी क्वेश्चन आते हैं, बट सर्बेरा थिवेटिया इज द मोस्ट कॉमन. अगर आप इस प्लांट को देखोगे तो ये आपने कई बारी अपने घर के सामने पार्क्स में, गलियों में ये प्लांट देखे होंगे. पीले कलर के बेल शेप फ्लावर्स विद लॉन्ग लीव्स, सर्बेरा थिवेटिया, ऑल्सो कॉल्ड एज येलो ओलिएंडर, ओके, या फिर पीला कनेर, इसे कॉमन लैंग्वेज में पीला कनेर भी कहते हैं. अगर हम देखें बाकी दो प्लांट्स जिनके नाम ऑप्शंस में दिए हुए हैं, उनकी फोटोग्राफ भी इस समय हम याद कर लेते हैं. वन प्लांट इज कॉल्ड एज नीरम ओडोरम, अगेन अ वेरी कॉमन प्लांट दैट यू सी अराउंड योर हाउस होल्ड, ऑल्सो नोन एज द वाइट ओलिएंडर, बिकॉज इसके जो फ्लावर्स हैं वो पीले कलर के नहीं है, वो वाइट कलर के हैं. और जो दूसरा डिफरेंस आप देख पा रहे होगे फोटोग्राफ में इज दैट इसके फ्लावर्स का जो अपीयरेंस है वो बेल शेप्ड अपीयरेंस नहीं है. यू कैन सी डिस्टिंक्टिव 1 2 3 4 5 distinctive 5 different petals. It looks like a normal opening of a flower. 5 petals का flower होता है. This is Neeram odorum, also called as white oleander. और दूसरा प्लांट है Cerbera odolum, Cerbera odolum, also known as Pili kirbir. ये भी कार्डियक टॉक्सिन कैटेगरी का प्लांट है, जिसमें अगेन द फ्लावर इज 1 2 3 4 5 वाइट कलर. बट इस प्लांट की डिफरेंस क्या है, यू कैन सी दैट इट कंटेन्स अ फ्रूट विच लुक्स लाइक मैंगो. एक मैंगो की शेप का फ्रूट है. इसको भी कुछ लोगों ने अपने घर के पास या फिर अराउंड द ड्वेलिंग वेयर दे लिव मस्ट हैव सीन. द फ्रूट इज काइंड ऑफ सर्कुलर और ओवल, और इसका जो ऊपर का छिलका होता है वो बड़ा हार्ड होता है, थिक पेरिकैप. दिस इज कॉल्ड एज सर्बेरा ओडोलम पीली किरबिर. Okay, these two plants are asked very less, but Cerbera thievetia is commonly asked in examinations. Cerbera thievetia के फोटोग्राफ भी दिखाए जाते हैं. Cerbera thievetia के एक्टिव प्रिंसिपल के बारे में भी पूछा जाता है. एंड सरबेरिया थिवेटिया में एक्टिव प्रिंसिपल होता है सरबेरिन, उसमें एक्टिव प्रिंसिपल होता है सरबेरिन. ओके, इफ यू गो बैक वी कैन राइट इट हियर. द एक्टिव प्रिंसिपल in this plant is cerberin. Okay, let's move to our next question. A dead body is brought for post-mortem examination with stellate shaped gun shot wound and muzzle impression print. What can be the distance? So यहाँ पर क्वेश्चन बड़ा क्लियर है. क्वेश्चन जिस तरीके से रिकॉल में क्रिएट हुआ है उसमें हमें जो इन्फॉर्मेशन मिल रही है वो क्या है, दैट द वुंड इज स्टीलेट इन शेप एंड इट हैज़ अ मजल इम्प्रेशन प्रिंट ऑन द स्किन. नाउ मजल इम्प्रेशन प्रिंट का मतलब क्या हुआ? इफ आई हैव टू ड्रॉ लेट्स से a sketch of a weapon, so we know कुछ इस तरीके का दिखता है एक फायर आर्म. इस फायर आर्म का जो सबसे इंपॉर्टेंट पार्ट होता है वो ये है बैरल, एंड द फ्रंट एंड ऑफ द बैरल जहां से बुलेट एग्जिट करती है कॉल्ड एज द मजल एंड. नाउ इफ this muzzle end of the barrel is in contact with the skin, what will happen is when the gunshot will be made, the bullet comes out with such a force that there is a sudden recoil of the gun from the contact and then it hits back. This creates an impression of muzzle mark on the area of contact, right? So अगर muzzle imprint दिख रहा है तब तो कोई क्वेश्चन ही नहीं है कुछ और सोचने का. तब तो द आंसर इज़ वेरी सिंपल कि ये जो शॉट किया गया है विक्टिम उसको कॉन्टैक्ट रेंज से शॉट किया गया है. कॉन्टैक्ट रेंज हम किसको बोलते हैं? व्हेन द गन इज इन कॉन्टैक्ट विद द बॉडी ऑफ द विक्टिम. ओके, सो आंसर मजल इम्प्रिंट सुन के ही सिंपल सा है दैट इट इज ए कॉन्टैक्ट रेंज शॉट. ओके, it is a contact range shot, right? But let's utilize this time for understanding of the ranges of the shot. उसके लिए let me draw yet another weapon here. Okay, and we say that when a weapon is fired, what comes out of the weapon? Most important part is the bullet itself, and this bullet is revolving on its axis. जब ये बुलेट जाकर के टारगेट पे लगेगी तो ये बुलेट उस टारगेट में एंटर करेगी और जो वूंड होगा उसको बोलेंगे एंट्री वूंड, राइट? नाउ whenever a bullet is shot, not only the bullet comes out of the barrel, there are 3 more products which come out of the barrel, and these 3 products are number 1, fire. Okay. Number 2, smoke. And number 3, partly burnt or unburnt gunpowder particles. Okay, if these products they also reach the target, they will also have some impact on the target, right? If fire will reach the target, what will it produce? It will produce burning or सिंजिंग. सिंजिंग होता है झुलसा देना, तो या तो जलाएगी एरिया को या फिर झुलसाएगी एरिया को, राइट? सेकेंड इज स्मोक. इफ the smoke reaches the target, it will deposit on that area, it will produce blackening. जहाँ पर भी smoke deposit होगी वहाँ पर काला काला हो जाएगा, that will be a blackened area. Okay. Third is gunpowder particle. When these gunpowder particle come and they hit the body, they produce what is called as tattooing, right? So अगर तीनों प्रोडक्ट बॉडी पे आकर के हिट करेंगे तो क्या होगा, बर्निंग भी होगी, ब्लैकनिंग भी होगी, टैटूइंग भी होगी. अगर फायर बॉडी तक नहीं पहुंच पाएगी पर स्मोक और गन पाउडर पार्टिकल्स पहुंच जाएंगे तो क्या होगा, ब्लैकनिंग होगी और टैटूइंग होगी पर बर्निंग नहीं होगी. अगर फायर और स्मोक दोनों ही बॉडी तक नहीं पहुंच पाएंगे पर गन पाउडर पार्टिकल्स बॉडी तक पहुंच जाएंगे, उस केस में टैटूइंग होगी पर ब्लैकनिंग एंड बर्निंग विल नॉट बी seen. So everything depends upon where is the target standing from the gun, how much is the distance. For example, let's say our target is standing here, that is the contact range, the gun is in contact with the target. Now at this range, if the target is standing, he is bound to have the effect of fire also, smoke also and gunpowder also, which means this person will have burning, blackening and tattooing along with the entry wound on his body. Now what if the person is not standing in the contact range but he is standing here, right? Here also what we see is that fire is reaching, smoke is reaching and tattooing particle is reaching. Now here also he will have burning, blackening and tattooing, right? Now what if the person is standing here, which is beyond the range of fire but in the range of smoke? Now he will not have burning but he will have blackening and tattooing. And what if the person is standing beyond the range of smoke also, that is here? This person will only have tattooing. And if the person is standing even beyond the range of gunpowder particles, he will only have entry wound on his body, no burning, blackening and tattooing along the entry wound. Okay. So this is the principle. What do we see on the dead body along with the entry wound at the time of autopsy? Looking at that presence of those, burning, blackening and tattooing, we can comment about what could have been the range of fire. Now if you look at the first two ranges, that is the contact range here and the next range which is called as the close range. The first one is the contact, the second one is the close range. Now in both the cases, blackening, burning and tattooing is present. So if blackening, burning and tattooing is present, how can we say either it is contact or close? Now here lies the difference. In contact range, when the muzzle of the weapon is contacting the skin and the fire is made, the bullet comes out and the bullet creates a track into the body. Behind bullet, the fire, the smoke and the gunpowder particles also come out. Now fire, smoke and gunpowder particles, they do not have environmental space to spread because the muzzle is in contact with the skin. So they are also bound to enter into the track created by the bullet itself. The fire enters into the track, the gunpowder particles also enter into the track and the smoke, which is highly pressurized smoke coming out of barrel, जब वो ट्रैक में घुसना चालू करती है, this smoke finds a potential area to spread, that is beneath the scalp over the periosteum. ये smoke इस potential free area में घुसती है, थोड़ा सा spread करती है, and then it blasts off. This phenomena is called as blowback phenomena. तो हमने क्या देखा, कॉन्टैक्ट रेंज में एक फिनोमेना होता है, वो क्या होता है, ब्लो बैक फिनोमेना. और ब्लो बैक फिनोमेना के कारण कॉन्टैक्ट रेंज के जो वुंड होते हैं, एंट्री वुंड, उसमें एक ब्लास्ट होता है स्किन के अंदर, एंड दैट इज व्हाई एंट्री वुंड बहुत बड़ा सा फटा हुआ वुंड होता है, एंड दिस टिपिकली gives rise to this kind of a stellate shaped entry wound, right? So contact range में हमें और क्या मिलेगा, stellate shape का entry wound, जो कि हमें क्लोज रेंज में नहीं मिलेगा क्योंकि क्लोज रेंज में ब्लो बैक फिनोमेना नहीं होता. Now that's one difference between contact and close. The second difference is close range में weapon जो था वो body के contact में नहीं था. So whatever fire, smoke and gunpowder particles, those were coming out of the barrel, they have environmental space to spread. So whatever entry wound is created into the body, the burning, singeing and tattooing is seen around the entry wound, not in the track, right? So what do we see in contact injuries are burning, blackening and tattooing are in the track, the wound is stellate shaped, and in close range the burning, blackening and tattooing around the wound, and it is not a stellate shaped wound. And an important thing that we have already talked earlier, जो हमें कॉन्टैक्ट शॉट में मिलती है वो क्या होती है, मजल इंप्रेशन मार्क. ठीक है, तो कॉन्टैक्ट शॉट के हमें दो बहुत ही इंपॉर्टेंट आइडेंटिफायर्स ऑलरेडी क्वेश्चन में दिए हुए थे, विच आर स्टीलेट शेप्ड लीजन एंड मजल इंप्रेशन मार्क, एंड सो वी सेड दैट द आंसर वाज कॉन्टैक्ट वुंड. ओके, बट इन दिस सेशन अभी हमने बात करी कि अगर थोड़ा भी वेरिएशन होता क्वेश्चन में तो किस तरीके से आंसर बदल सकता है. सो अगर अराउंड द वुंड हमें कुछ बताया होता कि ब्लैकनिंग है अराउंड द वुंड, टैटूइंग है अराउंड द वुंड और वुंड स्टीलेट शेप नहीं है, देन इट कुड हैव बीन अ क्लोज रेंज शॉट ऑल्सो. राइट, चलिए आगे चलते हैं. लेट्स सी दी नेक्स्ट क्वेश्चन. ओके, अ डेड बॉडी इज रिकवर्ड फ्रॉम अ रिवर. द बॉडी हैज साइंस ऑफ एंटीमॉर्टम ड्राउनिंग and also has multiple cuts on flexor aspect of arm. What can be the cause of these wounds? Okay, so it looks like it's a very well kind of a crafted or a created question where two things are mixed in one particular scenario. Two things which are mixed are injury and drowning. Okay, from the recall what I could understand was that the dead body has signs of antemortem drowning. So it is already given that it looks to be a antemortem drowning. Some variations in recall says that a photograph was also given where some cuts on the flexor aspect of the forearm were shown, and some say no, photograph was not there, but it was specifically mentioned that there are multiple cuts on the flexor aspect of arm. Now, one thing which is very very important to understand in what has been given in the question is, number one, multiple cuts. They are not lacerations, they are not bruises, they are not abrasions, which means these are incised wounds and they are multiple. Okay, and second, they are on the flexor aspect of arm. They are not on hand or palm. So they are not here on the hand or palm, they are here on the arm, right? Now when we go back to our understanding of injuries, we must have talked about this in our class sessions also, because I usually talk about it. Right. Right now I have just got an idea that somebody has written, image was given, the wounds are very deep and there is no grip of grass or mud. Okay. So question का variation हो सकता है, हम उसको भी discuss करेंगे, don't worry. Okay. This is from Mr. LAI. हम इसको भी डिस्कस करेंगे, डोंट वरी. सो अभी जो मैं कह रहा हूँ वो ये है कि अगर मान लो दिस इज द क्वेश्चन विच हैड कम इन द एग्जाम, जो इस समय हमारे पास स्क्रीन पे फोकस्ड है, तो वो क्या कह रहा है, मल्टीपल कट्स हैं और ड्राउनिंग एंटीमॉर्टम सजेस्टेड है. ठीक है, तो ये मल्टीपल कट्स उसकी बॉडी पे कैसे आए. नाउ जो कट्स का एरिया बताया हुआ है ना, जो कट्स का एरिया बताया हुआ है और उसके साथ में अगर हमारे पास में कोई अदर इंफॉर्मेशन नहीं है, देन इन दिस केस द कट्स गो इन फेवर ऑफ सेल्फ इन्फ्लिक्टेड इंजरी. इट लुक्स लाइक द पर्सन वॉज इन्फ्लिक्टिंग हिमसेल्फ. सेल्फ इन्फ्लिक्टेड इंजरी का मोटिव क्या होता है, खुद को इन्फ्लिक्ट करना बट किसी और पे ब्लेम लगाना. ओके, एंड प्रॉबेबली he might have blamed someone and that might have created a tussle between the two and he might have been pushed into the water. So if this much information is given, this does not go with active defense wounds, because active defense wounds generally hand पे होते हैं, right, and they are very deep wounds, they are not shallow wounds. But on the other hand, let's forget this aspect of the question now and let's see now जो कि अभी हमारे एक स्टूडेंट ने बताई है और वो ये कह रहे हैं, image was given, so there was probably an image, okay, and the image had deep wounds, right, and no grip of grass or mud in hand, right, ऐसे ही कह रहे हैं ना, which means कि क्वेश्चन में probably ये नहीं दिया था that it is a case of an antemortem drowning. Then the question would have been, a body has been recovered from water and on inspection during postmortem examination there are deep wounds present on the flexor aspect of the forearm. What could be the scenario or what could be the reason? अगर ऐसा क्वेश्चन आपके पास आया है जहां पर पिक्चर में भी आपको डीप वुंड्स दिख रहे हैं, देन दीज डीप वुंड्स गो इन फेवर ऑफ एन एक्टिव सेल्फ डिफेंस. उस केस में सेल्फ इन्फ्लिक्टेड इंजरी ऑप्शन नहीं होगा. उस केस में दे विल गो इन फेवर ऑफ एक्टिव सेल्फ डिफेंस, दैट द पर्सन वॉज बीइंग अटैक्ड actively. In the process of being attacked actively, he must have risen his hands to push the weapon away and the weapon must have struck, few times on his forearms, cutting the forearms very, very deep, which means he was killed with an weapon before he was thrown into the river or the water source, and that means the drowning would be post-mortem drowning. And so the question would not have given you any signs जहाँ पर हम ये बता पाए कि ड्राउनिंग एंटीमॉर्टम थी, जो कि अभी हमारे दोस्त ने हमें बताया है कि कोई भी एंटीमॉर्टम ड्राउनिंग का साइन नहीं दिया हुआ था. ओके, सो इट ऑल डिपेंड्स अपॉन हाउ द क्वेश्चन वुड हैव बीन फ्रेम्ड. तो मैंने आपके लिए दोनों वेरिएशंस डिस्कस करे. अगर पोस्टमार्टम ड्राउनिंग दी हुई है और सिर्फ इतना लिखा है फ्लेक्सर एस्पेक्ट पे वुंड है, फोटोग्राफ अगर नहीं दिया हुआ है और वो सुपरफिशियल वुंड है, देन इट गोज इन फेवर ऑफ सेल्फ इन्फ्लिक्टेड इंजरी. बट अगर फोटोग्राफ में डीप वुंड्स दिख रहे हैं आपको और एंटीमोर्टम ड्राउनिंग का कोई भी साइन नहीं दिया है, इसका मतलब किसी ने उसे पहले अटैक किया है, वो उस अटैक की वजह से मरा है एंड देन उसकी बॉडी को पानी में फेंक दिया गया है, राइट। एंड सो दोनों ही केस में जो क्वेश्चन है वो पूछ क्या रहा है कि जो उसके हाथ पे इंजरी है वो कैसी हुई है। तो सेकेंड सिनारियो में जहाँ पर उसको अटैक हुआ है वो हाथ की इंजरी जो है वो है सेल्फ डिफेंस में आई हुई एक्टिव इंजरी, ओके। पैसिव सेल्फ डिफेंस की इंजरी क्या होती है? पैसिव सेल्फ डिफेंस की इंजरी होती है जब आपको कोई ब्लंट वेपन से अटैक करता है। तो जब कोई ब्लंट वेपन से अटैक करता है तो हमारा ऑटोमेटिक रिएक्शन क्या होता है, हम अपने आर्म्स को अपने सर के और फेस के सामने करते हैं, सो दैट द ब्लोज दे डोंट लैंड अप ऑन आवर हेड और फेस, सो द ब्लोज ऑफ द ब्लंट वेपन लैंड अप ऑन आवर फोर आर्म्स, दोज आर कॉल्ड एज पैसिव सेल्फ डिफेंस इंजरी, ओके। सो ब्लंट वेपन में सेल्फ डिफेंस पैसिव इंजरी, शार्प वेपन्स में सेल्फ डिफेंस एक्टिव सेल्फ डिफेंस इंजरी, ओके। सो डिपेंडिंग अपॉन हमारे एग्जाम में क्वेश्चन किस तरीके से फ्रेम हुआ था, दीज कुड बी टू पॉसिबल आंसर्स, okay. Let's go forward and let's encounter the next question. It is actually a very simple question. It is rather more towards the pharmacological side of the question. The antidote for benzodiazepine poisoning is flumazanil. Naloxone की होती है opioid poisoning में naloxone होती है. Atropine is in organophosphorus group of poisonings and physostigmine is for धतूरा. दिस इज वन टिपिकल क्वेश्चन जो हर साल एग्जाम में कम से कम एक आता ही आता है, एक एंटीडोट हर एग्जाम में हर बारी आता है, ओके. सो दिस वाज अ प्रीटी स्ट्रेट फॉरवर्ड क्वेश्चन. नेक्स्ट चलते हैं. MTP can be done up to 24 weeks for. Now this question is again very relevant question because this comes from a very recently amended act. This is MTP Amendment Act 2021, जहाँ पर upper limit of termination of pregnancy has been increased to 24 weeks for special category of women, okay. So MTP till 24 weeks for number 1 rape victims, number 2 incest victims, number 3 rape on children or sexual assault on children, number 4 mentally or physically handicap victims of sexual assault. So these are certain categories जहाँ पर अगर इनमें से कोई फीमेल है उनके लिए the MTP can be considered to be done till 24 weeks of gestation. So the correct answer here is option B, okay. Let's move to next question. Patient died and relatives said he had a tattoo but it was not visible on autopsy, okay. Which is the best location for check for evidence of tattoo? Now the question is saying that the patient who has died, he had a tattoo, okay, but autopsy पे tattoo नहीं दिख रहा है, okay. इस फिनोमेना को बोलते क्या है? इस फिनोमेना को बोलते हैं फेडिंग टैटू और disappearing tattoo, fading tattoo or disappearing tattoo, okay. So आई थिंक अभी अभी एक अपडेट आया है हमारे चैट बॉक्स पे और हमारे दोस्त कह रहे हैं जो क्वेश्चन था हमने पिछला किया था उसमें ऑप्शंस हैं सर्वाइवर ऑफ रेप, बी माइनर, सी फीटल एबनॉर्मैलिटी और डी फेलियर ऑफ कॉन्ट्रासेप्टिव. अगेन आई वुड टेल यू द आंसर इज सर्वाइवर ऑफ रेप. ओके, सर्वाइवर ऑफ रेप के केसेस में एमटीपी प्रोविजन अवेलेबल है इन केसेस ऑफ अप टू 24 वीक्स ऑफ जेस्टेशन. ओके, और कौन से केसेस में हो सकता है? इंसेस्ट के केसेस की जो विमेन है उनकी अगर सिचुएशन है तब हो सकता है. मेंटली एंड फिजिकली हैंडीकैप फीमेल्स एंड पीडियाट्रिक चिल्ड्रन. ओके, माइनर के ऑप्शन में मत फंसो. माइनर मीन्स लेस देन 18, नॉट नेसेसरली अ पीडियाट्रिक एज ग्रुप. ओके, सो करेक्ट आंसर उसमें रहेगा सर्वाइवर ऑफ रेप. ठीक है. हाँ, इसके लिए डॉक ने करेक्ट आंसर दिया है. जो करंट क्वेश्चन हम कर रहे हैं रिगार्डिंग टैटू, दैट इज ऑप्शन नंबर सी, लिम्फ नोड. बट देखते हैं कि हम इसमें बात क्या कर रहे हैं. सो एज आई एम सेइंग, इस क्वेश्चन में हम बात कर रहे हैं समथिंग रिगार्डिंग कॉल्ड एज फेडिंग टैटू या फिर डिसअपियरिंग टैटू और डिसअपियर्ड टैटू. सी द थिंग इज, टैटू इज नथिंग बट डिपोजिशन ऑफ इंक इन अ पैटर्न सबडर्मली. सो एपिडर्मिस के नीचे जो होगा वो सुपरफिशियल है और जो डर्मिस में इंक पेनिट्रेट कर गई है वो थोड़ा डीप है. सो इफ द टैटू इज लिमिटेड टू द एपिडर्मल लेयर ओनली, विद ऑनगोइंग टाइम एपिडर्मल इरोजन के साथ में वो खुद ही फेड ऑफ होता रहता है. सो इफ यू विल सी दैट अ पर्सन डेवलप्स अ टैटू टुडे और उसमें डीपर इंक पेनिट्रेशन नहीं है, इट इज लिमिटेड टू द एपिडर्मल लेयर, इट विल नॉट बी अ चांस टू से कि 8-10 साल के बाद में वो फेड ऑफ हो जाएगा. तो धीरे धीरे हर साल वो थोड़ा थोड़ा फेड होता रहेगा. दिस इज कॉल्ड एज फेडिंग टैटू. फेडिंग टैटू को अगर हमें ठीक से देखना है तो हमें क्या करना होगा? फेडिंग टैटू कैन बी विजुअलाइज्ड विद UV light, infrared photography of the area, it can show a fading tattoo very well, and then rubbing the area to enhance the tattoo and watching with लेंस, उससे भी दिख जाता है. ठीक है. तो अगर थोड़ा फेड हो रहा है तो दीज आर सर्टन टेक्निक्स जो हम ऑटोप्सी में यूज कर सकते हैं एक टैटू को थोड़ा बेटर विजुलाइज करने के लिए. बट व्हाट इफ टैटू दिख नहीं रहा, डिसअपियर हो गया है? सी व्हाट हैपेंस इज, इवन इफ द टैटू वुड हैव बीन गिवन into the dermal layer, over a period of time the lymphatic drainage of that area keeps on dissolving the ink of the tattoo. जो lymphatic drainage है वहाँ की, the phagocytes they eat up the ink of the dermal tattoo also. So probability है कि काफ़ी सालों के बाद में वो dermal penetration tattoo भी vanish हो जाए या बहुत ही कम दिखे या ऑलमोस्ट डिसअपेयर हो जाए. बट उस केस में वो जो लिम्फेटिक ड्रेनेज हो रही है उस एरिया की, वो जाकर के जो लिम्फ नोड है उस एरिया का, वहाँ पर वो इंक कॉन्सेंट्रेटेड होगी. सो इफ़ वी आर गोइंग टू और वी आर लुकिंग टू फाइंड प्रेजेंस ऑफ एन ओल्ड टैटू इन एन एरिया, जो कि इस केस में बताया है कि रिश्तेदारों ने कि वहाँ डेफिनेटली टैटू था पर अब नहीं दिख रहा, विच मीन्स द टैटू हैज़ डिसअपियर्ड. And if we are going to dissect the locally present lymph node of that area, the concentration of the ink of the tattoo can be seen in that lymph node, and so the correct answer is कि उस tattoo को identify करने के लिए हमें क्या देखना पड़ेगा? We'll have to see the lymph node of that area. Okay, that's how the relevance of the thing is. Okay. Next question. Police recovers beheaded skull, the relatives of a missing person gives the photograph of the missing person to police. These two samples can be analyzed with which technique? Again a very straightforward question. ये नॉर्मली हम लोग काफ़ी बारी पढ़ते हैं अपने स्टडी के दौरान. पुलिस को एक beheaded skull मिला है तो we have the skull available. एंड सेकेंड इज़ कि जो रिलेटिव्स हैं उन्होंने फोटोग्राफ दे दिया है मिसिंग पर्सन का. अब अगर हमें ये आइडेंटिफाई करना है कि जो स्कल है वो उसी मिसिंग पर्सन का है जिसकी तलाश हो रही है, सो व्हाट कैन बी डन digitally is that the photograph of the missing person can be superimposed on the skull, of course with computerized technique digitally, to see if the bony prominences of the photograph matches with the bony prominences of the skull. This technique is called as superimposition. This technique is called as superimposition. Remember, superimposition is an identifying technique where a skull can be matched with the photograph of the person who is missing, and if the photograph superimposes correctly on the found skull, then the dead body whose skull has been found can be attributed to the person who is missing. And it can only be done with skull. Superimposition किसी और बोन के साथ में नहीं होता, ये सिर्फ skull के साथ में होता है for identification. Right. Next question. A case of road traffic accident presented with EDH, extradural hemorrhage. Where will be impact of collision? Pterion में angle of mandible, lambdoid suture, fourth option it could have been anything else, but हमारा आंसर इसी ऑप्शन में आ चुका है. हमारा आंसर है, if you see, let's say a skull, right? I am showing you the lateral aspect of a skull. It contains an area of fusion of four bones. We have parietal bone, we have temporal bone, we have frontal bone, and we have greater wing of sphenoid. This area of fusion is called as pterion. This is considered the weakest part of skull. In fact, टीरियन इतना वीक होता है कि डायरेक्ट ब्लो तो टीरियन का फ्रैक्चर कर ही सकता है. इफ देर आर heavier blows given on the top of the skull or on the back of the skull, even that can cause damage to pterion. ये इतना weak portion होता है skull का. Just beneath pterion is a division of middle meningeal artery. So as the pterion fractures, the meningeal artery ruptures. As a result, there is an easy development of extradural hemorrhage or epidural hematoma due to pterion trauma. Right? एक चीज़ जो हम पढ़ते समय हमेशा बात करते हैं वो क्या है? Extradural hemorrhage is a single hemorrhage जो कि स्कल में एक एक्सटेंसिव ब्लो के कारण ही हो सकता है. ये स्कल में ट्रिवियल ब्लोज से नहीं होता. हल्की ब्लोज कैन नॉट कॉज extradural hemorrhage. The only exception is if the blow has been given to pterion. Extradural hemorrhages can happen with a lesser force because it's the weakest portion of the skull. So answer here is very, very simple. The answer is pterion. Okay. Let's move to the last question of the lot. A chronic alcoholic presents with features of global confusion, ophthalmoplegia. Which vitamin deficiency is responsible? So we have confusion, ophthalmoplegia. अगर इसी में मैं एक और चीज़ ऐड करता हूँ दैट इज़ एटेक्सिया. So confusion, ophthalmoplegia, ataxia, classical triad of Wernicke's encephalopathy, right, due to vitamin B1 deficiency in heavy drinking. अगर ये ट्रीट नहीं होती है, इसी को प्रोग्रेस करते हैं, इट लेटर ऑन प्रोग्रेसेस टू बिकम कोर्साकॉफ्स सिंड्रोम. वहां पर क्या होता है, द पेशेंट देयर हैज एंटीरोग्रेड एंड रेट्रोग्रेड एमनीजिया प्लस डिफिकल्टी इन लर्निंग, वो नई चीजें नहीं सीख पाता, एंड कॉन्फैबुलेशन, इमेजिनरी वर्ड्स या इमेजिनरी आइडियाज से अपने सेंटेंसेस को भरता है क्योंकि वो भूल चुका होता है कि क्या बोलना है, राइट. सो दोनों ही केसेस में हमारे पास ट्रायड है. वर्निकेज एन्सेफेलोपैथी, वी हैव ट्रायड ऑफ अटेक्सिया, ऑप्थेल्मोप्लीजिया एंड कंफ्यूजन, and उसी का sequel if untreated results in Korsakoff syndrome, where the person generally presents with amnesia, difficulty in learning and confabulation. Okay, right, with that ये वाला सेशन हम यही ख़त्म करते हैं और आपके नेक्स्ट सेशन होल्डर आ चुके हैं. सो वी विल I will give the baton to him. Best of luck for your upcoming results. Believe in yourself now for whatever you have done in exam, and in case of any query, any problem, I'm always there with you, right? Bye.
Good evening, friends. So now we start psychiatry questions. Psychiatry questions इस बार थोड़ा सा tricky questions थे, तो देखते हैं कैसे tricky थे. एक और मैसेज उन्होंने दिया है that by this paper that they are going with standard textbook line to line. I will show you that how they pick the questions from the standard textbook synopsis latest edition from the line. Yes. जो भी if you feel that any modification in the question was there, let me know so that we can reach to the correct answer. Yes, first question, key feature of depression. Key feature था, students please do comment, key था या फिर characteristic कह सकते हो या फिर most common, जो I feel it was key, most of students told these are key. ये synopsis का 12th edition है. According to that, a depressed mood and loss of interest or pleasure are key symptoms of depression. तो बात यहाँ पे आ गई कि दोनों के दोनों लो मूड और लॉस ऑफ इंटरेस्ट दोनों के दोनों की फीचर्स हैं साइनोप्सिस के हिसाब से, अकॉर्डिंग टू साइनोप्सिस. नाउ यदि हम DSM-5 की बात करें, इफ वी टॉक अबाउट DSM-5, DSM-5 says that two main criterias are there, those are low mood or low interest. Okay, again says two, means you can't pick one. Yes. ICD 10 and 11 says that EMI, yes, energy, mood and interest, yes, these are major criteria. So now major criteria, main criteria, key features, both of these can be considered, but we will find the answer by the concept. Depression is mood disorder. Depression is classified as disorder of mood. So if I want to pick up one, definitely I will pick mood, low mood. Okay, friends? Yes, in this you must have done many questions in medicine and other subjects also, that if bookish language is given and first means first symptom or first drug which is written in the text, that is considered the best answer. So keeping in the mind, I will consider depressed mood, low mood as the answer of key features. Yes, any other thing? Yes. Just fast revision, it is seen in middle-aged female, depression is seen in middle-aged female, is the most common cause of suicide. Okay. Now, next question, Capgras syndrome is most commonly seen in which type of dementia? We all know Lewy body dementia, yes, is associated with visual hallucination plus delusion also, and we found that patients often have Capgras syndrome as a part of clinical picture. This is synopsis. Why I am giving you the lines of synopsis? Because this time they have kept these questions directly from the synopsis latest edition. Really it was little bit difficult, but trust me, if you have little bit idea, you will solve the question very easily by using the concept. Lewy body dementia, you know, visual hallucinations are there. Okay, means dementia with Lewy body is usually associated with psychotic symptoms, and Capgras syndrome is a delusion of misidentification. Although these delusions may be associated with Alzheimer's disease also, but characteristically or commonly it is associated, Capgras syndrome is associated with Lewy body. Capgras has been very important topic for FMGs. In 2018, there were two questions back to back, Capgras and Frigoli. So you must have an idea about this. Yes, what is Capgras? I give you example. Suppose there is a lady in the ward, she says that my husband is not my husband. He is somebody else. He is looking just like my husband. He is talking just like my husband. He is walking just like my husband. Everything is just like my husband, but he is not my husband. Yes, he is somebody else. Imposter, बहरूपिया. ये बहरूपिया है जिसने मेरे husband का रूप लेके आ गया है और कभी कभार पिटाई भी कर देगी वो. तो means known person has been replaced by similar looking person, that is Capgras. What is Frigoli? यस फ्री गोली में क्या होता है, पेशेंट सेज डॉक्टर साहब यू नो दैट द beggar sitting outside is not beggar, he is my boss. Yes, he has changed his physical appearance just like a beggar. Yesterday I went to post office, he changed his physical appearance just like postman. I came out from the post office, at red light he stopped me, he changed his physical appearance just like policeman. He can take multiple physical appearance. गोली दे रहा है फ्री गोली. क्या कहा, गोली दे रहा है फ्री गोली. यस कैप ग्रास सिमिलर लुकिंग पर्सन है, यस लेकिन कोई और है, तो दैट इज कैप ग्रास एंड फ्री गोली कॉमनली एसोसिएटेड विद लेवी बॉडी. यस थर्ड क्वेश्चन, विच ऑफ द फॉलोइंग आर फीचर ऑफ सूडो हेलुसिनेशन. सबसे पहले तो मैं निमोनिक बना देता हूं, हेलुसिनेशन एंड सूडो हेलुसिनेशन. इन सूडो S for subjective. So pseudo hallucination occur in subjective space, true hallucination occur in objective space. So answer can be found easily. Yes, pseudo hallucination occur in objective or subjective? Subjective space. So this is the answer. Okay. Now what is pseudo hallucination? Flashback. Bomb blast occurred. I give example. Suppose bomb blast occur, all family member died in front of your eyes. Yes, now you are seeing same flashback inside your mind. What I said, inside your mind, same scene, the same scene occurring again and again, that is flashback. So flashback, this event has already occurred. Now actually no bomb blast now, but you are seeing that scene of bomb blast without stimulus. So occur without stimulus, this is true pseudo hallucination. They are vivid. Vivid means clear. Vivid means clear. Yes, means that scene of bomb blast will be very clear inside your mind. That would be perceived in your mind, means subjective space. You want to stop these flashback, but you can't, means they are not under your control. They are not under your control. That is pseudo hallucination. So many times I give example, hallucination, lage raho munna bhai, you must have seen that they used to see, yes, Sanjay Dutt used to see Bapu, visualize Bapu, yes, and hear Bapu, बिल्कुल clear था, real की तरह. वो रोकना चाहता था, नहीं रोक सकता था, insight absent थी, they are experienced outer and objective space, बापू सामने दिखाई देते थे. Pseudo hallucination कहाँ पे होता है? Inside mind, insight is present. Okay? So these are differences. Now, yes, very frequently asked question, हर एग्जाम में क्वेश्चन मिल जाता है, ये कोई भी एग्जाम हो. पोस्टपार्टम डेज 5 डेज, पहली हालांकि डेज क्राइटेरिया नहीं है. यस, एनी मॉडिफिकेशन कुछ भी लगे तुम्हें तो यार बताना प्लीज. ओके, सिम्टम्स आए सैडनेस, मूड, सैडनेस ऑफ मूड, इरिटेबिलिटी, रेस्टलेसनेस, रिड्यूस स्लीप. देखो, postpartum blues is present in 60-70%, 70% अराउंड postpartum. ये है ट्रांजिएंट. क्या वर्ड यूज किया मैंने? ट्रांजिएंट सिम्टम्स. तो कई बार क्वेश्चंस में वर्ड आ जाता है ट्रांजिएंट डिप्रेसिव सिम्टम, माइल्ड सैडनेस ऑफ मूड, तो आंसर अपने आप हो जाता है postpartum blues. But in this question they have not used the word transient or mild. So how you will differentiate between postpartum blues and depression? For question purpose, you will remember wherever you find suicidal thought or ideation, wherever you find severe anhedonia or guilt, these things are there, these statements are there, then it is depression. Psychosis, psychotic symptom, delusion and hallucination would be there. Yes, let me simplify with the help of this table. Postpartum blues 30 to 70% पेशेंट में होते हैं. इसमें डिप्रेसिव सिम्टम्स होंगे, टीयरफुलनेस होगी, सैडनेस होगी, स्लीप डिस्टर्बेंस हो सकती है, मूड लेबिलिटी हो सकती है. ऑनसेट 3 to 5 days, जस्ट लाइक इन दिस क्वेश्चन, एंड दिस लास्ट 4 days to weeks. मतलब 2 हफ्ते में, 3 हफ्ते में ठीक हो जाता है. लेकिन पोस्टपार्टम डिप्रेशन ऑनसेट इज विद इन 3 months ऑफ डिलीवरी. DSM-5 में इसका नाम क्या दे रखा है? यस, डिप्रेसिव एपिसोड विद पेरीपार्टम ऑनसेट. इसमें तुम्हें क्या मिलेंगे? सुसाइडल थॉट, thoughts of harm to baby, anhedonia, guilt, decrease psychomotor activity. If these things are there, definitely answer would be postpartum depression. In postpartum blues, nothing to be done, only support to the mother. In postpartum depression, definitely you will treat on the guidelines of depression. Postpartum psychosis, I told you, delusion, hallucination, sometimes they start believing, mother start believing that my baby was born dead. Okay? या ही इज डेविल, यस राक्षस पैदा हो गया है, तो अब वो क्या करेगा, फीमेल क्या करेगी, उस बेबी को हार्म पहुंचाना चाहेगी. तो देर इज रिस्क टू द बेबी इन पोस्टपार्टम साइकोसिस. सो मैनी टाइम्स वी सेपरेट द बेबी फ्रॉम द मदर एंड वी स्टार्ट एंटीसाइकोटिक्स. गॉट द पॉइंट? सो दिस इज वेरी इंपॉर्टेंट टॉपिक. ऐसी कोई टर्मिनोलॉजी नहीं है. इसमें याद रखना है, यदि डिल्यूजन हेलुसिनेशन हुआ तो साइकोसिस है और उसमें वो तुम्हें हार्म टू बेबी रिस्क होगा, तो सेपरेट बेबी फ्रॉम द मदर एंड एंटीसाइकोटिक स्टार्ट कर देंगे. डिप्रेशन में क्लियर कट मिलेगा तुम्हें, सुसाइडल थॉट्स हैं उसके, गिल्ट है, एनीडोनिया सीवियर, डिक्रीज साइकोमोटर एक्टिविटी, और मतलब सीवियर सिम्टम्स डिनोट करेंगे तो डिप्रेशन. यदि वो माइल्ड की तरफ जा रहा है, 5 दिन हुए हैं, तुम्हें पता है डिप्रेशन का क्राइटेरिया क्या है, अभी हमने डिस्कस भी किया था, कम से कम सिम्टम्स कितने दिन के लिए होने चाहिए, 2 वीक्स के लिए होने चाहिए टू मेक द डायग्नोसिस ऑफ डिप्रेशन. क्लियर? सो ये की पॉइंट पे हमने अटैच हो गए, हम रेफरेंस ही मानेंगे, लेकिन ध्यान रखेंगे कंसेप्चुअली सॉल्व करना है क्वेश्चन. डिप्रेशन इज ए मूड डिसऑर्डर, तो मेन डिसऑर्डर किसका होगा, की फीचर क्या होगा, डिप्रेशन, ओ सॉरी लो मूड, लो मूड. ठीक, अब आगे चलते हैं. ये रियली डिफिकल्ट क्वेश्चन था. यस, तो इस बार साइकेट्री में उन्होंने, मैंने क्या कहा, साइनोप्सिस से लाइन उठा के डाली है. आई विल शो यू. ए पेशेंट इज शोइंग स्टबर्न एंड फ्रिजिलिटी, साइकोसेक्सुअल स्टेज ऑफ डेवलपमेंट. Psychosexual stage of development, according to Sigmund Freud, 5 stages are there: oral, anal, phallic, latent, genital. Sigmund Freud ने कहा जो सेक्सुअल प्लेजर है वो ओरल से एनल तक मूव करता है. जब बच्चा छोटा होता है 1 से 1.5 साल का, अप टू 1.5 year, he puts everything in the mouth. Means sexual arousal, gratification और gratification of life lies in oral cavity और perioral area. तो उसने कहा जितना भी सेक्सुअल प्लेजर है वो ओरल कैविटी की तरफ है, ओरल फेज कह दिया. ये फेज, ये जो स्टेज बताई थी, दैट वाज नॉट एक्सेप्टेड. क्यों एक्सेप्ट नहीं थी अभी देखोगे, बट क्वेश्चंस आस्क. तुम्हारा फेवरेट है ये टॉपिक, लेकिन उन्होंने थोड़ा डीप लेके देखते हैं. यदि किसी कारण से ए चाइल्ड और ए पर्सन स्ट्रेसफुल सिचुएशन में आया और ओरल फेज में आके अटक गया, तो उसे क्या क्या साइकेट्रिक डिसऑर्डर होंगे, दैट इज अल्कोहल डिपेंडेंस. क्या होंगे, अल्कोहल डिपेंडेंस. कैसे याद रखोगे, ओरल क्या लेते हो, अल्कोहल. ठीक है. सिजोफ्रेनिया, सहरा, यस, एस से मैंने सहरा बना दिया, दूल्हे का सहरा कहां पे होता है, फेस पे, तो ओरल. यस, कुछ भी याद रखना, डिपेंडेंट पर्सनैलिटी. ओके. ये एनल फेज क्या होती है, 1.5 से 3 साल. सिगमंड फ्रॉइड ने कहा जब बच्चा टॉयलेट ट्रेनिंग करता है तो उसे प्लेजर आ रहा है, ग्रेटिफिकेशन मिल रहा है, होल्डिंग द फीसिस, इन होल्डिंग द फीसिस. तो उसने कहा एनल फेज है 1.5 से 3 साल तक, और इसमें यदि फिक्सेशन और रिग्रेशन एंड फिक्सेशन होगा तो ओसीडी होगा. क्या होगा, ऑब्सेसिव कंपल्सिव डिसऑर्डर. सिंपल निमोनिक मैंने बनाया था इसका, कंटामिनेशन. मोस्ट कॉमन ऑब्सेशन इज कंटामिनेशन, मोस्ट कॉमन ऑब्सेशन इज कंटामिनेशन. और कंटामिनेटेड एरिया क्या होता है, एनल और पेरिएनल एरिया. तो हमने याद कर लिया. अब क्वेश्चन उन्होंने क्या दे दिया, स्टबर्न एंड फ्यूगिलिटी, ये ट्रेट्स हैं, ये किस में होते हैं, एनल फेज में फिक्सेशन की वजह से होते हैं. क्वेश्चन कहां से उठाया, ये पूरी लंबी टेबल दे रखी है, इतना बड़ा पैथोलॉजिकल ट्रेट दे रखा है एनल के लिए, और उसमें से उन्होंने कहां से उठाया, ये स्टबर्ननेस, फ्रूजिलिटी. ओके, मैंने इसको याद रख लिया. इस पंचायत के से, पंचायत का याद है तुम्हें, पंचायत में सचिव जी ने इसको क्या कहा था, ये इतना स्टबर्न था, इतना स्टबर्न था कि चक्का की कुर्सी तो हम लेकर ही जाऊंगा, चक्का की कुर्सी तो ये लेके ही जाऊंगा, लेके गया भी, इतना स्टबर्न था ये. ठीक है. और इसको क्या कहा था, यस यू कैन कमेंट, कि इसको क्या कहा था सचिव जी ने, तो वही एनल एरिया में स्टबर्ननेस और फ्रूजिलिटी, इकोनॉमिकल. इकोनॉमिकल मतलब कि पन्नी भी नहीं उतारनी. ओके, तो वो सब चीजें इससे मैच कर रही है, तो याद रख लेना ये है एनल फेज. ओके, क्लियर. No hepatitis B. Any yes? No hep B. Any change? Same था. Okay. Now next question. यह सिंपल सा क्वेश्चन था, अर्ज और इम्पल्स. इम्पल्स कंट्रोल डिसऑर्डर में तुमने पढ़ा भी है क्या होता है. क्लेप्टोमेनिया में सपोज करो मुझे क्लेप्टोमेनिया है, मैं किसी शॉप पे गया और मेरा मन करने लगा ये टूथपेस्ट उठा ले उठा ले उठा ले उठा ले उठा ले, अर्ज आने लगी. क्या आने लगी? अर्ज. उठा ले उठा ले उठा ले उठा ले, अर्ज आई. आई एम ट्राइंग टू कंट्रोल दिस अर्ज. एक पॉइंट आया, आई एम कांट कंट्रोल दिस अर्ज. आई पिक अप द टूथपेस्ट. उसके बाद रिलैक्स फील किया और उसके बाद गिल्ट आया. ये है इम्पल्स कंट्रोल डिसऑर्डर. इम्पल्सेस आती हैं, अर्ज आती हैं, पेशेंट इज अनेबल टू कंट्रोल, डू द एक्शन, आफ्टर दैट फील गिल्टी. सो ICD 11 में 4 इम्पल्स कंट्रोल डिसऑर्डर्स हैं. क्लेप्टोमेनिया, चुराना. पायरोमेनिया, आग लगाना. यस. इंटरमिटेंट एक्सप्लोजिव डिसऑर्डर. यस. गर्लफ्रेंड से लड़ाई हो गई, मोबाइल लिया, टीवी पे दे मारा, मोबाइल भी गया, टीवी भी गया, बाद में दुख हुआ. यस, that is intermittent. Compulsive sexual behavior disorder, new entity added in ICD 11. This may be a next question. Okay. ICD 10 में pathological gambling and trichotillomania were impulse control disorder, लेकिन ICD 11 ने ट्राइकोटिलोमेनिया को बना दिया है OCRD, क्लासीफाई किया है OCRD. 2 बार क्वेश्चन आ चुका है INI-CET में. यस, लेटेस्ट क्वेश्चन. और पैथोलॉजिकल गैम्बलिंग को बना दिया है एडिक्शन. ओके, सो दीज में बी पोटेंशियल क्वेश्चन. तो इसमें अर्ज सुनते ही तुम इम्पल्स लगा दोगे. यस. हेलुसिनेशन, डिल्यूजन, सूडो हेलुसिनेशन, वी ऑल नो हेलुसिनेशन इज डिसऑर्डर ऑफ परसेप्शन ऑफ थॉट. सूडो हेलुसिनेशन इज डिसऑर्डर ऑफ परसेप्शन ऑफ थॉट. डिल्यूजन इज डिसऑर्डर ऑफ कंटेंट ऑफ थॉट. ओके, दीज आर द क्वेश्चंस. ये फॉलोइंग आर द साइड इफेक्ट ऑफ लिथियम. हमेशा एक क्वेश्चन आता है, आज मैंने लिथियम स्टार्ट कर दी. सपोज करो पेशेंट मेरे पास आया, सपोज पेशेंट केम टुडे, आई स्टार्टेड लिथियम एंड आई विल आस्क पेशेंट to come again after 5 days. How many days? 5 days to check lithium level, and I will advise that don't take morning dose. Means suppose today I started lithium. Yes, I started lithium today. After 5 days, yes, patient would come, I will check serum lithium, and it should be checked after 12 hours of last dose. यदि उसने रात को गोली ली है तो सुबह, रात को 10 बजे गोली ली है तो सुबह 10 बजे सैंपल लोगे. आफ्टर 12 आवर ऑफ लास्ट डोज सीरम लेवल इज चेक्ड. क्यों सीरम लेवल क्यों चेक करते हैं? बिकॉज लिथियम ही इज हैविंग वेरी नैरो थेरेप्यूटिक इंडेक्स. ओके, थोड़ा सा ज्यादा हुआ दिक्कत हो जाएगी, तो इसीलिए हम इसमें मॉनिटरिंग करते हैं. नाउ व्हाट आर द साइड इफेक्ट? सपोज पेशेंट मेरे पास आया, ओपीडी में आया, मैं उससे हमेशा कहूंगा ओके स्ट्रेच योर हैंड. उसने हाथ स्ट्रेच किए, उसको ट्रेमर्स आ रहे हैं. दे आर फाइन ट्रेमर्स. क्या कहा मैंने? फाइन ट्रेमर्स हैं. मैंने घबराने की जरूरत नहीं है, मैंने बीटा ब्लॉकर दे दिया. नाउ द सेम पेशेंट केम आफ्टर फ्यू डेज. नाउ ही इज हैविंग कोर्स ट्रेमर्स. पॉइंट इट आउट. कोर्स ट्रेमर्स आर टॉक्सिसिटी. क्वेश्चन इज आस्क्ड, फाइन ट्रेमर्स, normal side effect, coarse tremor, toxicity, immediately check reflex. Hyperreflexia would be there. Patient may have ataxia, coma, death. Immediately you will shift the patient for dialysis. Before that you will check the serum lithium level and do dialysis, because lithium is excreted by kidney. Question, lithium is excreted by kidney. And side effect of, other side effect, diabetes insipidus, nephrogenic diabetes insipidus. Yes. Hypothyroidism, sometimes hyperthyroidism may be there. Okay, so this is side effect, this is side effect, this is side effect. So answer is tardive dyskinesia. This is extrapyramidal side effect seen with antipsychotics. Antipsychotics. Clear? Next question, treatment of benzodiazepine overdose. Yes, तुमने मजा लेने के लिए बेंजोडाइजेपिन ली, लेकिन हमने उसको फ्लूमेजानिल दे दिया. फुल मजा नहीं आएगा. यदि तुमने फ्लूमेजानिल ले ली तो फुल मजा नहीं आएगा बेंजोडाइजेपिन का. यस, फोमेपिजोल फॉर अल्कोहल टॉक्सिसिटी, नैलोक्सोन फॉर ओपियोइड इंटॉक्सिकेशन. Okay, IV naloxone. So these are the questions. Next is chronic alcoholism patient confusion, ophthalmoplegia, ataxia, mnemonic is Goa, Wernicke is encephalopathy, yes, B1 deficiency. Chronic alcoholism, B1 deficiency. इसमें question ये same था. I am having doubt regarding this question. Please do comment. Yes, Wernicke's encephalopathy is due to acute complication of thiamine deficiency. Yes, bilateral mammillary body lesion are found. Okay, global confusion, ophthalmoplegia, ataxia, and the treatment is high dose of parenteral. Yes, thiamine. I think this is the last question. Yes, image, identify the image. Yes, trichobazor. You all know that trichotillomania, pulling hair, eating, pulling hair, trichotillomania, eating, trichophasia, and if it cause obstruction, intestinal obstruction, trichobazor. So this question has been asked previously in FMG itself, and at that time the question was that a surgeon was operating for trichobazor. This surgeon will refer the patient to which specialty, and the answer was psychiatry. Okay, so these were the question. In these questions I will say that most of the questions were simple, except one, this anal stage fixation, stubbornness. You will remember this person, so stubborn he was. Okay, and Sachiv ji ने उसे क्या कहा था. Other than that, yes, this was simple question, repeated question. This is again repeat question. This was Capgras syndrome, rarely asked, and this was little bit confusing. So thank you for patience listening and best wishes for your result. Be positive. इस duration में, during this phase, अभी जब तक रिजल्ट नहीं आता, डू सम प्रोडक्टिव थिंग. ओके, कई बार हम कहते हैं कि यार चलो अब तो फ्री हो गए. ठीक है, फ्री हो गए, नो डाउट, रिजल्ट आएगा. रिजल्ट के बीच में या तो इन्वेस्ट इन योर हेल्थ और योर नॉलेज, क्योंकि ये सिर्फ ये आखिरी पड़ाव नहीं है. जैसे कौन बनेगा करोड़पति में कहते हैं, ये आखिरी पड़ाव नहीं है. इसके बाद क्लियर होते ही नीट पीजी आ जाएगा. ठीक है, तो इस टाइम को यूटिलाइज करो, इन्वेस्ट इन योर हेल्थ. थैंक यू.
Hi guys, I'm Dr. Siraj Ahmed, your faculty of pharmacology, and now I'll be discussing the recall of pharmacology that was asked in the recent examination. All this topic that we are going to Hi guys, I'm Dr. Siraj Ahmed, your faculty of pharmacology, and now I'll be discussing the recall of pharmacology that was asked in the recent examination. All this topic that we are going to discuss can be a very potential MCQ in the upcoming examination as well. Do remember that this examination has become totally integrated clinical pattern. So saying that this particular question was only from one subject will be little difficult, because you know one question had some information about micro and then they asked about pharma. Likewise, there were a lot of integration that we have seen in this examination. That is why we had a lot of difficulty as well, and many students had different version as per what they could recall, because these are all recall based session that we have. So as per whatever they recall, whatever topic that they could recall, we are going to discuss all those topic here. And a quick disclaimer to all of you guys that this is not something that I would say that the exact exam question that we had, but we try to come up with the best version of the recall that we could hear in this examination. So let's go and start this session. Feel free to comment in between if you feel that some option was not there or some option should be changed, or it's discussed in other way around. So please feel free to comment in the comment section, in the live chat option. I'll try to interact with you through chat option as well. Okay, so let's get started. And the very first question that I'll be discussing with all of you guys is: elderly male with 2 bottles of alcohol from a local liquor shop, and after consuming he developed symptoms like ataxia, drowsiness, blurring of vision. Which of the following is preferred? Now local liquor shop, definitely they are talking about a condition known as your methanol poisoning, right? Methanol poisoning. So methanol poisoning or ethylene glycol poisoning, what is the drug of choice that we have discussed with all of you guys? We are having fomepizole as an antidote of choice. Fomepizole as an antidote of choice. Now what is fomepizole? In next examination they can ask you fomepizole it is one of the alcohol dehydrogenase inhibitor. Alcohol dehydrogenase inhibitor. A point to remember here that fomepizole being an alcohol dehydrogenase inhibitor, until it was not there, we had another antidote that we were using by ethyl alcohol. Now some students are telling, sir, fomepizole was not in the option, only ethyl alcohol was there, and some students are saying nahi, dono option mein tha. Now that is why I'm just putting a quick disclaimer that this is not something that I say that this is the exact question that was there. Please feel free to go ahead and choose whether you marked ethyl alcohol or fomepizole. अगर fomepizole था आपके पेपर में तो definitely fomepizole will be the answer, period. इसमें कोई and if but नहीं है. But if fomepizole was not there and if you think that you have marked ethyl alcohol, so other alternative that we have is ethyl alcohol. So ethyl alcohol, what it will do? Ethyl alcohol, it is considered as a competitive inhibitor of alcohol metabolism. So methanol का जो enzyme है, that is alcohol dehydrogenase, they will all be shifted towards the ethyl alcohol metabolism. Therefore the risk of toxicity or the fatal outcome that was there with the methanol will be reduced, है ना. So ऐसा नहीं कि ethyl alcohol is a very helpful, है ना. Do remember both of them are alcohol, but एक का toxicity ज़्यादा है, एक का toxicity कम है. I mean in this scenario, so we have a specific antidote known as your fomepizole. So in single line, if I have to say, methanol poisoning or ethylene glycol poisoning. Ethylene glycol, that has been asked in one of the examination, ethylene glycol in one of the EPSC examination, that a patient is coming after drinking coolant of a car, है ना. So I think all of you guys have got this one. Naloxone is the antidote of opioid. Flumazenil is the antidote of benzodiazepine. So don't need to mug it up. All of you guys are already aware. Which of the following agent is preferred in the treatment of benzodiazepine? So again, benzodiazepine overdose के लिए क्या prefer करेंगे? Benzodiazepine के लिए we are having a flumazenil. It's an antagonist. It is considered as a antagonist of benzodiazepine, है ना. Benzodiazepine के लिए flumazenil is the antidote, है ना. Folinic acid will be added with the methotrexate. Naloxone again is the antidote for opioid, and fomepizole again is something that we'll be preferring in methanol or ethylene glycol poisoning. Now do remember a very, very important thing. In the very beginning, when we were discussing general pharma and also when we were discussing the rapid revision section, remember I gave you a table and I told you that in 2021 नीट पीजी में 5 क्वेश्चन आए थे उस टेबल से. आपके एग्जाम में 5 नहीं आए थे, 3 आए थे from one single table. What was the table? I'll give you the table. Like first and foremost, let us finish this question and then we'll talk about the next one. Thalassemia patient with a history of multiple blood transfusion brought with a chronic iron overload. Now which of the following is the oral drug that will be preferred for managing the symptom? Now oral drug for preferred. Now see, iron poisoning मैंने बताया था दो तरह के patient होंगे. One patient will be emergency condition, and in emergency we are going to prefer a drug that is your desferrioxamine. Now desferrioxamine, what is the root of desferrioxamine? It's an injectable agent. ठीक है. Now oral agent, if they are going to ask you, we are having two important oral agents. One is deferriprone, that is oral, and other one is known as your deferasirox, right? These two agents are oral agent. So we have already deferriprone, that will be the preferred agent. So कोई भी hemolytic anemia है, if there is a recurrent blood transfusion, there will be risk of iron overload. Iron overload will be there, and therefore you can give oral iron chelator agent. They are what? Iron chelator agent, oral iron chelator agent. ठीक है. Which one is iron chelator agent? Both deferriprone, desferrioxamine. 2021-2022 में जो क्वेश्चन आया था नीट पीजी, they asked that a child was playing and he consumed some tablet and there was an empty bottle of iron that was found around him. What will be the antidote, है ना? So now deferriprone here in this case scenario, because it's a oral they are asking. Okay. Now vitamin B12 deficiency, or if the patient is having megaloblastic anemia, EDTA, BL, we can use them in lead poisoning. D-penicillamine is something that will be used in a copper poisoning. Now, as I was telling to all of you guys that we will be copper poisoning or copper chelator. It's a copper chelator agent. Let us quickly discuss the table that I was talking about. Now this is one table from where questions are very frequently asked, and in this examination of FMGE we got 3 questions from one, and this table was discussed in rapid revision as well, and we also have discussed in general pharma section of our regular class also. Okay, so atropine का antidote क्या होगा? The antidote of atropine, it is going to be physostigmine. What is atropine? Atropine is a non-selective muscarinic antagonist. Morphine के लिए क्या है? That is going to be your naloxone. Morphine के लिए we have naloxone. Copper, the chelating agent will be D-penicillamine, right? D-penicillamine, it's a copper chelating agent. Okay, next that we are having is one more iron. Iron, as I told you, that we have desferrioxamine अगर emergency है तो desferrioxamine if there is emergency. However, we are having some oral preparation as well. Oral preparation we have deferriprone, and other one is known as your deferrasiroxy. So all these questions are already discussed a couple of times. In fact, when there was a MCQ up ki baar 200 par, in that also we discussed this one, all the antidotes. Lead poisoning mein we can use EDTA, we can also use BAL. Paracetamol poisoning mein we can use N-acetylcysteine. This question was also asked in the PYQ, I mean last year. Digoxin mein we will be using Digibind, it's a chelator of digoxin. Benzodiazepine poisoning mein flumazenil. So was it asked? Yes, flumazenil. Now in upcoming examination they might remove benzodiazepine and they can give you barbiturate. So for the barbiturate, remember we are going to do forced alkaline diuresis, है ना? Forced alkaline diuresis, right? Acidic drug के लिए we use forced alkaline diuresis. All right. Then beta blocker के लिए we have glucagon. Benzodiazepine poison के लिए we will be using flumazenil, right? So this is one table from where questions are frequently asked, and you can also be ready for the upcoming examination as well, and make sure that you are going to revise all this, right? Now let us see the next question quickly. A female with the history of HIV positive, not taking any antiretroviral therapy, delivered a baby. What should be the initial treatment that should be started immediately to the newborn? Now there were again few controversies, few students were telling other way around, but after discussing with many students, we come up with this conclusion that this will be the final version of this question. Now whenever there is a mother to child transmission के लिए prophylaxis के लिए we are having the agent that is nevirapine. We always use nevirapine suspension format 2 mg per kg for a total duration of 6 weeks. ठीक है, after 6 weeks you can after 6 weeks, or they usually say that confirmation of the diagnosis will usually be done after 18 months, and then only you will be starting other drugs. Now right now if you want to start a prophylactic agent because you are not very sure whether this baby has acquired or not, because the risk of transmission in HIV, what is the risk of transmission, ROT in HIV, risk of transmission kitna hai? Very less, that is your 0.3% risk is there in the needle prick. In the needle prick 0.3%. And mother to child transmission में there are many data and some of them are misleading as well, but on an average we see that okay, if there is a pregnant female there is high risk, high risk. Sometimes some studies are telling 25, some studies are telling 30, but needle prick में around 0.3%, right? Now mother to child transmission में usually क्या होता है, mother को हम क्या देते हैं, antiretroviral drugs देते हैं, है ना? Now if the patient is not taking antiretroviral drug, in that case scenario also we will be proceeding with the nevirapine to the newborn as soon as the baby is born. And it is also said that if there is a pregnancy, in the pregnancy, if the person is a female is diagnosed with HIV, you should start the antiretroviral therapy as soon as it is diagnosed. You do not wait for CD4 count now. Okay. For prevention we are having two drugs. Remember, zilovodine is also one of the drug, but the preferred one is always going to be nevirapine. In fact in our country as well there is a list of essential medicine, उसमें दो drug दिया गया है for the prophylaxis, zilovodine और nevirapine का discussion हुआ है. Nevirapine is always preferred. Cost is one reason, easy availability is one reason, less side effect is the other reason. Okay, a newer drug bedaquiline, multiple times I have discussed this question with all of you guys. Bedaquiline को याद रखना है, B से bedaquiline, it is one of the ATP synthase inhibitor. Now in the examination what they did not give the term ATP, they give the full form of ATP, है ना? So adenosine triphosphate synthase inhibitor of the mycobacteria. Yes, DNA dependent RNA polymerase inhibitor, this will be the mechanism of action of rifampicin. Arabinosyl transferase will be inhibited by ethambutol. Catalase peroxidase is the enzyme that is required for the activation of isoniazid. If there is any mutation in the catalase peroxidase, isoniazid will not be activated. So catalase peroxidase mutation is mainly responsible for the isoniazid resistance. So right now all of you guys are already aware of bedaquiline. Now delamanid, you check out any of the review class that we have discussed. We have discussed it. Delamanid, pretomanid. Now what have I told you? Manid and manid, है ना? मैंने बताया था आपको manid and manid, दोनों ही manid है. Manid and manid, जो manid है, they both are actually mycolic acid synthesis inhibitor. Mycolic acid synthesis inhibitor. same as your isoniazid, that is also one of the mycolic acid synthase inhibitor. Delamanid is also a mycolic acid synthase inhibitor. Bedaquiline B or ATP synthase inhibitor. So energy production in the mycobacterium will be compromised. All right. Now next time what they can ask you, potential MCQ इसके साथ discuss कर लेते हैं इसके important side effect. So bedaquiline जो है, it's a drug that is mainly approved for the MDR tuberculosis and also can be used in XDR-TB because XDR-TB जो B-Pol regimen है, ज़्यादा B-Pol regimen. So bedaquiline, pretomanid and linezolid. So इसके important side effect they can ask. Important side effect, they are highly cardiotoxic agent and the cardiotoxicity they mainly causes QT prolongation. They are also hepatotoxic agent. They also can lead to electrolyte imbalance. So examiner asks that what are the important lab parameters that you should keep an eye on. So now you have the answer already, ECG, LFT and electrolyte parameters. You should always keep an eye on all these parameters, right? So we'll go ahead with the next question. A 30-year female brought by her husband. Now there was a history of depression. Now this history has been distorted by many students and by many people. Different version has been given, but we have come up with one of the version that suits best. He just try to understand the concept that there is a female had a depression, diagnosed with major depressive disorder. She was accompanied by her husband. She was started on an antidepressant, and after starting the antidepressant, she developed some symptom of insomnia, restlessness, agitation, anxiety, diarrhea, headache. Now some of these symptoms may not be there, but students clearly they recall that agitation or restlessness था सर इंसोमनिया भी था, हेडेक, डायरिया, एंजाइटी. आप देख लो अगर है तो, अगर इतना आ रहा है एंटी डिप्रेसेंट देने के बाद से, तो विच ड्रग इज पॉसिबली शी वाज स्टार्टेड. नाउ मेजर डिप्रेसिव डिसऑर्डर में which drug can cause this one? Now do you guys know that I always used to discuss the important side effect of SSRI, side effect of selective serotonin reuptake inhibitor is SSRI, और SSRI को क्या बोलता हूं मैं? S stand for your serotonin syndrome. So because of excessive serotonin, the patient will have nausea, vomiting, diarrhea, anxiety, agitation. ये सारे के सारे आएंगे. Anxiety, agitation, restlessness, ये सारे के सारे आएंगे. And diarrhea will be very predominant. There will also be blood pressure, BP fluctuation will also be one of the problem with this serotonin. And vivid dreams, एक बार पहले AIMS में पूछा हुआ है, vivid dreams is also something that has been asked in the AIMS. Then sexual dysfunction in the 2021 examination, sexual dysfunction was something that was asked. Now sexual dysfunction may they will be causing delayed ejaculation. Because of the delayed ejaculation, this happened to be a good news for some people because it was, it got FDA approval for premature ejaculation. It got FDA approval for premature ejaculation. So that's a very good news. Hai na? So delayed ejaculation, anorgasmia is something else that was mentioned. That is one of the side effects. R stands for your restlessness and insomnia. Now please do remember this one, that SSRI ka side effect will be remembered by the very simple mnemonic of SSRI. Now after giving which of the following drug the patient developed this one. Now which one is SSRI? The only one in the list that is SSRI is fluoxetine. Citalopram, fluoxamine है ना. The only one in the list is fluoxetine. Buspirone is the anti-anxiety drug. Buspirone ये काम नहीं करेगा. Haloperidol is antipsychotic drug. It will mainly associated with your extrapyramidal symptom. Lithium is a drug for mania, है ना. Mania के लिए drug of choice है. It can cause renal toxicity, it can cause leukocytosis, it can cause tremors. वो सारे symptom cause करेगा, है ना. तो fluoxetine is the correct answer. I hope this question is there in the best shape that we could get, and all of you guys are satisfied with the version that we got here. Okay. Now next question. There is a 70-year-old patient was brought to the OPD. With complaints of urinary hesitancy and incomplete urination. Incomplete urination, or they say, the patient is not, satisfied, and he feels that the urge to urination is still there after some time. So USG also shows there is a prostate enlargement and residual urine volume of around 130 ml. So this is clearly a case of benign prostatic hypertrophy. And in BPH, we always use some of the important agent. One is known as your 5-alpha reductase inhibitor. Now 5-alpha reductase inhibitor, it inhibits the activation of testosterone to dihydrotestosterone.
ठीक है, डाइहाइड्रोटेस्टोस्टेरोन में कन्वर्ट नहीं होने देता है, विच इज द एक्टिव फॉर्म विच इज इन्वॉल्व मेनली इन द एनलार्जमेंट ऑफ द प्रोस्टेट ग्लैंड. सो अल्टीमेटली क्या होता है, द ग्लैंड का साइज भी इसके थ्रू कम होता है ना. 5 अल्फा रिडक्टेज इनहिबिटर वी कैन यूज. वी कैन ऑल्सो यूज अल्फा 1 ब्लॉकर लाइक फॉर एग्जांपल प्राजोसिन टेराजोसिन तो ड्रग ऑफ चॉइस है अगर बीपीएच के साथ हाइपरटेंशन आ जाए, है ना. सो बिनाइन प्रोस्टेटिक हाइपरट्रोफी विद हाइपरटेंशन, this will be the drug of choice, है ना. Now given the option that we have in a BPH, are you going to use ACE inhibitor, aldosterone receptor antagonist, calcium channel blocker, or 5 alpha reductase? I think it's needless for me to say anything, all of you guys are already aware, है ना. So instead of asking which of the following drug can be used in BPH, they gave a scenario. So आपका क्लिनिकल क्वेश्चन ऐसा नहीं कि बहुत डिफिकल्ट है. इंस्टेड ऑफ सेइंग विच ऑफ द फॉलोइंग ड्रग कैन कॉज द शोन साइड इफेक्ट, दे आर गोइंग टू गिव यू क्लिनिकल क्वेश्चन. एंड दिस इज एग्जैक्टली व्हाट वी हैव बीन हार्पिंग एवर सिंस 2018-19 कि बच्चों आपके एग्जाम में क्लिनिकल बेस्ड क्वेश्चन होंगे. एंड एग्जामिनर इज नॉट प्रिपेयरिंग टुडे, इट हैज बीन कमिंग फ्रॉम 18-19. यू चेक आउट एनी वीडियो ऑफ 18-19 है ना. वी आर टेलिंग एट दैट टाइम एज वेल दैट ओके योर एग्जामिनेशन has or your subject has become a clinical pharmacology and expect clinical based question. So simplest of the question are in clinical based. Okay, let's see the next one. 44-year-old patient with the HIV positive presents to OPD with complaints of blurred vision, floaters in the eye. Now this can be a very good integrated question with ophthalmology. You check out one session where me and Dr. Shachwat Ray sir have conducted a session, ऑफ्था और फार्मा इंटीग्रेशन में. एग्जैक्टली सिमिलर काइंड ऑफ क्वेश्चन वी हैव गिवन विद इमेज. यूट्यूब में है फ्रीली, काफी 2-2.5 महीने पहले किया था, आप चेक कर सकते हैं ना. सो सीएमवी रेटिनाइटिस का डायग्नोसिस भी दे दिया, पिज्जा पाई रेटिनोपैथी, कॉटन वुल स्पॉट ऑन द रेटिना. व्हाट इज द डायग्नोसिस, सीएमवी रेटिनाइटिस, एंड द ड्रग ऑफ चॉइस विल बी गैनसाइक्लोविर. सो वी प्रिफर वन मोर प्रो ड्रग दैट इज गैनसाइक्लोविर. तो ये भी डायरेक्टली डिस्कस्ड क्वेश्चन है. Ganciclovir, it's the pro drug that can also be used. Other that can be used will also be Cidofovir can also be used, and foscarnet is something that can also be used. What cannot be used, that was asked in 2016 FMG. PYQ check करिएगा. What will not be used in CMV? Not for CMV. This was asked already. Not for CMV. And option is acyclovir. Remember, acyclovir will not be used in CMV. It has no efficacy. But cidofovir, foscarnet, ganciclovir, and ganciclovir can be used. Ganciclovir is the drug of choice. We do not have any role of cotrimoxazole or tenofovir. Tenofovir is an antiretroviral drug that can also be used in hepatitis B. Okay, so I hope all of you guys are okay here, and all of you guys have made correct. Ganciclovir, CMV retinitis. That's a very simple one. Next one. This is the list of drugs that will be used. Ganciclovir implant, and IV ganciclovir, ganciclovir, and Cidofovir you can use, foscarnet you can use. So these are the drugs that can be used. Examiner is not expecting from you to remember the doses exactly, है ना. But जहाँ कहीं भी important है, जैसे कि कुछ important areas जैसे कि TB, malaria, leprosy, वहाँ पे we used to discuss the doses. However, in this examination they ask medicine का question integrated with pharma, where they have discussed what will be the dose of steroid in a certain condition, है ना. तो वो मैं डिस्कस करूंगा अभी. नेक्स्ट वन, फीमेल पेशेंट विद हिस्ट्री ऑफ पोस्टपार्टम हेमरेज वर ट्रीटेड विद ऑक्सीटोसिन और एर्गोमेट्रिन. Postpartum hemorrhage, what is the drug of choice? First and foremost, the drug of choice, it is going to be what? It is going to be oxytocin. Now here whether doses were given or not, I am not very sure. Some students said sir कुछ dose था, some students said नहीं simple drug था. Now अगर dose था तो again do remember, आपको उस पे ध्यान नहीं देना. ध्यान क्या देना, क्वेश्चन का लैंग्वेज सुनिएगा. They have already given oxytocin and ergometrin. Oxytocin is the drug of choice, followed by ergometrin, that is the next alternative that we have. But even after two drugs, they are not able to stop. The next line, the next preferred agent that we have is a carbopros that happens to be PGF2 alpha analog. PGF2 alpha analog. This will be causing uterine contraction. uterine का contraction कराएंगे, so that the vessel could be constricted. The vessel could be constricted because the vessel is there in the crisscross fraction of the myometrium. So carbopros is something that can be used. Now can we use dinoprost? No. Dinoprostol is something that can be used. Yes. Can we use misoprostol? Yes. Misoprostol can also be used. But since this is emergency scenario, oral पे rely नहीं करेंगे. We'll be preferring either per rectal route वाला or injectable route वाला. Right now, carbopros is something that will be preferred in this case scenario, and this is the list of the drug that will be mainly preferred for the treatment of the postpartum hemorrhage. So with the doses, oxytocin 10 to 40 units, and methyl ergonovine or methergine, that's the same thing that they have mentioned as well. Ergometry, that's the same thing, उसी का derivative है ना. If it is not responsive, then we will go ahead with the next line. So that is going to be PGF2 alpha analog. देखिए PGF2 alpha analog, carboprost is something that PGF2 alpha. Later on we can use dinoprostone. As I said, dinoprostone we will be using, that is PGE2 analog, or misoprostol. Misoprostol is something that can also be used. So 1000 microgram per rectal preparation is something that can also be utilized for the uterine contraction. Uterine atony हो गया तो postpartum hemorrhage है ना. Postpartum hemorrhage को prevent करने के लिए we will be giving oxytocin or we will be giving ergometrine. If not responsive, we can give PGF2 alpha analog. ठीक है. And in the January 2023, what they asked, that in a patient with the history of bronchial asthma, which of the following drug will not be used? So carboprost वहाँ पे था. So carboprost will also be associated with bronchoconstriction. Therefore, they should be contraindicated in patients with history of bronchial asthma. With the history of bronchial asthma, they should be contraindicated. So I think it's pretty clear कि हम PYQ जो पिछले वाले आए थे उसको भी डिस्कस कर ले रहे हैं, एंड आने वाले क्वेश्चंस भी पोटेंशियल MCQ आर आल्सो बीइंग डिस्कस्ड एज वी आर प्रोसीडिंग. एल्प्रोस्टाडिल, इट इज वन ऑफ द PGE1 एनालॉग. एल्प्रोस्टाडिल एक ऐसा प्रोस्टाग्लैंडिन जो दिल पे काम कर रहा है. तो आई टोल्ड यू टू इंपॉर्टेंट थिंग जो दिल से जुड़े हुए. एक तो इरेक्टाइल डिसफंक्शन दिल से जुड़ा हुआ है, आई मीन अगर आप समझ सकते हैं तो, और दूसरा कौन सा दिल से जुड़ा हुआ मामला है जिसको हम बोलते हैं, देयर इज नोन एज इन अ ट्रांसपोजिशन ऑफ ग्रेट आर्टरी to maintain the patency, of ductus arteriosus. So दो दिल के जुड़े मामले हैं, right? Erectile dysfunction and in a transposition of great artery, that's a cardiac malformation that we see. Next one, let's see. A patient with history of psychiatric condition on some medication was brought to the emergency with sudden hypertensive episode after consuming wine. So psychiatric condition में wine के बाद अगर problem आ रहा है, so which drug will be causing this possible outcome? I mean, the outcome is hypertensive emergency like scenario. Okay, so usually remember guys, psychiatric condition में अगर patient, मान लीजिए एक patient है depression का है, if there is a patient with depression, or if there is a patient on Parkinson disease, he could be on MAO inhibitor like मेरा बेटा शेरा जैसा MAO inhibitor, सेलेजिलिन, रासाजिलिन, याद है कि नहीं? सेलेजिलिन, रासाजिलिन है ना, सेलेजिलिन, रासाजिलिन, they are the MAO inhibitor है ना. डिप्रेशन में मोक्लिवेमाइड. So which of the following drug can cause the problem? Now phenelzine is a MAO inhibitor. Do remember some students are telling sir MAO inhibitor था, कुछ बोले सर नहीं सर फेनेजिलिन था पक्का, गारंटीड है सर, लिख के लो फेनेजिलिन था. तो यूजुअली समझिए जब 3 ऑप्शन रहता है ना ड्रग का नाम, तो चौथा ऑप्शन भी ड्रग ही होता है. कभी एग्जामिनर ऐसा डिस्क्रिपेंसी नहीं करेगा दैट देयर विल बी 3 ड्रग्स एंड 1 क्लास, है ना. दैट इज यूजुअली नॉट आइडियल सिनेरियो. तो whenever they give the class, they will always give all the classes. तो चारों का क्लास रहता है, अल्फा ब्लॉकर या TCA या SSRI. अगर 3 का ड्रग था और एक आप बोल रहे हैं MAO इनहिबिटर, सो दैट इज समथिंग दैट आई कैन नॉट डाइजेस्ट. सो अगर फेनेल्जिन है तो फेनेल्जिन बच्चे बोल रहे हैं, तो आई एम टोटली एग्रीइंग दैट देयर वर चांसेस दैट पॉसिबली फेनेल्जिन वाज देयर. फेनेल्जिन इज अ MAO इनहिबिटर, है ना, एंड MAO इनहिबिटर कैन डेफिनेटली कॉज, MAO इनहिबिटर वाला पेशेंट अगर वाइन कंज्यूम करता है या कोई भी ऐसा फूड कंज्यूम करता है जिसमें टायरामीन होता है, सो दैट विल बी लीडिंग टू सर्टेन प्रॉब्लम. वी कॉल देम एज द चीज रिएक्शन. ठीक है. So what is the treatment? So for the treatment we will be using phentolamine. Phentolamine is one of the non-selective alpha blocker. Phentolamine is a non-selective alpha blocker. Clear? So again, this is a recall. Quickly let's go through all these questions. Which of the following adverse effect is not seen even after a year of lithium therapy? So lithium side effect, isn't that we have already discussed lithium side effect. L stand for your leukocytosis. Lith is a simple mnemonic that I told you, leukocytosis. I stand for your insipidus. So which insipidus? So diabetes insipidus. Then we have tremor. Tremor happens to be the most common side effect. Tremor is the most common side effect. It is also a teratogenic, so pregnancy may we should try to avoid because it is associated with Epstein. Isn't that it has been asked in 2021 FMGE, which of the following drug will be causing Epstein anomaly? So in upcoming examination they can ask you Epstein anomaly, patient will have which type of chest x-ray? तो box shape heart, tin से बनता है box shape heart, है ना, Epstein box shape heart, and hypothyroidism. So these are the side effects that we have discussed a couple of times already. Lith is a very, very simple mnemonic for you to remember. So will it cause hypothyroidism? Yes. Diabetes insipidus? Yes. Will it cause tremor? Yes. Why will it cause tardive dyskinesia? Look at the tardive dyskinesia. Tardive dyskinesia, it is an extrapyramidal symptom. Tardive dyskinesia, it's one of the extrapyramidal symptom. Okay, that is mainly associated with the typical antipsychotics. With the typical antipsychotics, antipsychotics will be causing, associated with typical antipsychotics mainly. All right. Next, which of the following non-depolarizing muscle relaxation will be causing Hoffman? I think ये क्वेश्चन तो पढ़ने का और इसमें टाइम स्पेंड करने का जरूरत ही नहीं था. Hoffman degradation due to structure rearrangement, some drug will be inactivated. So you can consider this as an anesthesia, consider this as a pharma, hardly matters क्योंकि दोनों लोग पढ़ाते हैं. ठीक है. Hoffman degradation दो जगह होता है, cis atracurium, atracurium, है ना? Cis atracurium, atracurium. That is why they are considered safer in the renal failure patients. So next time they can give you this case based scenario, patient with the renal failure history and also hepatic failure history. Which of the following non-depolarizing muscle will be preferred? So safer in renal failure or hepatic failure will be cis atracurium because it's undergoing Hoffman degradation. So they are getting inactivated not by enzymatic metabolism but through the structural rearrangements. A young person is planning a trip to Ladakh. What is Ladakh? A place full of mountain. So mainly examiner is mainly asking mountain sickness. अब इसमें इससे ज्यादा आसान क्या होगा? Instead of telling a patient going to mountain, they use a place, है ना? That mountain sickness. So mountain sickness के लिए what is the drug that will be preferred? Acetazolamide is a carbonic anhydrase inhibitor. This carbonic anhydrase inhibitor, it can also lead to your CSF acidosis. Boys and girls, any CSF acidosis, it will be doing what? It will cause any CSF acidosis whenever it is going to happen, it will be causing hyperventilation. Any CSF acidosis will be causing hyperventilation and because of that there will be CO2 washout and oxygen ka intake hoga. So in mountain sickness again, this is something that you can utilize. Mountain sickness you can utilize carbonic anhydrase inhibitor. We are having acetazolamide, dorzolamide, there are so many other drugs in this one, dichlorphenamide. Okay, so acetazolamide के multiple uses है ना. Acetazolamide इसके uses जो होते हैं मैं आपको बता चुका हूँ पहले. MECA is the mnemonic. So since this time they ask mountain sickness, they can ask you next time other. Mountain sickness is one of the area where it is the drug of choice. In epilepsy, like in a catamenial epilepsy we can use. In a glaucoma we can use. In angle closure glaucoma and also for the alkalinization of the urine. This alkalinization of urine, boys and girls, it is required mainly in the acidic drug poisoning. है ना? So MECA is a simple mnemonic. So expected MCQ will be other use of acetazolamide. Sumatriptan is a drug for migraine. Is hyoscine scopolamine mainly for motion sickness. Promethazine is something that can also be used for the motion sickness. Okay. Next one. Thyroid hormone. Now you can consider this as a pharma, you can consider this as a physiology. We both used to discuss this. Thyroid hormone, thyroid. So they will be acting mainly by nuclear receptor. So we used to say what? That nuclear, nucleotide. So nuclear receptor se karne wale, we will be having thyroid, retinoic acid receptor, aryl hydrocarbon receptor, PPAR, peroxisome proliferator activated receptor, alpha and gamma. So all of them, they are going to act via your nuclear receptor. Nuclear receptor. Now nuclear receptor सब family दो तरह के होते हैं. कुछ साइटोप्लाज्म में होते हैं, कुछ न्यूक्लियस में होते हैं. Now these are mainly present in the nucleus. Nuclear receptor present in the nucleus. साइटोप्लाज्म में कौन से होंगे? Which all will be present in the cytoplasm. So remember mainly the steroids, है ना? Mainly the steroids like glucocorticoid, mineralocorticoid, sex steroid like your androgen, progesterone. Now there are some controversy to this as well because in Goodman-Gilman at places they have mentioned that they are acting on nuclear. Do remember they are all nuclear only. Nuclear के सब family हैं. Nuclear receptor पूरा है family है. उसके अंदर दो family है. Nuclear receptor present in the nucleus, nuclear receptor present in the cytoplasm, and a vitamin D as well. Its site is mainly present in the cytoplasm. Right, so these are the thyroid hormone receptor that we are having. They are mainly acting as nuclear, not ligand gated or G protein or tyrosine kinase. Tyrosine kinase is the enzymatic receptor that we know already. Okay, ligand gated will be all the ion channels, like calcium chloride mediated, like GABA, GABA A, GABA C, nicotinic receptor, NMDA receptor, 5-HT3 receptor. They will be acting via your ligand gated. Let's see the next question after this one. The next question that we have is which of the following agent is preferred in a patient with facial palsy? So facial palsy again nerve paralysis hai. So you will be giving steroids. This is the drug of choice. Agar wo hota ki if there is a patient with a history of some viral infection, then we would give steroid and acyclovir as well as acyclovir. है ना, जिसको Ramsay Hunt syndrome बोलते हैं. But here अगर facial palsy सिर्फ दे रहा है या some nerve inflammation is ongoing, we'll be using anti-inflammatory agent steroid like prednisolone. Okay. Next, which of the following agent is not used in the bacterial vaginosis? Not used in bacterial vaginosis. Usually, the preferred agent is tinidazole, metronidazole. Bacterial vaginosis, mein you will be using metronidazole, tinidazole. Clindamycin is something that can also be used, but what is not used will be your erythromycin. Erythromycin, it's one of the macrolide. Erythromycin is one of the macrolide, like clarithromycin and all. Clarithromycin, erythromycin, azithromycin, they will not be having a use in bacterial vaginosis, and metronidazole being the preferred agent. Next one, which of the following is not acceptable? Again, there were a lot of controversy around this one as well. Not acceptable as an emergency contraceptive with respect to the doses and sometime with respect to this 0.05 or 0.75. Now, what I came up from some of the students are दो क्वेश्चन आए थे. एक में लीवोनोर्जेस्ट्रल के बारे में 0.75 डोज था और एक में 0.05 था, लेकिन ये जो इमरजेंसी कॉन्ट्रासेप्शन वाला था इसमें दे डायरेक्टली गिव 0.075. So sir, this question was as it is mentioned here. So I hope you guys are getting this point that examiner when asked this one, है ना, you will be going ahead and reading the question very very carefully. Not acceptable. Combined oral contraceptive pill 2 tablets after 12 hours, है ना, 2 tablets immediately and 2 12s after 12 hours within 2 days. Ulipristal 30 mg single dose within 5 days. Centroman, right, 50 mg 2 tablets 12 hours apart within 24 hours. So ये वाला जो term था ना, this was a little confusing for all the students. बोल रहे थे बच्चे सर काफी बड़ा बड़ा ऑप्शन लग रहा था, but I think this was something that you should know that levonorgestrel का either we use 0.75 or we use 1.5. दोनों में से कोई एक यूज करते हैं. नॉट एंड दिस विल बी यूजिंग, अगर ये यूज कर रहे हैं दिस विल बी यूजिंग एज ए सिंगल डोज विद इन 72 आवर्स. ठीक है. एंड 0.75 इट विल बी यूज 2 doses 24 hours apart. 2 doses 24 hours apart. 0.75 अगर देते हैं तो 2 doses 24 hours apart. So this will be the correct answer here. Levonorgestrel 0.005 is not an acceptable as an emergency contraception. Okay. Next one, let's see very quickly. Emergency contraception का again a quick summary that we are having within 72 hours क्या देंगे or within 5 days. Within 5 days or best that we are having is IUCD, that's the most preferred one. Some students were saying sir IUCD भी option था. See, even if IUCD was there in option, that is an acceptable. That's an acceptable emergency contraception within 5 days. Ulipristal 30 mg as soon as possible or within 5 days. That is there in the option. Combined oral contraceptive pills immediately 2 tablets. One is after 12 hours, one is immediately. Levonorgestrel 1.5 mg single or 0.75 2 tablet, not 0.075. ठीक है. और Ormiloxifene, Centropan also can be used for emergency contraception. Do remember, it's for emergency contraception, not for abnormal uterine bleeding or not for regulating the menstruation. उसके लिए नहीं यूज कर रहा है. emergency contraception का क्या डोज है उस पर भी ध्यान रखना है. Many people were telling सब वीकली देते हैं all, है ना. तो आइडिया देखिए कि कहाँ पे पूछ रहा है, कहाँ पे देना है. Is it for regulation of the menstruation or is it for emergency contraception? Okay. Now let's see the next one. A patient given penicillin. Now penicillin mediated hypersensitivity is IG mediated type 1. So ये तो मैं बार बार बोल चुका हूँ, है ना, जब भी हम ऑटोनॉमिक नर्वस सिस्टम एड्रेलिन पढ़ते हैं, है ना. सो इसमें द ड्रग ऑफ चॉइस इट इज गोइंग टू बी एड्रेलिन, है ना. एड्रेलिन 1:1000 intramuscular route. So you can say that this is a pharma question, micro question, patho question, doesn't matter. अगर आपने इन तीनों में से कोई भी क्लास किया है तो तीनों लोग पढ़ाए. अगर मैं फार्मा की बात करूं तो आई हैव डिस्कस विद ऑल ऑफ यू गाइस वेयर आई वाज डिस्कस द एड्रेलिन कहाँ देंगे तो पेनिसिलिन मीडिएटेड हाइपरसेंसिटिविटी रिएक्शन एग्जैक्ट केस मैंने लिख के दिया हुआ है, देखिएगा आप लोग. ठीक है. तो व्हाट विल बी द एंटीबॉडी मीडिएटेड, तो आईजी मीडिएटेड टाइप 1 हाइपरसेंसिटिविटी रिएक्शन. ओके. हाइपरसेंसिटिविटी पे 3 क्वेश्चन थे, 2 फार्मा से इंटीग्रेटेड थे. अ पेशेंट विद लेप्रोसी. सो लेप्रोसी में 2 तरह के लेप्रा रिएक्शन हो सकते हैं. लेप्रा रिएक्शन कैन बी ऑफ 2 टाइप. वन इज नोन एज टाइप 1 लेप्रा रिएक्शन एंड अदर वन इज नोन एज टाइप 2 लेप्रा रिएक्शन. टाइप 1 लेप्रा रिएक्शन इज type 4 hypersensitivity because I told you that the total score or rule of 5 should be followed. Rule of 5 should be followed. Type 1 will be fourth type of hypersensitivity और type 2 will be टाइप 3 हाइपर सेंसिटिविटी. तो रूल ऑफ 5 हो गया, बिकॉज अल्टीमेटली आपको दोनों को मिला के 5 बनाना है, तो 2 और 3 5 हो गए और 1 और 4 यहाँ 5 हो गए. तो इफ यू ऑलरेडी नो द रूल ऑफ 5 देन यू कैन टेल मी टाइप 2 लेप्रा रिएक्शन में कौन सा होगा. 2 और 3 5 बनाना है तो टाइप 3 हाइपर सेंसिटिविटी रिएक्शन, राइट. सो लेप्रा रिएक्शन इज टाइप 2 विल बी टाइप 3 हाइपर सेंसिटिविटी रिएक्शन. So 2 questions of hypersensitivity reaction. In fact, there were 3 questions of hypersensitivity reaction total. 2 can be integrated easily with the pharma, and we usually very commonly discuss this. A patient with pheochromocytoma underwent surgery. Which of the following agent is given prior to the surgery to control the intraoperative hypertension? Now pheochromocytoma का नाम जहाँ कहीं भी आए, what is one drug that you are going to prefer? The drug of choice for pheochromocytoma, it is none other than the drug of choice for pheochromocytoma. It is none other than your phenoxybenzamine. Look at the name, such a big name, phenoxybenzamine, used for pheochromocytoma. Such a big name, phenoxybenzamine, used for pheochromocytoma, right? Now phenoxybenzamine is one of the non-selective alpha blocker, that is alpha 1 alpha 2 both blocker, and it is always added, we are always going to add phenoxybenzamine with, है ना, हम इसके साथ बीटा ब्लॉकर ऐड करते हैं और इसी ऑर्डर में देते हैं, पहले अल्फा ब्लॉकर फिर बीटा ब्लॉकर, इसी ऑर्डर में देते भी हैं, ठीक है. नाउ अल्फा एड्रेनर्जिक ब्लॉकर इज द आंसर हियर, वेरी वेरी इजी, है ना, वेरी वेरी इजी. नाउ दिस टाइम अगेन सी, दे आर नॉट गिविंग नेम ऑफ द ड्रग, दे आर गिविंग क्लास ऑफ द ड्रग, है ना. सो फेनॉक्सीबेंजामिन सबने रट लिया, आप किस क्लास का ये बताओ, इज इट बीटा ब्लॉकर, अल्फा ब्लॉकर? कैन वी यूज बीटा ब्लॉकर? यस, बट डू रिमेंबर, अगर पूछ रहा है कौन सा प्रिफरेबल है हमारे लिए, तो पहले हमेशा हम अल्फा एड्रेनर्जिक ब्लॉकर ही देते हैं, ठीक है. 5 alpha reductase inhibitor will be utilized for BPH. Phosphodiesterase inhibitor, we are having many type of phosphodiesterase. Phosphodiesterase 3 in heart failure, it has antiplatelet activity. Phosphodiesterase 4 can also be used in COPD as an anti-inflammatory. Phosphodiesterase 5 in a patient with the erectile dysfunction we can also use, like sildenafil, tadalafil. Okay, so we quickly revise that as well. Next, a patient consumed an anti-emetic agent metoclopramide. Which of the following statement is incorrect about this drug? Which of the following is incorrect? Now metoclopramide is what? It's a D2 blocker, it's a prokinetic, and what we know already that this prokinetic, it's similar to your domperidone, but domperidone does not cross the blood-brain barrier. This actually crosses the blood-brain barrier. Because it crosses blood-brain barrier, it can cause D2 blockade in the CNS as well, and it will be associated with extrapyramidal symptom. That is why not a very commonly used prokinetic agent. So can cause hyperprolactinemia. See, dopamine always have inhibitory effect on the prolactin. Dopamine हमेशा prolactin को रोक के रखता है, भाई सब रुक जाओ, ज्यादा मत जाओ, है ना, ज्यादा सिगरेट नहीं हो. Now if dopamine is inhibited, prolactin level will automatically be high. So hyperprolactinemia. So can it cause hyperprolactinemia? Yes. Can it cause extrapyramidal symptom? I just mentioned yes, it will be causing extrapyramidal symptom like dystonia, akathisia, है ना. It crosses blood-brain barrier. That is how it is going to cause CNS symptom. It is safer than domperidone? No, it is not safer than domperidone. Domperidone is more safer because domperidone does not produce extrapyramidal symptom like dystonia, akathisia, oculogyric crisis. Okay, next one, oculogyric crisis. A 55-year-old diagnosed with cervical cancer. What is the drug of choice? Cervical cancer, drug of choice, cisplatin. Have I already told you that cisplatin, it is one of the platinum compound? It is considered the drug of choice in many conditions. It is considered the drug of choice in a patient with a head and neck cancer. It is considered the drug of choice in a patient with the upper GI cancer. Upper GI cancer like esophageal cancer, mein it is the drug of choice. It is also considered the drug of choice in a patient with a gastric cancer. It's the drug of choice. It's also the drug of choice in a patient with the cholangiocarcinoma. We have discussed this. Cholangiocarcinoma, cisplatin. It's also the drug of choice in a patient with the genitourinary carcinoma. तो genitourinary carcinoma में क्या क्या आ जाएगा? What all things will come in genitourinary carcinoma? So there will be bladder cancer. There will also be, है ना, cervical cancer, ovarian cancer, testicular cancer. All this will come. Testicular cancer, all this will come, and all these are going to be the indication of your cisplatin. In fact, cisplatin can also be used in a patient with a lower GI carcinoma, but not the drug of choice. Lower GI cancer में drug of choice होता है. Drug of choice in lower GI cancer, that can be potential MCQ, is going to be 5-fluorouracil. 5-fluorouracil. But can we use cisplatin also? Yes, we can use cisplatin as well. So it's a very, very simple question. We are not going to use selective estrogen receptor modulator like tamoxifen. Paclitaxel is one of the taxanes MPhase inhibitor that is having multiple uses, like for example ovarian cancer, breast cancer. Adriamycin again is a drug that is not the drug of choice. Drug of choice पूछता है तो cisplatin becomes the drug of choice. ठीक है. Next, 60-year-old female presented with cervical carcinoma. Now I got two versions of this one. Hours ago only I got this version that there is a 60-year-old female and she was diagnosed with cervical cancer. She was treated with cisplatin. तो cisplatin पे दो क्वेश्चन हो गए, हाइपर सेंसिटिविटी पे दो क्वेश्चन हो गए. विच ऑफ द फॉलोइंग द मोस्ट इंपॉर्टेंट टॉक्सिसिटी. नाउ कुछ बच्चे बोल रहे थे कि सर मोस्ट कॉमन साइड इफेक्ट आएगा. सी मोस्ट कॉमन तो यूजुअली जीआई रिलेटेड साइड इफेक्ट आता है. मोस्ट पीपल जितने लोग को देते हैं ज्यादातर लोग को नोजिया वोमिटिंग होता ही होता है. तो जीआई साइड इफेक्ट इज नोजिया वोमिटिंग डायरिया. तो ज्यादातर लोगों में नोजिया वोमिटिंग होगा. तो मोस्ट पीपल अगर पूछते हैं तो नोजिया वोमिटिंग. बट स्टूडेंट्स क्लियरली सेड सर मोस्ट कॉमन नहीं था, मोस्ट इंपॉर्टेंट टॉक्सिसिटी था. तो मोस्ट इंपॉर्टेंट टॉक्सिसिटी रिमेंबर थोड़ा सा चेंज किया, थोड़ा सा लैंग्वेज, मोस्ट कॉमन से मोस्ट इंपॉर्टेंट टॉक्सिसिटी बोल दिया तो तुरंत से वक्त, जज्बात, हालात सारे बदल गए, है ना. आंसर बदल गया. GI टॉक्सिसिटी से अब इसका आंसर क्या होता है? नेफ्रोटॉक्सिसिटी. एंड फॉर द प्रिवेंशन ऑफ द नेफ्रोटॉक्सिसिटी वी गिव फ्लूइड लोड, फ्लूइड लोडिंग करते हैं, क्लोराइड डायूरेसिस करते हैं, एंड वी ऑल्सो यूज अ नेफ्रोप्रोटेक्टिव एजेंट एमीफॉस्टीन. एमीफॉस्टीन इज अ नेफ्रोप्रोटेक्टिव एजेंट, है ना. So do remember, it is not something that will be causing mainly pulmonary fibrosis. It is a side effect that is associated with bleomycin, busulfan, cyclophosphamide, methotrexate. They will be causing pulmonary fibrosis. तो देखा आपने, है ना, थोड़ा सा लापरवाही का नतीजा, है ना. तो ध्यान रखना है, क्वेश्चन को बहुत ध्यान से पढ़ना है. एंड सिली मिस्टेक्स आर द मोस्ट कॉमन कॉज ऑफ मिस्टेक दैट वी ऑलवेज यूज्ड टू से इन द क्लास एज वेल. आई ऑलवेज यूज्ड टू से इन द क्लास. ठीक है. विच ऑफ द फॉलोइंग कॉजेज थाइमिडीन लेस डेथ ऑफ द कैंसर सेल. थाइमिडीन लेस डेथ, दैट मींस थाइमिडीन इज वन ऑफ द पिरिमिडीन. सो एग्जामिनर इज आस्किंग कि इनमें से कौन सा है जो पिरिमिडीन के फॉर्मेशन को इनहिबिट करेगा. तो पिरिमिडीन के फॉर्मेशन को वही इनहिबिट करेगा विच इज हैविंग पिरिमिडीन लाइक एक्टिविटी. सो ओनली वन दैट इज हैविंग पिरिमिडीन एनालॉग इज 5-fluorouracil. As simple as that. Thymidine is one of the pyrimidine, है ना. 6-mercaptopurine is a purine analog. Methotrexate is one of the dihydrofolate reductase analog, not inhibitor, analog. Cyclophosphamide, it's one of the alkylating agent. ठीक है. तो थाइमिडीन लेस डेथ, जब आप एंटी कैंसर चैप्टर खोलोगे, रेगुलर वाले लेक्चर में, मेन लेक्चर में चेक कर सकते हैं, एंटी कैंसर ड्रग जब आप खोलेंगे तो एग्जैक्टली सेम लाइन, ये जानते हैं कहां से उठाया गया? दिस एग्जैक्ट सेम लाइन हैज बीन टेकन फ्रॉम गुडमैन गिलमैन, है ना. उसको बोल्ड करके, अंडरलाइन करके, है ना, सेमी कॉलन में दिया हुआ है. दिस ड्रग विल बी कॉजिंग थाइमिडीन लेस डेथ, है ना, थाइमिडीन लेस डेथ. ओके. Pediatric patient brought with fever, status epilepticus. He has history of similar episode before. And which of the following step will be used in the management of this patient? Now, अगर पेशेंट को फीवर है और स्टेटस एपिलेप्टिकस है, you don't only treat the fever, no, है ना, and you're not worried mainly about BP, and you're not only going to rely on clobazam. Clobazam is a type of benzodiazepine. Their activity is like a benzodiazepine only. They are one of the GABA A analog, है ना. So their activity is like benzodiazepine. Clobazam is something that is used in a patient with the Lennox-Gastaut syndrome along with other drugs. Along with other drugs, we can use clobazam, है ना. Other anti-epileptic drugs we can use clobazam. But अगर यहाँ पे आ रहा है status epilepticus में, तो we are going to prefer midazolam. Now remember, अगर आपके पास ऑप्शन दोनों हो कि midazolam और lorazepam, तो अगर IV access है, ask और check IV access is there, then go for IV lorazepam. Go for IV lorazepam. But यहाँ पे कुछ मेंशन नहीं किया है, बस बोल रहा है कि can we use midazolam? Yes. अगर IV एक्सेस नहीं है, then we are going to prefer midaz. So we can give midaz as well, midazolam as well. Do remember, है ना. यहाँ से पेशेंट स्टेटस एपिलेप्टिकस के साथ आ रहा है. So this is one of the American Epilepsy Society का समराइज्ड गाइडलाइन है. This is from American Epilepsy Society का समराइज्ड गाइडलाइन है. Read the discussion here very carefully. If no IV access available, then can we use midazolam IM? Yes. We can use midazolam IM, or we are also having buccal. डोज इंपॉर्टेंट नहीं है, बट मिडाज आपको दे सकते हैं, IM दे सकते हैं. अगर IV एक्सेस अवेलेबल है, देन डेफिनेटली वी आर गोइंग टू प्रेफर व्हाट? IV लोराज़ेपाम. ठीक है, बहुत सिंपल सा डिस्क्रिप्शन है, कुछ ज्यादा कॉम्प्लिकेशन है नहीं, है ना. कैन वी यूज मिडास? यस, because we are having IEM preparation as well. IV lorazepam definitely is a drug of choice. ठीक है. अगर इससे रिस्पॉन्ड नहीं करता है, if it is non responsive to this one, then we are going to give fosphenytoin. Fosphenytoin is one of the pro drug of phenytoin, है ना. और we can give other anti epileptic drug like levetiracetam, है ना, और valproate. उससे भी काम नहीं चलता है ना. मान लीजिए आपने मिडास और लोराजिपाम दिया, डायाजिपाम दिया, काम नहीं चला तो आपने फॉस्फेनिटोइन दिया. फॉस्फेनिटोइन अगर नहीं था तो यू कैन गिव लेट्स से लेवेटिरासेटाम, वालप्रोएट, राइट. इससे भी काम नहीं चला, देन यू विल गिव बार्बिटूरेट. इफ स्टिल नॉट रेस्पॉन्सिव टू दिस वन, देन यू कैन एक्चुअली sedate द पेशेंट. यू कैन गिव जनरल एनेस्थीसिया लाइक यू कैन गिव प्रोपोफॉल, यू कैन गिव कीटामीन, है ना. तो ये समराइज डेटा मैं आपको बता रहा हूँ, है ना. यू आर गोइंग टू एनेस्थेसाइज द पेशेंट. ठीक है. तो ये हो गया आपका स्टेटस एपिलेप्टिकस. नाउ यू कैन सी that this will be a very much similar to pediatrics, very much similar to what was discussed in medicine, similar to what was discussed in pharma. We have discussed this already, right? So midas can we give? Yes, midas is something that can also be utilized. Next, 5-year-old child brought to OPD by parents with complaints of squint and decreased vision for doing the refraction testing. अगर आपको याद होगा तो कुछ दिन पहले एलन के पेज पे भी और मेरे इंस्टा के पेज पे भी सेम क्वेश्चन, एग्जाम के जस्ट 3 दिन पहले ये क्वेश्चन पोस्ट हुआ था, है ना, कि फॉर टेस्टिंग द रिफ्रैक्शन इन अ पीडियाट्रिक पॉपुलेशन व्हाट विल यू यूज. सो पीडियाट्रिक्स में वी आर गोइंग टू यूज एट्रोपिन, और प्रॉपर डिस्क्रिप्शन भी मैंने दिया हुआ है कि इन पीडियाट्रिक पॉपुलेशन द सिलरी मसल टोन इज वेरी हाई. सिलरी मसल टोन इज वेरी हाई. सो गो अहेड एंड ज्वाइन LNX का जो इंस्टा है उस पर भी काफी MCQ हम पोस्ट करते रहते हैं ऑन रेगुलर बेसिस, सो दैट नोविंगली और अननोविंगली, अनइंटेंशनली अगर आप स्क्रॉल भी कर रहे हो तो कुछ लर्निंग हो जा रही है ना. सिलरी मसल टोन क्या होता है? हाई होता है. किसका? पीडियाट्रिक पॉपुलेशन में. तो विल बी यूजिंग पोटेंट, है ना, पोटेंट ऑइंटमेंट यूज करते हैं, ध्यान रखिएगा. ड्रॉप नहीं यूज करते हैं, ऑलवेज ऑइंटमेंट, बिकॉज ड्रॉप विल हैव मेनी ऑफ द सिस्टमिक साइड इफेक्ट लाइक एट्रोपिन फीवर. ठीक है. बट एडल्ट में क्या प्रीफर करेंगे? इन एडल्ट we will be preferring tropicamide. If tropicamide is not there in option, then we can also go ahead with the cyclopentolate. This goes in the same order. ठीक है. Tropicamide is the milder one, and most potent one is the atropine, that is lasting for around 7 to 10 days. And in some textbook they also say up to 14 days half life इसका loss कर सकता है atropine का. तो adult में usually we avoid this one, है ना, because there will be prolonged blurred vision. No, we should avoid that. Which is correct regarding step criteria of the drug? Step criteria of a drug, है ना. I remember I discussed it twice, thrice only. फिर मुझे लगा कि ये ज्यादा हो रहा है. तो अगर आप पुराने लेक्चर्स देखोगे तो स्टेप क्राइटेरिया, इट इज मेनली फॉर चूजिंग P drugs, फॉर चूजिंग द P drugs, फिजिशियंस ड्रग, है ना, फिजिशियन ड्रग. तो आजकल जितने भी मेडिकल कॉलेजेस में आप जाओ तो देयर आर फ्यू टॉपिक्स दैट आर डिस्कस्ड इन वेरी मच इन डिटेल. जैसे कि मैं आपको आज बता रहा हूँ, एक पी ड्रग है जिसको अच्छे से इस पे लैब होता है, प्रॉपर इसका डिस्कशन होता है ना. ड्रग प्रोमोशनल लिटरेचर, DPL जिसको बोलते हैं, ड्रग प्रोमोशनल लिटरेचर, ये आपके सिलेबस का है, ड्रग प्रोमोशनल लिटरेचर, है ना. और जो एग्जामिनर है वो somehow they belong to these areas, ड्रग प्रोमोशनल लिटरेचर, बिकॉज आपके एग्जामिनर कहीं मार्च से तो नहीं आ रहे, इसी प्लेनेट के हैं, इसी किसी न किसी मेडिकल कॉलेज से होंगे, है ना. तो ट्राई टू अंडरस्टैंड, ये मेडिकल कॉलेज में बहुत स्ट्रिक्टली फॉलोड लैब टॉपिक्स हैं जो डिस्कस होते हैं, है ना. एसेंशियल मेडिसिन का टॉपिक, है ना. ORS वाला टॉपिक, है ना. रैबिट आई वाला टॉपिक, है ना. एंड सम हार्ट वाले जो अफेक्ट ऑफ सर्टेन ड्रग्स ऑन द हार्ट, ये सारे बहुत ही डिटेल में डिस्कस किए जाते हैं कॉलेजेस में. तो इसलिए आपको ध्यान रखना पड़ेगा स्टेप मेनली, है ना, सेफ्टी, टॉलरेबिलिटी, है ना, एफिकेसी एंड प्राइस यानी कि कॉस्ट, है ना. तो ये स्टेप ऐसा कोई क्राइटेरिया नहीं है, ये एक कॉन्फ्रेंस ने, एक स्पीकर ने इसको समराइज करने के लिए, सिंप्लीफाई करने के लिए उन्होंने यूज किया था स्टेप क्राइटेरिया, और जब से ये यूज हो रहा है, ऐसा कोई हार्ड एंड फास्ट नहीं है ना. सेफ्टी, एफिकेसी, सुटेबिलिटी, कई लोग ऐसे भी बोल देते हैं, लेकिन स्टेप क्राइटेरिया अगर बोल रहा है तो मेनली दिस इज फॉर चूजिंग द कॉन्सेप्ट ऑफ द पी ड्रग, नॉट फॉर द क्लिनिकल ट्रायल और फॉर द वॉल्यूम डिस्ट्रीब्यूशन ऑफ द ड्रग मेटाबॉलिज्म. तो पी ड्रग को चुनने के लिए हमारे पास बहुत सारे तरीके हैं, एंड फॉर द क्राइटेरिया दैट वी आर यूजिंग इज द स्टेप क्राइटेरिया इज द सेफ्टी, tolerability, whether the patient will be able to tolerate or not, whether the patient will be able to take it or not, suitability of the patient. Like for example, if you have to choose oral drug versus per rectal drug, so you'll be choosing oral because oral will be more suitable for the patient, it will be more easy for him. And efficacy, how effective is the drug, and cost, cost should always be considered not in terms of per tablet but in terms of entire cost of the therapy. For example, let's say एक एंटीबायोटिक है मार्केट में 20 रुपए की आ रही है वंस डेली. लेट्स से मैं आपको एक नाम बता रहा हूँ, आपको अच्छे से पता चल जाएगा. एजिथ्रोमाइसिन आता है 500 मिलीग्राम वंस डेली, तो इसका आता है ₹20 पर टेबलेट. कोएमॉक्सिक्लेव 625 मिलीग्राम, इसको बीडी और टीडीएस डोज में देते हैं, और इसका भी आता है 20 पर टेबलेट. नाउ कैन यू से दैट दे बोथ आर हैविंग सिमिलर कॉस्ट? नो, because you have to consider the cost of the entire therapy. Amoxiclav अगर patient लेता है तो more or less he will have to spend around 200 or sometime more than 200 like 300. Azithromycin अगर लेता है तो around 110 रुपीस में काम हो जाएगा, because इसको once daily लेना है और इसको twice or thrice daily लेना है. बात समझ रहे हैं? तो you will be considering the entire cost of the therapy rather than discussing the per tablet. ठीक है, कॉस्ट पर यूनिट नहीं, पर टैबलेट नहीं. ठीक है, तो पी ड्रग के लिए फर्स्ट एंड फॉरमोस्ट पी ड्रग इज फिजिशियंस ड्रग ऑन द बेसिस ऑफ द एक्सपर्टीज ऑफ द फिजिशियन according to the disease that is prevalence in that area, in their area, they will be coming up with their P drug, है ना. Now this P drug can vary. Physician's drug, P drug मतलब physician drug or preferred drug. It is never personalized drug. Remember, it is preferred drug or physician's drug. It is never personalized drug. Please remember that, है ना. तो पहले diagnosis बनाइए, then you make what are the therapeutic objective that you are going to do here, and inventory मतलब what are the classes of drugs that you can use here. And out of that you use the step, the criteria that they are telling, that you use the step, that is safety, tolerability, efficacy and price, and then out of them which tops the list, choose that as a P drug, है ना. So in some areas, let's say upper respiratory tract infection, let's say for me I prefer giving azithromycin, but in some places I see in fact in just 200-300 kilometers from my place, I see the physicians are more preferring, let's say cefixime, or let's say some other cephalosporin or coamoxiclav, and they are telling for their patient in their area azithromycin is something that is not showing much effect. So it is totally dependent on the physicians on expertise, right? P drug. So step criteria is for choosing a concept of P drug. Okay, this was a pulmonary TB case in a pediatric population, and they asked that pediatric population में क्या कैसे ट्रीट करोगे. सी pediatric adult दोनों में ट्रीटमेंट सेम रहेगा. क्या रहेगा? So 2 HRZE, that is isoniazid rifampicin, pyrazinamide, ethambutol. pyrazinamide को मैं pyrazinamide को मैं जानबूझ के pyrazinamide बोलता हूँ. अगर आपने कभी मेरा TB क्लास लिया होगा तो मैंने बताया 5 रीजन क्यों मैं इसको pyrazinamide बोलता हूँ. ठीक है, प्लस 4 HRE. ठीक है, 4 HRE. Steroids is something that is not preferred until unless there is, let's say, CNS involvement or pericarditis involvement, right? Or some other systemic condition like, let's say, ocular infection like uveitis. उसमें हम steroid use करेंगे. Other than that हम steroid use नहीं करेंगे. तो 2 HRZE plus 4 HRE यही prefer करेंगे हम. We are going to prefer the same. And according to the guidelines of TB elimination program that we have, this is one table that we are having, HRZE that we are going to use. Do remember, streptomycin is a reserved drug. It is not given as a first line drug. It's a reserved drug. Category C drug में आते हैं. Aminoglycoside category C drug में आते हैं. ठीक है. But HRZE, according to the guideline of 2022, this table has been taken from the guideline of 2022. Do remember that steroids के, as I said, CNS condition like TB meningitis, cardiac condition like pericarditis, अगर पेशेंट को साथ में एडिसन्स डिजीज है या मिलियरी ट्यूबरक्लोसिस विद एल्वियोलो कैपिलरी ब्लॉक और टीबी यूवीआइटिस, ये सारे इंडिकेशन है स्टेरॉइड की अगर टीबी को ट्रीट करना है. और एंटी ट्यूबरकुलर के साथ इफ यू वांट टू गिव स्टेरॉइड, दीज आर द इंडिकेशंस. डू रिमेंबर दैट. ओके, 2 HRZE and 4 HRE. So this is again screenshot taken from 2022 का गाइडलाइन ऑफ टीबी पेशेंट, नेशनल टीबी एलिमिनेशन प्रोग्राम वाले PDF से लिया हुआ है. ठीक है. अ पेशेंट हैज अनकंट्रोल्ड पोस्टमार्टम ब्लीडिंग. Patient had PT and APTT was normal. There is history of similar kind of profuse bleeding in the past. Okay, so bleeding ज़्यादा हो रहा है, PT APTT normal है, and history in the past. That means कुछ तो deficiency है. So examiner is asking which vitamin deficiency. See, factor 8 deficiency will be causing some condition like, let's say, hemophilia A. This will be causing a condition called your hemophilia A. This will be causing a condition called your hemophilia B. ठीक है. And von Willebrand will be causing von Willebrand disease. बट यहाँ पे पीटी एपीटीटी नॉर्मल है, पूछ रहा है विच ऑफ द फॉलोइंग डेफिशिएंसी कैन कॉज, सो विटामिन के डेफिशिएंसी, बिकॉज विटामिन के डेफिशिएंसी होगा तो विटामिन के डिपेंडेंट फैक्टर्स विल नॉट बी फॉर्म. इफ दे आर नॉट गोइंग टू बी फॉर्म, डेफिनेटली देयर विल बी ब्लीडिंग. सो आवर ड्रग warfarin, isn't that we always discuss warfarin is a competitive inhibitor of vitamin K dependent factors. So some of them are clotting factor like 2, 7, 9 and 10 है ना, clotting factor like 2, 7, 9 and 10. Okay, 2, 7, 9 and 10. We are having one more question. This is integrated with medicine. I would say this is purely integrated with medicine. Addition disease में starting किससे करेंगे? So we will be starting with the 100 milligram. We are going to start with the 100 milligram in the addition disease steroid. है ना? So this is again for sickle cell crisis integrated with medicine. Remember, we will be preferring always heparin. Now some students were telling sir IV था, कुछ बोले थे subcutaneous था, कुछ बोले थे कोई नहीं था. तो sickle cell crisis में the preferred anticoagulant we prefer is always heparin. Remember, we are not going to rely on just by giving warfarin, because warfarin complete onset of action will be taking around 4-5 days and तब तक काफी सारे organ damage हो चुके होंगे, तो we will not be going ahead with that. And if you have to choose between rivaroxaban oral versus heparin injectable, we will definitely preferring heparin, है ना. Aspirin is for antiplatelet. Again, antiplatelet is something that should be avoided here because bleeding risk is already high है. So we will not be choosing aspirin is actually antiplatelet. और यहाँ पे हमें thrombus को अगर thrombus formation को inhibit करना है तो we'll be giving anticoagulant like heparin. Okay. So this was one of the very important question, and I think this was the last question that we had, and you can consider this an integrated question of the medicine. So quickly in the next let's say 50-60 सेकंड, 1 मिनट में जल्दी से सारे क्वेश्चन को देख लेते हैं. तो आई थिंक आई हैड अराउंड 35 क्वेश्चन. दैट इज शॉकिंग. 35 क्वेश्चन में लास्ट के 3 इंटीग्रेटेड विद मेडिसिन है, तो फिर भी कम कर दो अगर, तो 30 क्वेश्चन ऑन एवरेज मेडिसिन से फार्मा से आए हुए हैं. उसमें से भी 2 क्वेश्चन और हटा दो जो कुछ गायनी वाले हैं और एक एनेस्थीसिया वाले, तो 28 क्वेश्चन, 28 क्वेश्चन फार्मा से, जो आप फार्मा के नोट से कर सकते हैं. जो हॉफमैन एलिमिनेशन था वो भी फार्मा के नोट से कर सकते हैं. जो हाइपर सेंसिटिव रिएक्शन वाला था पेनिसिलिन इंड्यूस्ड, और योर लेप्रा ना, टाइप 2 लेप्रा रिएक्शन, वो भी कर सकते हैं, है ना. तो एक बार जल्दी 60 सेकंड में लेके चलते हैं आपको क्विकली, है ना. क्विकली एक बार जल्दी से रिवाइज कर लेते हैं फॉर ऑल ऑफ यू गाइस. सिकल सेल क्राइसिस में वी विल बी यूजिंग हेपारिन. एडिशन डिजीज में स्टार्टिंग डोज ऑफ स्टेरॉइड शुड बी 100 milligram, and vitamin K deficiency will be having prolonged history of bleeding. History of bleeding is always going to be there if there is a vitamin K deficiency. Then pediatric population, adult population, 2 HRE and 4 HRE. This is again according to the guideline as well. As I've told you, step is for choosing a P drug. P drug is physicians or the preferred drug. 5-year-old child brought to the OPD with squint. So pediatric population, if you want to do refraction, if you want to do mydriasis cycloplegia, you will be preferring atropine ointment. Adult में tropicamide. Then we are having midazolam for a patient with status epilepticus. अगर IV रूट है तो IV lorazepam प्रीफर करेंगे. IV एक्सेस नहीं है तो midazolam को हम IM दे सकते हैं, midazolam को हम बक्कल भी दे सकते हैं. Okay, which of the following causing thymidine less death? तो pyrimidine analog like 5-fluorouracil. Cisplatin therapy will be having most important toxicity like nephrotoxicity. To prevent that, amifostine will be preferred. ME में I यहाँ छूट गया, amifostine. ठीक है. 55-year-old patient diagnosed with cervical cancer, drug of choice cisplatin. Cisplatin will be the drug of choice in many cancer, as I mentioned there. And metoclopramide is unsafe. They will be causing extrapyramidal symptom. They are unsafe than domperidone. Intraoperative hypertension, pheochromocytoma, alpha blocker like phenoxybenzamine will be preferred. Lepra, type 2 lepra reaction, type 3 hypersensitivity, and penicillin induced hypersensitivity will be type 1 hypersensitivity. Emergency contraception के लिए levonorgestrel 0.075 नहीं होता है, 0.75 या 1.5 होता है. Which of the following not in bacterial vaginosis? की erythromycin is macrolide, not effective in bacterial vaginosis. Facial palsy में preferred will be steroid. Nuclear receptor, thyroid hormone will be acting on nuclear receptor. General pharma का बहुत favorite topic है ना. Then mountain sickness के लिए acetazolamide is something that will be preferred. Other use of acetazolamide we have already covered here. Cisatracurium, Hoffman elimination we have already discussed here. And adverse effect not seen in the lithium therapy. Lithium will not be causing tardive dyskinesia. Tardive dyskinesia is an extrapyramidal symptom associated with the typical antipsychotics that we have discussed already. Phenelzine is a MAO inhibitor. MAO inhibitor can increase the risk of cheese reaction or anything that is having a tyramine, tyramine rich food, wine, banana, beef, and all those things. or any food product that is having milk in it. Okay, carboprost will be preferred for the uterine contraction. In this scenario, it's a case-based scenario. You can say that this is integrated with gynae as well. Okay, well, ganciclovir will be preferred. Ganciclovir CMV retinitis, the drug of choice. 5-alpha reductase inhibitor for benign prostatic hypertrophy. Fluoxetine will be causing SSRI wale side effect. So again, serotonin syndrome, sexual dysfunction, restlessness, and insomnia. That is what it is seen here. Now some students are saying, sir, ऐसे नहीं आया था, वो सिर्फ पूछा था मेजर डिप्रेसिव डिसऑर्डर है, उसमें कौन सा एंटी डिप्रेसेंट है. तो इन पूरे लिस्ट में इकलौता एंटी डिप्रेसेंट है, दैट इज फ्लूक्सेटिन. फ्लूक्सेटिन इज ओनली एंटी डिप्रेसेंट, ऑल अदर्स आर used in some other condition like haloperidol is antipsychotic, bispirone is anxiolytic, lithium is used for mania. ठीक है, तो दोनों ही कंडीशन में आंसर सेम रहता है फ्लूक्सेटिन. Bedaquiline mechanism of action they asked, so ATP B or A, ATP synthase inhibitor, and do remember about other, that is delamanid, pitamid, manid, and manid, that is mycolic acid synthase inhibitor. For prevention of mother to child transmission, nevirapine for 6 weeks will be given 2 mg per kg. Immediately will be starting, within 72 hours we should start. देन डिफरेंट एंटीडोट पे 3 क्वेश्चन आए थे. एक तो आयरन के लिए आयरन ओवरडोज हो गया और ड्यू टू रिकरेंट ब्लड ट्रांसफ्यूजन, सो डेफेरिप्रोन वी हैव डिस्कस दिस वेरी फ्रीक्वेंटली. फ्लुमाजेनिल फॉर बेंजोडाइजेपिन ओवरडोज एंड फोमेपिजोल we are going to use for methanol or ethylene glycol poisoning, right? So this will be everything which we wanted to discuss in pharmacology recall. I hope it was beneficial for all of you guys. Feel free to drop your message in the recall section. Any question that you feel was not in the original form or was little distorted, that is very much possible, because again these are all recalls and recalls are having some fallacy, but this is the best kind of recall that we could try to collect the maximum data, and we have discussed with many students actually to come up with the best form of this question, right? So thank you very much to all of you guys. I'll see you around in the upcoming classes. Bye bye.
So hello and welcome all of you. So I'm Dr. Ankit, your faculty of anatomy in our Next, and this session over there is a recall session. So we had our exam of FMG on 30th of July, and this is a recall session of the subject anatomy. So first of all, big relief for all of you, and I wish you all the best so that you score 150 plus and you clear this exam. Second thing is a big relief, and these sessions have dual benefits, minimum dual benefits. For example, if you have already given the exam, you'll be able to see what questions you did right or wrong. That is a part, because that nothing can be done now, but still you have some topics because the fight has not yet ended. You'll be giving further exams after this, so you will have to know and recall all these topics that you have to prepare for future exams also. So that is one benefit. The second benefit are for your juniors who are going to give the exams, because they will be knowing what are the important topics and what are the questions that have been asked and which ways they are asking, and how the things are changing with each passing year. So these are the benefits, and again I wish you all the best. So just relax and enjoy the session. And this is our anatomy subject, and these are all the recalls given by many students who gave the exams. Let's start with the session over here. The first question which came from the anatomy side was after vaginal delivery, a female presented with pain on the anterolateral aspect of the thigh. Which nerve was injured? Now see, if you look at all the previous sessions which we have done, our our next main video lectures or rapid revision, or even the offline classes which we have done, or even just before the exams we had various YouTube sessions on Abki Baar 200 Par. You will realize that name Abki Baar 200 Par was not just a gimmick, because if you go through all those questions, it would have been really easy to clear the exam with at least 200 plus questions. So we'll see, we'll be showing you some screenshots where we have done and we have recorded various questions and topics. So if you go through all the videos and go through all the previous YouTube sessions recently before the exam, you'll realize that most of the topics were from those sessions only. So that's a good thing, and that is part that tells you that okay, we keep on revising the main videos and other sessions. Most of the questions will be cleared. So let's see about this question now. So after delivery, the lady had a pain in the anterolateral aspect of the thigh. Which nerve was injured? It was various times they have asked. It's a PYQ previous year question. पहले भी बहुत बार पूछ चुके हैं. And the disease we all should be knowing. The disease name is our Meningia paresthetica, right? What we normally call it as Meningia paresthetica. Right? Involvement of which nerve? Involvement of the nerve that is our lateral cutaneous nerve of thigh. Right? How is it involved? Understand that also. See, this nerve over here, it lies around 1 centimeter in proximity to a very important bony landmark, that is our anterior superior iliac spine. And as this nerve is a cutaneous nerve, so it is lying close to the skin and close to the bone also, because you can feel this ASIS. So after delivery or after any operations or after even muscular hypertrophy, this nerve can be easily, this compressed between the bone or the inguinal ligament at that area. Therefore, when this nerve is compressed or irritated, it will lead to pain on the anterolateral part of the thigh, because there is where this nerve is going actually. This disease is known as our meralgia paresthetica. Right? And see, they have asked this question, so remember in futures for the juniors, the questions can be, where is this nerve coming from? Understand this? So this nerve is actually coming from the lumbar plexus. This nerve is coming from the lumbar plexus, right? Its root value is around L2, L3. Its root value is around L2, L3. These all have been discussed. Let me show an image over here. This is a cadaveric image, and here the muscles are being shown, basically the anterior part of the thigh. And if we trace it over here, and see this is the medial border of the sartorius muscle, that is medial border adductor longus, that is the inguinal ligament. So this region over here, this region is known as the femoral triangle, right? Femoral triangle. And where would this nerve be? This nerve which we are discussing, the lateral cutaneous nerve of thigh, it is running close around over here and entering into the lateral part of the thigh. Now where it is very close to the skin and close to the bone also. Which bone? Anterior superior iliac spine, which will be over here. Because this ASIS over here gives rise to the muscle. That muscle is sartorius. Understand this part. Therefore, this nerve can easily be damaged. Now, this whole femoral triangle anatomy itself is very important that we have covered. Let me show an image over here where we discussed this question just few days back before the exams in our various sessions, right? In our YouTube channels also, LNX YouTube channel also, we have discussed. You can see this question, and again, this question we have discussed, and by God's grace or by luck, that has been asked like this only in a different way, but yeah, the topics that we have discussed. Okay, so can have a look at this also. So after this question, and the question that came from the histology part, a very good question, very old question, a very evergreen question. This esophagus does not have which of the following histological layers? And the options over here were mucosa, submucosa, muscle, and serosa. So see, we all know histologically esophagus is a part of the gut. Which part of gut? It is a part of foregut. Gut has 4 layers. What are the 4 layers of gut? Very basics, which we did in all our video lectures. From inside to outside, if you go from inside the lumen to outside, what will we be having over here? Inside always you have the mucosa, right? Mucosa can have different linings. Normally it is columnar epithelium, but in esophagus it has stratified squamous non-keratinized. But in the main part of the gut, the small intestines and the stomach, we have the columnar. So we have a mucosa, and then we have the supporting layer known as submucosa, the loose connective tissue. Then we have what is the role of this? Mucosa will have all the epithelium, right? So it will have the muscularis mucosa, it will have the lamina propria. Some mucosa will have all the vessels, the connective tissue. Outside this, for aiding peristalsis, we have the muscle layer. We have the muscle layer basically, and in the gut we have the mnemonic that is known as ICOL, inner circular, outer longitudinal. But in esophagus, it's a bit tricky. Upper part of the esophagus will have more of a skeletal muscles, right? Lower part of the esophagus will have more of smooth muscles. In between, the middle part of the esophagus has some sort of mixed muscles, but that is fine. That is understandable. Then, on the outer part, as we reach in the gut, I'm talking of gut, we have serosa or we have adventitia. Now, what is the meaning of it? See, adventitia is nothing. Adventitia is just a loose connective tissue which is covering the layer or the gut from outside, where it merges with the fascia outside the gut. That is adventitia. But when that adventitia is spatialized, when it has the peritoneum, then we call it as the serosa. Right? So this serosa will be found in all those organs which are basically intraperitoneal. That also we have discussed in our lectures. Therefore, this serosa layer is not present in esophagus because the majority part of the esophagus is lying in thorax, cervical part, and the small part lies in abdomen, and it does not have that peritoneal or the visceral peritoneal layer covering it. Therefore, this is the layer that is actually absent in esophagus, and that is what they have asked. A beautiful, old question, a very important question that has been keeping on coming in from our histological question. And here's an image of the histology for the esophagus. This is a cut section, the Mason trichome stain. Here you can see few things. What are these? You can see this irregular lumen of the esophagus. Now, why there is irregular lumen? Esophagus normally is collapsed. Normally it is collapsed. When you swallow anything, when you swallow a liquid or a food particle or a semi-solid particle, then it starts to dilate. And therefore, in front of esophagus, what we have? Trachea. So if you take a cut section like this, then anteriorly you will have the tracheal rings. This is the anterior part, that is the posterior part. And behind what you have, this collapsed esophagus, And behind the trachea or the posterior part of the trachea, we have this muscle over here known as the trachealis. We have this trachealis muscle. These are the cartilages of trachea. The C-shaped ring cartilages of trachea, and this would be our collapsed esophagus. Now, when anyone swallows anything, then this esophagus obviously will start to dilate, and therefore it will put pressure anteriorly as well, because behind we have this vertebrae. So therefore, it is this anatomy over here that the tracheal rings, the cartilage is not complete ring of cartilage, it is only C-shaped anteriorly. Behind you have a trachealis. Now this will be pushed by the posteriorly dilated esophagus anteriorly, right? Therefore, we have this collapsed lumen. Now, if we just zoom it a bit, we'll see a few things over here. This is epithelium over here. Now, this epithelium over here will be always remember stratified squamous, non-keratinized. Then, sir, why not columnar? Because it is, when you swallow the food will have some friction onto that food pipe. So you need some protection. You need a stratified layer. Therefore, we have this. Then what do you see over here? This is the part that is the mucosal part. That is the amphor mucosal part, which will have a bit of lamina propria and a small bit of muscularis mucosae as well as over here. Then we have this area, if I put with the red color, this area being the submucosa part, which is actually connected tissue, and it's quite strong in esophagus. It is actually protecting the mucosal layer. It is having the vessels, it is having the nerves, it is having the lymphatics, it is having all the fibroblasts, all the connective tissue over there. So it is surrounding the mucosa. Outside it, you have this thick layer that is the muscle layer. Now, why do we need muscle? For peristalsis, for movement. Suppose you are lying on, you have swallowed anything, that normally food passes down through the esophagus without the aid of gravity also, due to these muscles, right? So you have these muscles outside, then outside this layer should have serosa if it was a totally intraperitone. But here we have, in place of it, we have simple adventitial layer over here. And that is what they ask, histology of the esophagus, a simple question. Right, so remember, for all those who have given the exams, be happy if you have marked the serosa, and I hope that all of you have marked it. And for all the juniors, it's a good learning curve for you, right? Let's see then the question which they asked. So, patient presented with RTS, a road traffic accident. On investigation, EDH was found. EDH is our epidural or extradural hemorrhage. Epidural hemorrhage over here, epidural hematoma. So, epidural hematoma or hemorrhage was found. Which part of the skull was fractured? It's a very, very famous question. It is one of those evergreen questions which always, if you see the last 5 years, out of 4 times they have asked. So we all know that epidural hematoma, the main artery involved or the main vessel involved for here is the rupture of the middle meningeal. Which vessel it is? It is the middle meningeal artery. And which branch of it? Basically the anterior division of it. Right, and this artery is itself a branch of branch of the maxillary artery, which is itself a branch of external carotid artery. I hope some students said the branches were also asked, EC or ICA. So remember that too. So middle meningeal artery, anterior division gets damaged in epidural. Now where is this located? It is for the meninges. Meninges are inside the skull. So it is basically present inside the skull. Now which part of the skull? That part of the skull is known as the pterion, that I hope we all are aware of. This is a very important part. Now, if you also be looking at the other lectures, main videos, or even the clinical videos, you will realize that we have pointed out this area, how to look for this area. It is somewhat around, you say 2 to 3 centimeter behind the frontozygomatic suture and 1 to 1.5 centimeter above it. This area over here, that is the area for pterion. It is actually nothing but H-shaped area or H-shaped sutures, because there are few bones which come over here that we'll see. So basically, this question was all about asking you about the pterion. That is what it is. Nasion is anteriorly, inion is posteriorly, asterion is on the lateral side behind. This is what they ask about the pterion. So remember this pterion H-shaped suture, we'll look at the image. The vessel is anterior division of middle meningeal, which is itself a branch of maxillary artery. That is a branch of external carotid artery. And here you need to do a management, have to be a craniotomy, because it's an arterial bleed. It's acute bleed. It's going to compress the brain. So you need to do a craniotomy. You need to remove the clot and the blood from there to decrease the pressure which is being applied on the brain. And here is this image over here. If you look at this image over here, this is showing us, very important over here, showing us the frontozygomatic suture. This is FZ suture, which you can actually palpate. This is the frontal bone, this is zygomatic bone over here. Here, if you feel the suture, this is the frontozygomatic suture. So if you go behind it around 2 to 3 centimeter at this point and around 1 to 2 centimeter above it, this area is the area of the pterion. Now, what are the bones over here? Understand the name of the bones. the frontal bone, the parietal, the temporal, and the greater wing of the sphenoid bone over here. These bones they meet and they form this H-shaped suture over here. This part of the skull is thin. Why? Because it is covered by temporal fascia. So inside the bone is actually thin and it's lying on the lateral outside. So any injury over here can damage this bone. And if it damages, if it fractures, the part of this bony spicules that will go deep inside you have this artery, and this artery, as you can very well see over here, this is the anterior division of the middle meningeal artery. Anterior division of the middle meningeal artery. And if they may ask you also that this artery is entering the skull from where? This artery should be entering the skull from which foramen? And then this foramen also you should be knowing it. The foramen from which it is entering is basically the foramen spinosum. Right? Now, damage to this artery will lead to bleeding, and then you have the CT scan image, and you have this image which is actually biconvex shadow. It is actually biconvex shadow. CT scan image, biconvex shadow, extraaxial hematoma. That tells you this epidural hemorrhage. And normally these hemorrhages, they don't cross the sutures. That also an important point to remember. They do not cross the sutures. Why so? The reason is they are above the dura. And dura has layers which are endosteal and the meningeal layer. So if we just go a bit deep into the layers over here, understand, suppose this is the one bone of a skull and this is the second bone of a skull, with between you have the sutures, right? Now try to understand, this will be the endosteal layer of the dura mater. This will be the endosteal layer of dura mater. Deep to it, what we have the meningeal layer of dura mater. This is the meningeal layer of dura mater. Now this bleeding over here is occurring where? This bleeding over here is occurring at this point, epidural, at this point. Therefore, when this bleeding will occur, it will enlarge, but it won't pass through the suture line because the endosteal is fused with the periosteal, or you can with the sutural ligaments. Because here you have the sutures and this will be the sutural ligaments. And this endosteal layer is actually fused to the sutural ligament. So this bleeding normally does not cross sutures. Therefore, the shape becomes like this. Understand this part, right? So that was the question, and we have done it previously also. Have a look at this. Just few days before the exam, we discussed about the question again, the PYQ. This is a proof of why this was the PYQ. And you can see the artery over here. We have discussed the stereon also over here. We have discussed this EDH. Everything was discussed already. Well, this is our normally asked questions. So just to prove that if you go through all the LNX channels and the lectures and the videos, you are sure to get benefited. Next question over here. Identify the image over here. Let me tell you, around 2 to 3 years back, they have asked this in NEET PG also. You look at the PYQs in our app, you will understand it. What is it? You can see the swelling over here in the anterior part of the arm. It is basically due to the biceps brachii muscle rupture, and the sign is normally known as a Popey's sign. Popey's sign is a famous cartoon figure, right? So the biceps muscle rupture or the biceps brachii muscle tendon ruptures, the muscle will actually retract back and it forms a swelling over here. This is known as Popey's sign. Right, biceps muscle. Now see, they have asked this. So you know, in anatomy, they can ask you about the various muscles in the front of arm. They can ask you relevant questions in futures, like what is the nerve supplying it? The nerve supplying it is musculocutaneous nerve. If you know this, very good. If you don't know this, then also it's very good because you know it now, right? So nerve supplying this muscle is musculocutaneous nerve. This nerve is basically supplying all the muscles of the anterior arm. Humeral shaft fracture, not having tennis. What is tennis elbow? Tennis elbow, you all must have heard about in our India, we have the great cricketer Sachin Tendulkar. Around 2004 or 5, if I'm not wrong. Now, that time he had this problem, tennis elbow. It is about the lateral epicondylitis, swelling in the lateral epicondyle, the muscle tendons which are attached over here, lateral epicondylitis, right? They can ask you about tennis elbow as well as in future. So, what is the main muscle involved over there? The main muscle tendon involved is ECRB. Others are also involved. The main is this. Tennis elbow can be asked. Radial nerve injury is a very common question. I guess there was another question on the radial nerve injury that also we have done. There was, I guess, a mid-shaft fracture of humerus, and which nerve or which structure was damaged was the question that was asked, right? Again, radial nerve injury, right? So these are all the questions that have come, and I'm very happy to see the questions actually. And if you also know, if you have revised, then you'll go through it. Now this image over here is showing us the biceps muscles. Now look over here. These are the two heads of biceps. The one on the outer side, that is the long head, and on the inner side is the short head of biceps muscle, and you can see the tendon. Where does the tendon insert also? That is also a question. On which bone? Is this radius or ulna? The answer over here will be the bone radius. The biceps tendon basically inserts onto the radius bone. And this is the reason why the biceps muscle action, if we talk about, it is also involved in supination, because it is the radius bone that moves in supination, pronation, not the ulna. This tells us, right? And if you look over here, when you cut the biceps muscle, deep inside the muscle that you see is the brachialis. Is the deeper lying muscle, and there's the cut end of the biceps. Brachialis over there is going to the ulna, therefore it is not involved in supination, pronation, but it is a deep muscle, it is very huge, and thick, and a very powerful muscle. It is a main flexor of forearm. It is a main flexor of forearm. Again, it will supplied by which nerve? The nerve over here will be this nerve that is going down like this. Now, which nerve is this? This nerve is your musculocutaneous nerve. So, this nerve is the musculocutaneous nerve. See? Okay, so this was a question, and I hope you marked it correct. Let's see what else was asked. Again, one of the favorite topics for FMGE is our perineal pouches and the urethral rupture, and again they have asked this. A person had an RT and reported an emergency. He suffered from injury to which urethra? Bulbar part of urethra. Now this should strike your mind. We are dealing with which part of the perineum. This bulbar urethra isn't there. We have different parts of urethra, anterior, posterior urethras. This bulbar urethra basically in the anterior part of urethra, and therefore it lies closer to the skin below the perineal membrane. We are dealing with injury to the superficial perineal pouch according to the question. This also bulbar part of urethra is one of the most common areas of urethra that will be ruptured. That should strike your mind. Your basic revision. Now the question was, what can be the location of the collection of urine due to this injury? So we have an injury in the superficial perineal pouch part of the urethra, that is the bulbar part of urethra. So the urine will start to collect where? In the superficial perineal pouch. It doesn't go into two main places. If you remember, we have discussed many times in our lectures. It doesn't go to two main places. What are those two main places? Those two main places are, it will not go into the ischioanal fossa or ischiorectal fossa. It will not go into the thigh because of the anatomical reasons. The reasons were a Holden's line for the thigh and fusion of Colles fascia with the perineal membrane for the ischial. So it will not go over there. Where will it go? It will go to superficial pouch. It will go to the, it can go to the anti-abdominal wall because it is lying superficial to the Scarpa's fascia, right? So it can go anywhere, but not to these two places. They are asking you what can be the location of the collection of urine. Let us see the options. Inguinal pouch, not too deep perineal pouch because deep perineal pouch is lying above, so superficial. It is not an intraperitoneal bleed. It won't go into the inside the cavity. It can't go inside. Anti-abdominal wall. Yes, it will go definitely anti-abdominal wall, no doubt about it. Again, ischiorectal fossa, it won't go. Let us just look at a couple of images to see the differences over here. See, this is the pelvis shown over here, the bladder over here, and this is the urethra over here, right? And this over here, urethra, which is different parts. So this structure which is lying over here known as perineal membrane, right? This separates the perineum into superficial and deep perineal pouches, right? You will see in the other image the parts of urethra over here. Now see over here, these are all the parts of male urethra. Now see over here, again you have a bladder over here. Bladder is not shown, this is the lower limit of bladder is shown. Below the bladder, prostate, right? And therefore this part of the urethra is the prostatic part of the urethra, P. This small part is the membranous part of urethra, M, and these P and M are basically the parts of posterior urethra. Posterior urethra. Right, and therefore below the membranous part of urethra, if I put a dotted line over here to represent which membrane? The perineal membrane. So this structure over here will be the perineal membrane, and below perineal membrane we have the superficial perineal pouch. Above it we have the deep perineal pouch. Bulbar urethra, you can see this bulb of penis. So this is the area where there could have been some bleeding over from here. Some bleeding would have been occurred from here. And this is from where the blood and the urine would have come out. And therefore it would have collected where? In the superficial perineal pouch. And therefore also understand that this will go above also because there is more collection over here. It will go into the scrotal layers. Around the penis also it can go. Then it can go in the anti-abdominal wall deep to Scarpa's fascia. It can even reach up till the axilla. So that Scarpa's fascia is throughout into the upper part of abdomen also. It can up till reach the axilla as well in rare cases. So therefore understand the two perineal pouches, frequently asked question, the frequently asked topic, and answer over here is the anti-abdominal wall over here, right? Let's see the next question over here. Again, repeated question. If you have doing the last 3-4 years of PYQs, this question you should easily sort it out. A person had the extraction of the third molar tooth, and after this the patient observed to have loss of sensation. The loss of sensation from where? from the entire 2/3 of the tongue and floor of the mouth. Okay, loss of, now which type of sensation they have not said, but they're saying loss of sensation. So we can assume loss of all the sensation, pain, touch, temperature, all of it, and the floor of mouth. Which nerve is most likely to be damaged? So there was the extraction of which tooth? Third molar tooth. And therefore, obviously, there is some nerve damage. They're asking you which nerve damage it is. They're also giving you reasons over here, right? So just few years back, again a question came. At that time, let me tell you, the PYQ, the question was, surgery was being done on the submandibular gland and its duct, right? Which nerve is damaged? That in that case also the answer was same. Again over here, the answer will be our lingual nerve. So here there are few hints. What are the few hints? One hint is, okay, do you know that which nerve supplies the anterior 2/3 of the tongue sensory supply? General sensation is given by the lingual nerve, and the taste sensation is given by the chorda tympani. Chorda tympani nerve, which is a branch of facial, and this is a branch of mandibular division of tricep, right? So both are different, but anatomically, this chorda tympani nerve is very, very thin. This chorda tympani nerve is very, very thin, and it is basically being carried by the lingual nerve. This chorda tympani nerve is very, very thin, and basically it is carried by it. So we can assume over here, we can understand over here that if the lingual nerve is damaged over here, then both the, obviously the lingual nerve will be damaged, but this chorda tympani also will be damaged, right? And they are providing sensation to the anterior part of the tongue. And this lingual nerve, as it is running, it is very close to the third molar tooth. Therefore, the answer is our lingual nerve over here, not the hypoglossal, not the axillary, not the inferior alveolar nerve. Let's see an image over here. Over here, you can see this is the lingual nerve. They are not showing, but the chorda tympani is running with it in a common sheath. And below you have this as the hypoglossal nerve. And the question which a previous year question came was this, about this, and this time they gave you about the third molar tooth. Again, third molar will be close to the mandibular foramen behind, and therefore behind we have the lingual nerve that is running, right? Again, a branch of V3. And we also have the hypoglossal nerve and the inferior alveolar nerve, which is slightly above. So basically, for the dentist, they have to anesthetize the inferior alveolar nerve. If you have to do any any procedure on the teeth of the lower jaw, you have to anesthetize the inferior alveolar nerve, because that is sensory to all the teeth and gums of the lower jaw. So you put an anesthesia solution behind third molar tooth. If you have gone to the dentist, you might be knowing it. And when you put anesthesia over there, anesthesia fluid around it, our lingual nerve is also anesthetized. So even the tongue sensations are also lost. In the anterior part of the tongue, the lower jaw teeth sensation are also lost. That is the reason we have this. So in the question, they have given two things, third molar and this, both of them, if you combine them clinically, answer comes out to be lingual nerve. Beautiful question, right? Let us see this question. Again, a very old PYQ, very repeated, very practical question. If you have done your duties in any hospitals, in medicine or TB chest ward, you'll be knowing it. Or even if you have watched any of the lectures on thorax, a needle has to be inserted by an intern. What is the most preferred site for this clinical procedure? I mean, the language of the question would have been slightly different here and there. But obviously, suppose you have to take the fluid from the pulmonary cavity, right? There is some this pneumothorax or hemothorax or hydrothorax or any pleural abscess there, you have to drain it out. So you will insert a needle. Where will insert in which part of the rib? The lower part of the rib or the upper part of the rib? Where will you go? Obviously, you should not go to the lower part of the rib, because here you have what? Here you have the costal groove, and this costal groove is having what? It is having these intercostal nerve and vessels. The arrangement also has been asked vein, artery, nerve in this format from top to bottom. So obviously you can't go at the, you should always go to the upper border of the lower rib. So if there is this, there are two ribs, imagine this is rib 1 and rib 2, or let us say some other logical number, let us say rib 4, rib 5. And therefore the needle has to have entered at this location. This location the needle should enter. Why? Because deep to it, this area we have the vein, artery and nerve. So if you insert the needle over here, these structures can be damaged. Let us see this image over here. These are the two ribs which are shown. This is rib 1, this is rib 2. You can see this intercostal structures over here. So obviously if you insert the needle at this point, you can damage these structures. I mean, there are good chances that the structure might be damaged. They might not be damaged also, but why take the risk? Therefore, obviously go at this, not at this point. That was the question that they asked. Obviously, if that was not the option, you can think of going at the middle of the spaces and also, but obviously don't go at the lower border of the rib. Always prefer to go at the upper border of the lower rib. That is a famous question, right? Okay. Let's come to another question. What is the vertebral level for the red colored line as shown in the image? So this sort of image that we got, I mean, exact image might be a bit different, but actually the image was over here at this point. You can see this red line. The numbers are written over here because I hope the numbers were not written, because already then the answer will be self-sufficient. But if you look at this line over here, there are a few planes which are located over. What are those few planes? Let me highlight over here. This line, let us say it plane number A, and this line, let us call it as plane number B. Now, if you feel the anterior superior iliac spine, just behind it, around 4 to 5 centimeter behind it, you feel a thickening. That is a tubercle of iliac crest. If you join two on both sides of tubercles, imaginary plane, that becomes a transtubercular plane. Which plane? Becomes a transtubercular plane. That is around L5 or L4, L5 as it's seen over here. That was the line that was asked in the exam. And the second part that can be asked in the future exams is, highest point of iliac crest will be this point B, that is also known as supracristal plane, also known as Stuffius line. This passes around L4. Now, where is it used? To whenever lumbar puncture is being done. Whenever lumbar puncture is being done, you flex the patient either in sitting position or lying down lateral position. You feel the highest point of iliac crest. That is around L4. So these are over here. So if you look at the options, obviously options were confusing, no doubt about it. But here, best bet, we can go with this option L4, L5, transtubercular plane. One of the planes involved when we divide the abdomen area into the regions or the quadrants, right? This transtubercular plane is over here. Other planes also there. There's transpyloric plane, there is subcostal plane. So let us just go through a bit. The transpyloric plane that goes around L1, L2 junction. The subcostal plane that goes around L3. What is subcostal? The lower bottom of the costal margin. Then you have the supracristal plane, upper part of the highest point of iliac crest, around L4, and this transtubercular plane around L5, or you can say L4, L5 junction. That was actually being asked over here, right? So again, a very famous old question, but a very practical question. This is a very practical question that is over here. Again, an old question. A maid complained of pain and swelling at the knee. Which bursa can be affected in this case? Now, sort of image must have been given to you, or if not, then you should be knowing what they are dealing with. They are dealing with the housemaid's knee. Obviously, if you have done the PYQs, it is again a cakewalk question. The housemaid's knee, we have the pre-patellar bursitis. And then the second also, you should be knowing clergyman's knee. They are two famous. They are the infrapatellar bursitis. Okay. So if this was marked A, if this was marked B, that is marked C, or that is marked D, go with option number A. Being basically, you have to search out the pre-patellar bursa that might be inflamed in this, what we say is the housemaid's knee. Why is that? Let us look at the image. When the housemaid is doing the household chores over there, sweeping the floors, they bend more. And they bend more, the patella is the one that is actually striking the surface. But between the patella and the skin, there is a small bursa that might be inflamed. This leads to this pre-patellar bursitis. Understand the logic behind it. Clergyman's knee, which are the normal priests which are there in churches or other areas, when they kneel down, it is the part of the knee area that is, or knee region that is touching the floor is below the patella, and therefore this is the infrapatellar bursa which is involved, and therefore leads to infrapatellar bursitis. Understand this. So pre-patellar housemaids, infrapatellar clergyman's knee. Simple as that. Understand the logic behind it. Don't just cram or rot learn anything. Try to understand the simple logic behind things. Okay, another question. The ossification, the time of ossification. Right, so normally what happens is that you can say this question is a part of forensic question. Anatomy also we talk about ossification, but they're asking about the ossification time of the talus. Normally the talus ossifies around the 7th month. Around which month? Around the 7th month of the intrauterine life. So there are 7 tarsals, we all know. Only 3 tarsals are ossified before birth. So in intrauterine life, right, it is a calcaneum, it is a talus, and it is a cuboid. So these 3 tarsals are ossified before birth in intrauterine life. You can see in image, the calcaneum ossifies around 5th to 6th month of intrauterine life. Talus ossifies around 7th month of intrauterine life. Cuboid a bit late before birth, around the 9th month of intrauterine life. Remember these three. Other tarsals, the cuneiforms and navicular, they are ossified post-birth, right? Here's an image showing us all these. This was the one that they asked this time. So be prepared. What the talus is what they asked this time. So be prepared about the calcaneum, the navicular, the cuboid, the cuneiforms over here for the future questions, right? So be prepared for that. Okay. So this was the question, and therefore answer is option number B. Though options are pretty close, but best bet over here would be the seventh one. Right. Let us see one more. A man is sitting and faces difficulty in standing up and in walking. Which nerve? So when we sit down and when you have to stand up. So when you're sitting down, our hip joint is in flexed position. Which joint? Hip joint. And when we stand up, our hip joint goes from flexion to extension. So which is the main extensor of the hip joint? The muscle over here will be the gluteus maximus, supplied by which nerve? That should be the answer, and that is supplied by the inferior gluteal nerve, and therefore this should be the answer. Now some students are also saying that scissoring gait, some question was given of that. Now normally scissoring gait, if you look at scissoring gait in medicine, scissoring gait is basically seen in cerebral palsies. Scissoring gait when you're walking and there's spasm of the medial compartment thigh muscles, and there's scissoring gait because their adductors are more, they're in spasm. So they are contracted in a contracted state. This scissoring gait goes like this. That would be case of cerebral palsy, or if you can correctly frame the question in the comment box, you can have a look at that too. But the only talk of the standing up from a sitting position, basically referring to what is the gluteus maximus muscle supplied by the inferior gluteal nerve. Scissoring gait basically should have some of the cerebral palsy cases that could be there, spasm of the medial thigh compartment muscles. Okay, do remember that. So let's see in the question. Yes, see, this is again an evergreen question. Anatomical snuff box. It seems to be like the paper is incomplete with unless they ask the question from this topic. Anatomical snuff box, I guess the boundaries they have asked. So we have done a multiple number of times, but again, just to recapitulate, the lateral boundaries of it are formed by the abductor pollicis longus, extensor pollicis brevis, and the middle border of this box is formed by the extensor pollicis longus muscle. And these two clinically, if their tendon sheaths get inflamed, we have the decurvent stenosynovitis. Right? Let's see a couple of images. This is where we have the anatomical snuff box being labeled over here. This is the anatomical snuff box area. Medial boundary is this extensor pollicis longus, M for medial, and these are forming the lateral borders. Content is the radial artery, and at the roof we have the cephalic vein, the superficial branch of the radial nerve. Let us see one more image over here showing us the radial artery as a content of it. Right, as a content of it, these are tendons, and this would be the cephalic vein over here. This would be the cephalic vein, which is forming the line at the roof. This topic again just few days before the exam. Luckily, we were discussing this in a different sort of questions. Like this question we have discussed pain on the lateral side about the decurvent stenosynovitis. Anatomical snuff box is what we have discussed over here. And again, we discussed on the fracture. I guess there some students were also saying the question came on the scaphoid fracture, some bone fracture over there. Again, that question we have discussed just few days before the exam. So these are so repeated topics that we now discuss. Then, according to the inputs we received, the image-based question came out the aortic aneurysms and having multiple episodes of hiccups, and which nerve would have been involved. Some question was like this. Now look at this image, try to understand. This is a cadaveric image. The student said this cadaveric image was over there. Now this cadaveric image is taken on the left side. So this is the anterior aspect, that is the posterior aspect. The left lung and the pleura has been removed. So basically we are looking at the mediastinum from the left side. First of all, understand the image. Now if you understood the image, and this region is the heart basically, and this thick is our arch of aorta. This is the arch of aorta. And here what we have, if I just outline a bit from here, here we have the structures lying at the root of the hilum of the lung. Okay, this also we have discussed multiple number of times, and here let me show you a few structures, and let me write it over here. This will be the pulmonary artery over here, that will be the bronchus, these will be the veins over here, pulmonary veins. Right, fine. But the question was different. The question was asking about any nerve damage. Now see over here carefully, I am putting two arrows. One arrow is going over here and one arrow is going over here. Right, if we just zoom it, try to understand, I am putting multiple arrows to just show you the nerves. Right, You can judge yourself where was the arrow placed. And normally if they are asking the hiccups, they are asking about the diaphragm, the spasmodic contraction of the diaphragm. And the only motor supply of diaphragm is the phrenic nerve, no other nerve. So out of these, if we label this as A and B, you all should be very well aware which is the phrenic nerve. The A over here is the phrenic nerve, which passes in front of the root of the lungs. It also supplies the pericardium, the outer layer of the pericardium, sensory supply. And the nerve going behind this is the vagus, 10th or the vagus nerve. Because behind you have the esophagus. This vagus nerve passes behind because it has to pass with the esophagus. Why? Because it is going to supply the foregut and the midgut, which include the esophagus and the stomach. Therefore, the vagus nerve passes behind. Now, talk of hiccups over here, as I already told you, we have discussed it. This is related to diaphragm, the motor supply of diaphragm. That is only provided by this nerve, that is the phrenic nerve. Now, vagus nerve can have some sensory supply to the diaphragm, but mainly motor supply, when talk of it, it is only phrenic nerve. Okay, so just recall and try to visualize which question was asked. And this we have also discussed in our lectures. Just let me show an image over here where we have discussed this already, being the phrenic nerve and TLD vagus nerve behind. We have discussed them in details in our video lectures. Let's see another question. Again, a beautiful question about the maneuver over here. So in this maneuver, the sort of image might have been there. Language of the question might have been a bit different, but the essence of the question remains the same. They asked about the maneuver, which is actually being compression of the right margin of the lesser omentum, where we have this portal tride structures. So we have the portal tride structures, which obviously include the portal vein, the hepatic artery, and the common bile duct. And if you simply compress them, press them between your forefinger and the thumb, you are actually dividing the liver and the extrahepatic biliary apparatus with their blood supply. Right? And this maneuver, I hope we all must be aware of it, is known as the Pringles maneuver. It is used in liver or the EHB, extrahepatic biliary apparatus surgeries, when the bleeding is somehow not controlled. This is a Pringles maneuver. Right? Now see over here, let me give you a rough idea what is actually happening. See, this is the esophagus, that is the stomach, right? And this is the duodenum. This is, imagine the lesser omentum going around. And here you have this as the right margin. This right margin is having the tride structures. So what is being done is that if you insert the forefinger or the index finger behind the right margin of lesser omentum, and the thumb, if the thumb is placed where? If the thumb is placed in front, right, can compress this right margin. Basically, we are dealing with which foramen? This foramen where your index finger is going behind the right margin of lesser omentum is the epiploic foramen. Epiploic or the foramen of Winslow. Epiploic foramen or the foramen of Winslow. This famous question repeated last. So again, a practical question has been asked. Understand, all of you are listening, understand how the trends are simply changing to a more clinical and more practical approach, which is actually for the good. Right? So Pringles maneuver is what you should be knowing. It is a basic thing. Right? We have the structures. Now, see, the questions have asked, the questions are there for Pringles maneuver, the questions have been asked for epiploic foramen. Let me show you this. We have discussed about the epiploic foramen, the bleeding at the posterior part of epiploic foramen, answer is IVCs. All this we have discussed. But understand, the question might also come around the arrangement of the structures. Where in this portal tride, we have said, okay, there are three structures are there: vein, artery, and CVD. How they are located? See, most posteriorly we have the portal vein in the right marginal lesser omentum. Covering it anteriorly and to the left of it, we have this hepatic artery. So this artery will be in front of the portal vein on the left side, and covering it anteriorly and to the right, this will be the bile duct. Understand the relations also in the this right margin of lesser omentum, that can be asked. So in the image also they are being shown over here, and this maneuver is a Pringles maneuver, right? Okay, a man suffered an injury on the head, and after this the blood collected around the eyes. Injury on the head and blood around the eyes. Again, a practical question, which I hope if you go to the OPDs of even the OPDs, you might see this, because person had a head injury or the minor head injury around a day or few hours back. Now he is seeing those raccoon eyes, black eyes. He will rush, normal person will rush to the ophtho department, right? So if you go to the OPDs, you will see this. They are asking you what is leading to all of this. That is the question. Where is actually the bleeding? Because the injury happened to the head, injury didn't occur around the eyes, the primary injury. So this is basically a question from the anatomy of the scalp. the bleeding is actually happening where? The bleeding is actually happening around the epineuritic or subepineuritic bleed. So basically around the epineuritic attachment would be the best bet out of these options, or they can also subepineuritic region around the loose areolar tissue layer, subepineuritic layer. Now see, understand the anatomy over here, a bit anatomy over here. What is this? Everything has a meaning behind it. We have the skin outside. Deep to the skin, what we have? We have this connective tissue. Again, it has a lot of septa, nerves, vessels, all of it. Deep to the connective tissue, what we have? We have the epineuritic layer. So this will be the muscle layer, right? Muscles, frontalis and occipitalis, and joining them will be the epineuritis over. This will be the epineuritis over here. Deep to it, what will have? We will have the loose areolar tissue over here. And deep to it, what will we have? We will have the periosteum layer over, which is actually fused to the skull bones again. Right? Now see what happens is this frontalis muscle over here, this frontalis, if we consider this as the anterior aspect and this as the posterior aspect, this frontalis muscle over here is fixed to the upper eyelid muscles. If you elevate the upper eyelid, you see some horizontal pieces over here. Frontalis muscle and the LPS, they are working in tandem, right? So therefore this frontalis is glued to the upper eyelid, right? If the bleeding is occurring somewhat over here, so slow bleeding starts over here, if the injury to the head, this blood will slowly trickle down in this direction, and then the loose skin around the orbit, the blood will start to collect over here, black eyes. Now you might ask a question that, sir, why the blood does not go laterally, why does not go posteriorly? Because if you look at the basic anatomy of the scalp, once you look at all those lectures, the layers over here are fused to the lateral and the posterior aspect. At the nuchal lines, they are fused to the bones. On the sides, they are fused to the temporal lines and the zygomatic arches over here. So they can't go, but here they are fused to the skin at the upper eyelid. So the blood can easily trickle down. That is leading to this question, this answer. Here's an image showing us a simple black eye. This is a minor case. Sometimes cases are there when everywhere over here we have the collection of blood, right? Okay, so these were the questions, and then again showing you a few screenshots because I have heard the question came around the humerus fracture also, and asking you which nerve was damaged. So you can see the question we have just discussed few days back, that there was a fracture of the mid shaft part of the humerus, and again this nerve and this deep brachial artery is injured. So these are all few days back. So just to motivate you to look at those YouTube sessions, even high speed also, try to attend live, because you can ask questions directly with the faculty over there, and the main video lectures as well. This question also we have discussed just few days back, and the same thing. If humerus is shown, the fracture is being identified, and which nerve is being damaged, again radial nerve, right? So these sort of questions have been come, and we have luckily discussing them. So go through all the subjects about the lectures. And I guess we also heard about a question came from the craniorachis, right? So that is basically part of embryology, neural tube defect. So neural tube defect, when there is a non-closure of the neuropores, normally we should be knowing that the neural tube is there and they have two neuropores, an anterior neuropore and a posterior neuropore. It closes around day 25 and this closes around day 28. They don't close. If the anterior neuropore doesn't not close, there is an anencephaly. When there is less development of the skull bone, the brain is underdeveloped, being exposed outside. Obviously, the child is not viable for birth. Okay, is non-viable, is a stillbirth baby. And when that closure goes down posteriorly as well, or inferiorly as well, there is opening of the spinal cord, the CSF lying outside. That is what is known as a craniorachis, combination of all these layers which are not able to close. That is again a neural tube defect, and I hope due to the feedback we received that some image-based question was there. So I hope this was the question, and craniorachis would be the best possible battle, right? So guys, that was all, and again I am telling you that relax, exam is over, right? For all those who have given the exam, understand these are topics, note it down, okay? So don't relax too much, note it down the topics. If you will be clearing, and I hope you will be, then these are the topics for the future exams. And for those who are going to give the exams, understand the type of questions, and all the best. And do also understand that, because before the exams, few days back when we are doing the sessions on YouTube and all, these are very fruitful sessions as we have seen over here, right? So that's all the best, and thank you.
Hello students. So now we'll be starting with the radiology discussion for today's FMG exam. So around 8 questions were asked in today's FMG exam from radiology. And yes, the exam was a little tough in comparison to the previous exams, more of in sync with NEET PG level. But you guys, you know what? The lines between FMG, NEET PG and ANAESTHESIA are slowly getting blurred. And I would agree to the part that FMG exam should not be so tough because it is not a counseling exam, it is more of a licensing exam. You're getting a license to practice internship. So, but it is what it is, right? It is what it is. And still a lot of questions that were asked in radiology especially were those from the previous year still, maybe a little back, 3-4 years, previous years, but still they were asked, the topics were similar to the previous year questions only. So let's start with the first question. So the first question is: a patient presents with chills and rigors. He has acute pain in the right flank. So he has an infection, most likely, that we are talking about. The investigation is shown below. What is the diagnosis? So the investigation that is shown, what is it? It is an X-ray abdomen. It is an X-ray abdomen, right? And I think this was the image that has been given to me by students. And what do we see here? So we see in the right renal fossa. In the right renal fossa, we see a black shadow. We see a black shadow. Now, black on an X-ray is air, right? So a air containing structure in the renal fossa will be an emphysema. So air in lungs, we call it emphysema. So this, in a background of patient with chills and rigors, kya hoga answer? The answer will be an emphysematous pyelonephritis. Yes. So cholecystitis. Why will cholecystitis not be an option? Not be the answer. Now in cholecystitis, the air shadow is not in the region of renal fossa. It is more in the right hypochondrium. And normal cholecystitis, normal cholecystitis does not have air. Can cholecystitis have air in the gallbladder? So yes, if the answer was, अगर option में आपको दिया होता कि gangrenous cholecystitis है, ओके गैंग्रीनस कोलेसिस्टाइटिस है, तब में भी हम कोलेसिस्टाइटिस को कंसिडर कर सकते, बट उस केस में भी ऐसी शैडो नहीं होती कोलेसिस्टाइटिस की. दिस इज अ शैडो ऑफ emphysematous pyelonephritis. Now this was also something that I taught in the class about emphysematous pyelonephritis. Very important clinically, life-threatening disease, needs to be drained emergently so as to save the kidney. Now coming on to the second question, which sign is present in the following radiographs? So this is an AP radiograph of the abdomen, and this is a child that we are given because there are thin ribs that are present in this abdomen X-ray. Now there are two bubbles that are seen here. So this is a double bubble sign, and double bubble sign is seen where? It is seen in cases of duodenal atresia. Okay, duodenal atresia. Now clinical cues are also very important. So let's say if the question had bilious vomiting, then duodenal, if the question has bilious vomiting, then the duodenal atresia can be a likely possibility and the double bubble sign can be a right answer. But if the question mentions that it is a non-bilious vomiting, okay, so then the obstruction has to be proximal to the ampulla of Vater, and in that case the answer will be a CHPS, congenital hypertrophic pyloric stenosis, and that has a single bubble. So आप ये लोग खुद ही बताएं कि whether in the option the question whether bilious vomiting was given or non-bilious vomiting was given, because that would change the answer. Now air crescent sign is seen on X-ray. If this is seen on X-ray, it is seen in an aspergilloma, okay, and on a CT it is seen in invasive pulmonary aspergillosis. Now cupola sign is seen in pneumoperitoneum, and this is again a sign that is seen on an X-ray abdomen, Now this is also something that I taught in the class. So single bubble sign is seen in CHPS, double bubble sign is seen in duodenal atresia, and if there is a jejunal atresia, then you see three bubbles, one in stomach, one in duodenum, and another in the small intestine. That is the triple bubble sign that you see in jejunal atresia. Now coming on to another CT of a head injury. Now head injury is such a favorite topic of examiners be it NEET PG, be it ANAESTHESIA CT, and now FMGE, that you cannot miss head injury, studying head injury for your entrance exam. So one of the important topics in radiology is a head injury, be it EDH, SDH, SAH, skull fractures. So this is a patient who presented with a road traffic accident having a head injury. The CT scan is shown below. What is the likely diagnosis? So let's dissect the CT scan. So in the right frontal region, here, what do we see? We see this big scalp hematoma, and beneath that we see a fracture. Now this fractured skull, as the name suggests, is depressing the skull bones. So the answer here is a depressed skull fracture. Now various type of skull fractures I taught in the class. So linear fractures are the most common fracture in which the fractured segments are not displaced, they are in line with each other. In depressed fractures, skull fractures, the fractured segments go inside the brain, okay, they get depressed. That is a depressed skull fracture, and they need to be treated because it increases the ICT. Now in children, depressed skull fractures do not manifest like this. In children, because their bones are pliable, they are malleable, so the bones bend inwards without causing a cortical breach. Now that is known as a ping pong fracture or a Pond's fracture. Okay, so ping pong fracture or a Pond's fracture is kind of a depressed fracture that we see in children. Okay, now coming on to the next question, what is the likely diagnosis from the CT scan image given below? Now I'm not aware of the very clinical details that were asked in the question, but if this was the CT scan that was given to you, then the answer is pretty straightforward. So the medial end of both kidneys, are fused in the center. So this is a case of a horseshoe kidney. Now why is horseshoe kidney important for you clinically? Because these kidneys are more prone to trauma, they are more prone to ureteric obstruction. So increased incidence of UTI, renal stones are common in horseshoe kidneys. And what sign do you see on IVP? You see this flower vase sign, okay, both the medial calyces are fused together, so giving a flower vase sign, okay, flower vase sign we see in horseshoe kidney. Now coming on to the next question from radiotherapy, which of the following is true about radiotherapy? So vomiting is a late adverse reaction? No, it is an immediate adverse reaction. Okay, signs and symptoms of radiotherapy are reversible? No, they are irreversible. Okay, the dose of radiation at a point is inversely proportional to the square of the distance from the source. Yes, this is the inverse square law. This is the inverse square law that we see in radiotherapy. That is, as the point that as we go farther away from the source, the dose of radiation decreases by 1/4. Okay, so if we let's say go twice the distance, if we double the distance from the source, the dose would decrease by 1/4. This is known as the inverse square law. Now the next question, the radiological investigation of choice for pheochromocytoma. Now this is a very controversial question in my opinion, because for pheochromocytoma, usually when we investigate it, we rely more on the biochemical markers than we do so on the radiology per se. Now the role of radiology in pheochromocytoma is mainly for localization. Okay, it is mainly for localization, and in localization, MRI has the best sensitivity. MRI has the best sensitivity as far as localization is concerned. So that will be the investigation of choice in this answer. Now if the question had an option of DOTA-NOC PET, if this was the answer that was option that was given in the question, then that will be the answer in this case, because pheochromocytomas and paragangliomas show SSTR expression. So but in this in the options that were given to me, the option that was of a FDG PET, so that will not be the answer. Among these options, MRI will be the radiological investigation of choice. Now, moving on to the next question, a linear accelerator is used for the production of? Now, linear accelerator produces both electrons and X-rays. So, the answer here is an X-ray. Now, the most common linear accelerator that you see in your day-to-day life is that of a cathode ray tube. Okay, so X-rays uses cathode rays. Basically, there is a positive and a negative terminal, and you rapidly accelerate electrons. They bombard a target, and then X-rays are produced. So, linear accelerators are used to produce X-rays in radiotherapy. Now, for production of gamma rays, what do we use? For production of gamma rays, we use cobalt 60. Okay, cobalt 60 is used for the production of gamma rays. Now, the last question, a 22-year-old man presents to the emergency department after a road traffic accident. His blood pressure is 80/60, so he is hypotensive. So, we are dealing with an unstable patient, okay, hemodynamically unstable patient. His pulse rate is 110, he is tachycardic, and his respiratory rate is 18 breaths per minute. Which of the following will be the next step in this case? So, in an unstable patient, after a road traffic accident in an emergency, you have to do a fast. So, the next step will be a E-fast to see free fluid in the abdomen. Now, if it was a stable patient, then what would have been the next step? Still the next step would have been E-fast followed by a CECT. But in this case, since the patient is unstable, we'd go ahead with E-fast, and if it's positive, we'll go ahead with a laparotomy. We'll open the patient to see the cause of bleeding. So, that was all from the radiology questions. Mixed bag of tough and easy questions. In my opinion, some of questions were quite conceptual. You had to think about it. But overall, many of them were from previous year questions itself. Thank you.
पूरा स्टार्ट कर दूँ? चलो कर लेते हैं फिर से स्टार्ट. Okay guys, am I audible? I know many of you are waiting for medicine recall. This is very, very important. Okay, starting with our first question, that is, which of the following is not included in ABCD2 score? So just try to understand this. This ABCD2 score is a score that is used to predict future chances of stroke in a patient with TIA. So understand this. Why we use a score? So I told you in the class also, this could be like an expected question, and this question came in exam. So this score is used to predict stroke in a patient with TIA. TIA means transient ischemic attack. So in this you can see A for age, B for BP. So age is a feature, yes. BP is a feature, yes. We give 1 point for BP also. Diabetes and duration of symptoms. So remember, current stroke, current clinical feature, it is a feature of stroke, but remember previous stroke is not a feature. Previous stroke is not a feature of ABCD2 score. Clear guys? Am I clear? आगे चलें. First question, पहला question सही हुआ नहीं हुआ? Okay, there are many doubts for other subject as well. So just see, am I clear? Try to, I'm just reading your doubts as well. So just try to ask me your doubts in the comment box. Let's move to the next question. Shoaib Ansari, Doc, Abhi, Shivani, आगे चले. Okay, then this ECG was given, or some students are saying ECG was not given, but again they are asking like all are seen in WPW syndrome except. So again we have discussed this in WPW and long Levine syndrome. These are two syndromes which are associated with short PR. So QRS can be prolonged. That is what we see broad QRS. But PR is not prolonged, it is short. Delta wave is classical feature. Right? So PR shortening is seen, PR prolongation is not seen. So just let us see what we have discussed in our LNX tab. We have discussed WPW and non-Levine syndrome. So you can see a bundle of Kent, we have bundle of James Mayhem. You can see broad QRS. Here you will see normal QRS. Here you will see delta waves are present, delta waves are absent. Then treatment of choice for this condition will, both case condition will be, because these are because of aberrant pathway, so it will be like a radio frequency ablation. Am I clear? आगे चलें. So देखो पेपर टफ आया था. I can understand first paper was bit difficult, but medicine was not difficult this time. There were a lot of questions from the straight forward topics. तो घबराने वाली बात नहीं है. पेपर 2 में मेडिसिन में से 40 में से आउट ऑफ 40 यू हैव मेड मोर देन 25 करेक्ट, ट्रस्ट मी. तो 25 तो यहीं सही हो गए, तो पास तो अपन वैसे ही हो गए. समझ आया? ओके. Patient had road traffic accident. Presentation is having bradycardia and hypertension. So what we call this quotient reflex. GCS is 6. So there is low GCS. SpO2 is 82. SpO2 भी कम है, GCS भी कम है. What should be the next management? Now we don't know it's stroke or not. So thrombolyze करने का तो पता ही नहीं है. IV fluid we will give, but IV fluid there is hypertension already. Urgent CT head, but this is a condition like this patient need an urgent intubation because SpO2 is low. Am I clear? So it's an indication of urgent intubation of this patient. Okay, आगे चलें. Okay, coming to fourth one. So patient present with edema. So edema, ascites and raised JVP. So these are all feature of right heart failure. So there is increased liver enzymes. On evaluation, portal hypertension was present. Means there is damage to right side of heart. Damage to right side of heart. And also there is portal hypertension means there is congestion in the liver. So what we call this? We call this chronic passive congestion of liver, or we call this cardiac cirrhosis or natremic liver. It can occur due to cardiac failure. So it's the case of cardiac failure. So it is a liver cirrhosis in a patient that is because of right heart failure. Am I clear? Okay, बताओ समझ आया नहीं आया?
So see, this is a nutmeg liver. We have discussed same thing. We call this chronic passive congestion of liver, that is right heart failure leading to cirrhosis. Okay, moving to next one. What can be given to celiac disease patient? So this is like a question again, you know, like we have celiac brew, we can give barley, rye, oat and wheat. Barley, rye, oat and wheat. So understand now, see the option what we can give. So suji or semolina, suji and dalia, these are two product of wheat. So ये तो आपको नहीं देने. This you can't give to patient. Oat you cannot give because oat is in bro. Barley, rye, oat, wheat. So oat भी नहीं. Rice pulao, biryani, आप चावल दे सकते हो. So remember, R is not rice. I have mentioned this clearly. So R is not rice. So this was the question came in exam. And rice you can easily give. So rice, पुलाव, बिरयानी खिला सकते हो. तो ये तो सबका सही हुआ है ना, क्यों घबरा रहे हो, कहाँ गए सब के सब? Is this correct or not? Okay, moving to next one, layer absent in esophagus. So like I told you, like this is a layer like serosa. This is considered absent because only in esophageal stomach junction, we call this gastroesophageal junction or squamocolumnar, only in that area it's present. So it is negligible. The serosa is negligible or absent in esophagus. So layers, that is serosa. Again, it's an anatomy overlap MCQ, but again came from our app, so that's why I thought to discuss this question. Clear? Okay, moving to next one, Duke's criteria. So like some students are saying, they were asking question like how many are component in and minor category. So you can see like there is fever, vascular phenomena, immunological phenomena, some predisposing event or blood culture positive, which is not blood culture not satisfying the above criteria. So that is like these are 5 features. So I could not get the exact question, but remember in Duke's criteria there are total 5 minor criteria. So I think this was the question. You can give your input in the comment box. There were total 5 minor feature in Duke's criteria. Moving to next straightforward question, non-caseating granuloma. So it is like a first line of sarcoidosis, which you can see non-caseating granuloma. So again question came straight away from the notes. So non-caseating granuloma you will see in a patient with sarcoidosis. On the other hand, caseating you will see in a patient with tuberculosis. Am I clear? Okay, आगे चलें. Drug of choice for facial nerve palsy. So understand this, for facial nerve palsy, suppose if you are getting a patient on time if you give steroid, then there is like a good improvement in symptoms. So remember, otherwise like we do just physiotherapy, we can give to patient. Otherwise remember there is not much improvement in later on. So try to start steroid as soon as possible. So drug of choice will be steroid. So steroid only one option what we have prednisolone. Increase aldosterone and decrease renin is seen in. So I could not get other option, but what I can show you is like this we have discussed in our again in our app, that is increase aldosterone and decrease renin. That is a classical feature we see in a patient with Cohen syndrome or primary hyperaldosteronism. So that is seen where in a patient with Cohen syndrome. Clear? You can also type in the comment box what are other options. So like in our app in the YouTube also we can make a full video with all 4 options. Okay, आगे चलें. HIV patient is diagnosed with TB. What is investigation of choice? So remember, I told you like in most of the cases like HIV patient they have sputum smear as negative. In that case, how we make a diagnosis? We make a diagnosis by doing CB-NAT. So investigation of choice for a patient who is diagnosed with HIV and TB, what we do? We do CB-NAT. CB-NAT is cartridge-based nucleic acid amplification test. We also call this as Gene Expert. Gene Expert. Moving to next one, the 70-year-old man present with a low backache. 70-year-old man with low backache, KFT is deranged, LFT is normal, gamma globulins are disproportionately increased, X-ray spine showing lytic lesion. So what is the defect, origin of defect? So understand this, this is a question where they are asking you like the diagnosis is clear, it's a case of multiple myeloma, and multiple myeloma it's a tumor of plasma cell. So basically they are asking like what is the site of defect. So remember, multiple myeloma it's a tumor of plasma cells. Moving to next one, patient present with ataxia, confusion, ophthalmoplegia. So you can see a classical triad, GOA, that is global confusion, ophthalmoplegia and ataxia, that's seen in a patient of Wernicke's encephalopathy. So it's a case of Wernicke's encephalopathy, and Wernicke's encephalopathy you can see that is due to thiamine deficiency. So again, this is like a straightforward question which came in exam. So the paper is not that difficult, but you are thinking, don't worry, तुम पास हो, trust me, paper अच्छा गया है. सही तो हो रहा है ना? Okay, patient presented with feature of dermatitis, diarrhea and delayed wound healing. So like remember the most important metal which I can say for wound healing, that is your zinc, and most important enzyme will be matrix metalloprotease. So diarrhea, for diarrhea in children we also give ORS with zinc. So remember, this is the case of zinc deficiency. So zinc is that element which is important, and there is a condition which is occurring due to zinc deficiency, that's called acrodermatitis entropathica. So actually it's a case of acrodermatitis entropathica. Acrodermatitis entropathica, that is due to zinc deficiency. It's an autosomal recessive condition. So this is the answer for this question. Moving to next one. Pregnant girl with increased bleeding post dental extraction, PT is normal, and there is thigh bruising. So just try to understand this. Whenever we talk about like a primary platelet disorder, then remember this will affect your bleeding time. But in disorder of clotting factor, you will see PT, APT will be affected. So factor 9, if you see factor 9 and factor 8, these are ruled out. Why? Because the question is mentioning girl. Am I clear? So just try to understand this. Hemophilia A and B. Factor 8 deficiency is hemophilia A. Factor 9 deficiency is hemophilia B. These are ruled out. Why these are ruled out? Because these are seen in boys. These two conditions are X-linked recessive and X-linked recessive condition. These are in boys. Now coming to vitamin K deficiency. So vitamin K dependent clotting factor, what we have clotting factor 2, 7, 9, 10. So here you will see there will be PT and APTT both will increase. PT and APTT both will increase. So PT will increase, APTT will increase. On von Willebrand disease, you will see it's a defect like von Willebrand factor is a transporting factor for factor 8. So here you will see there is a decreased von Willebrand factor. So what will happen? You will notice when this is deficient, there is an indirect deficiency of factor 8. So factor 8 means your I can say intrinsic pathway will be compromised. So APTT will increase, but PT will be normal. PT will be normal. That's why the answer for this question will be von Willebrand disease. So you can clearly see in this question the hint is PT is normal. PT is normal. So this is the hint they're asking about von Willebrand disease. Am I clear? Okay, आगे चलते हैं. 40-year-old patient with difficulty in eating due to dry mouth. So first hint in the MCQ you are getting is as a dry mouth. She also has dry eyes, keratoconjunctivitis सिक्का. So इससे easy कुछ question नहीं हो सकता. Then there is cervical lymph node. Cervical lymph node means maybe the patient is developing some sort of like a marginal zone lymphoma. So it could be because of lymphoma, and marginal zone lymphoma is very common in a patient with Sjögren's syndrome. So all these are features which are suggestive of Sjögren's syndrome. Is it clear? So sarcoidosis is diagnosed as occlusion in Wagner's granulomatosis. There was also, I know like there was a question on Wagner's granulomatosis as well. So that also we'll discuss later on. Don't worry. आगे चलें. In Wagner's, it's mainly a vasculitis. So you will not see like these dry features. MCTD is the condition where you will see like features of 2 or more autoimmune conditions. Coming to next, a patient present with hypotension, muffled heart sound. Hypotension, muffled heart sound and raised GVP. So you can see like this is what we call this Bake's triad. So this is like a topic which is like FMGE exam favorite, and it's coming from past, I can say now 3 years. Past 3 years FMGE favorite topic. So you can notice here like this is a classical feature like Bake's triad, decreased BP, hypotension, increased JVP, muffled heart sound. So I also told you mnemonic, that mnemonic was PATHOLOGY. PATHOLOGY means pericarditis will have a prominent Y descent, tamponade will have a prominent X descent. So this is so diagnosis will become cardiac tamponade, and in cardiac tamponade what you will see a prominent X descent. Prominent X descent. So prominent X descent means that is not given in the option. Prominent Y you will see in pericarditis. So what you will see when one X or Y, any one is prominent, means other will be decreased. So there will be like absent Y descent. So answer for this question will be absent Y because there is prominent X. Is it clear? Prominent Y you will see in constructive pericarditis, and large C wave you can see and multiple defects. Absent A wave you will see in a patient with atrial fibrillation. So these are ruled out options. Okay, then this is like an interesting question which came in exam. A 60-year-old bedridden patient developed breathlessness. So again, look at the age of the patient, 60-year-old, breathlessness. CTPA means like it's the computerized tomography pulmonary angiography. So that is actually the investigation of choice. CTPA is investigation of choice for pulmonary embolism. So CTPA was done, right? Now CTPA is done. So it's a case of, so diagnosis I can make with this, that is a case of pulmonary embolism. So which investigation should be used to help finding etiology of presentation? So what else we can do? So remember, one thing is what we can do, we can go for like a color Doppler of vein, because most of the embolus, this will come or this will migrate from lower limb. So that color Doppler is not given in the option. Echocardiography, no. Coaglogram, I will not give you any significant finding. MRI is not needed because we have already confirmed the diagnosis with CTPA. So what can help is D-dimer we can do, that can help in confirming a diagnosis. But remember, already diagnosis confirmed, just D-dimer will help you to make a diagnosis. So actually क्या करते हैं, पहले D-dimer करते हैं, फिर CTPA करते हैं. लेकिन क्वेश्चन आपसे उल्टा पूछ लिया. So they are already telling you like CTPA is done. So what else we can do? We can do D-dimer test. Am I clear, guys? D-dimer test. Coming to next one, radiological investigation of choice for pheochromocytoma. So understand this. We have discussed in the class like pheochromocytoma. First thing that we test is urinary metanephrin. Then we'll go for plasma metanephrin. Like if you want to localize the tumor, for localizing to see the tumor, what we do? We go for MRI abdomen. So MRI abdomen. But if tumor is small, in that case, remember, if it is small means less than 1.5 centimeter, that is not seen in MRI. In that case, we can do MIBG scan or we can use a DOTA-TATE scan. Is it clear? So even for like extraadrenal pheochromocytoma, what we call this as paraganglioma. In case of paraganglioma, we straight away go for DOTA-TATE scan. So this thing also we have discussed. So remember, here what we are doing, it is just they are asking about investigation of choice. So first thing what we will do, we will do MRI. Am I clear? MRIs. Suppose in this question, if I ask you like radiological investigation for a pheochromocytoma that is smaller, then answer will become MIBG scan. Okay, then this was a question of rule of half. So rule of half we have discussed. Like again, circle was given, so you can see half will be diagnosed. Out of this half, so half will be treated, right? And you can see half will be adequately treated. So I think there was a question based on circle, like how much percentage. So half means how much percent will be adequately treated, that will be less than half, around 12.5%. So that was a question, that is rule of half is basically for hypertension. So they are asking like a mark adequately treated. So this is the circle, this is the area which I am marking here. This is the area. So let me mark this area. So this is the area which is adequately treated. Clear? That is rule of halves. Okay, coming to next, a person bought 2 bottles of liquor from a liquor shop and later presented with drowsiness, ataxia and blurry vision. Name the antidote. So again, it's a case of alcohol toxicity. So what will be the antidote? So understand, antidote, like some students are saying like fomepizole was not given. So it is not given, then in the option there should be ethyl alcohol. So flumazenil is the antidote for benzodiazepine toxicity. That I think this question also came in exam. Naloxone we give for opioid toxicity. Diazepam is again a benzodiazepine, so that will not use. So answer will be fomepizole. If it is not given, then answer will be ethyl alcohol. So I think friend, in these only one of them is given the option. I think many students are saying ethyl alcohol was given, so this is the answer. Okay, am I clear, Rohan? Okay, coming to next, benzodiazepine antidote. So that you already know now, flumazenil. So we have discussed this, flumazenil. So remember, I told you like drug of choice for alcohol addiction, disulfiram, for withdrawal, benzodiazepine, and for alcohol toxicity, what we give fomepizole. So again, from our straight away from our notes, the question came in exam. So what is the mechanism of action of bedaquiline? This was a question that came in exam. I think I have placed the wrong slide here. So this is like it's inhibiting ATP mycolic acid synthase. This was the question which came in exam. This will inhibit ATP mycolic acid synthase. Coming to next one, calcitonin is a tumor marker. This was the question straight away. So you can see calcitonin is a tumor marker for medullary thyroid carcinoma. Calcitonin is a tumor marker for MTC, that is medullary thyroid carcinoma. I think there was also a question on most common. So remember, most common thyroid cancer will be papillary cancer of thyroid. Papillary cancer of thyroid. A patient presents with symptom of confusion, ataxia, ophthalmoplegia. What is vitamin deficiency? So again, it's the case of Goa. So Goa means that is, you will see thiamine. Thiamine means it is vitamin B1. So this is straight away like Wernicke's encephalopathy case. So this was asked in exam, and I think most of you have marked this correct. Okay, coming to this was like a dose-based question, interesting question which came in exam. So loading dose of Altiplase in 80 kg person. So just look at the screen what I have discussed. Altiplase we give 0.9 mg per kg. So maximum what we give 100 mg. So initially what we give 10% as bolus. Now see, 80 kg is the weight of person. So how much you will give as bolus? So remember, we will give 8 mg. 10% will be 8 mg. So this was the question like loading dose, that is the loading dose. As bolus what we give, that is the loading dose. So loading dose will be 8 mg. Rest we will give like as an infusion over 1 hour. So remember, Altiplase dose they have asked in mg. So in 80 kg what we give 10% we give as bolus, and rest 90% we give via infusion. Am I clear? Okay, coming to next, a 33-year-old woman evaluated with excessive daytime sleepiness from past 1 year, BMI is more. So this was a straight away question. This same question came in INICET in this attempt. Same as repeated in your exam. So BMI is more. You can see BP is more. PO2 is you can see 70. PCO2 is 53. So bicarbonate is 33. So it's like a patient having respiratory acidosis. So it is not Cushing syndrome because even it's not OSA or CSA. It's a case of obesity hypoventilation syndrome because patient is having respiratory acidosis. This thing also we have discussed. Obesity hypoventilation syndrome. All of the following will have hypokalemia except. So again, I could not take the screenshot off because I could not have that time. But remember, all these questions came from the notes. All of the following will have hypokalemia except. So remember, most of the RTA they will have hypokalemia. Type 1, yes. Type 2, yes. Type 4 is RTA is renal tubular acidosis. So remember, RTA type 4 is hyperkalemic type. Is it clear? And this ureterosegmentoscopy, this will lead to your nagma, or I can say, so again here you will see hypokalemia. So only in RTA4, RTA4 is called hyperkalemic type. Okay, child is brought with a 2 to 3 weeks history of not feeding well and irritability, history of TB in sister. LP was performed, following is likely to present in CSF. So they are asking you like what will be the findings. So remember, TB is a bacteria and it's a chronic bacteria, chronic infection, so lymphocytes are ruled out. So you have option of lymphocytes. Now see, I told you bacteria, they love sugar. So they will eat all the sugar from the CSF. So you will see low sugar. So lymphocytosis, low sugar, and proteins will increase in any meningitis. So low protein, that is already ruled out. So remember, proteins and pressure, this will increase in all sort of meningitis. So answer will be lymphocytosis, low sugar, and high protein. And this type of CSF, what we call this as Cobb-Webb CSF. Cobb-Webb CSF. Okay, coming to next, a 60-year-old present with sudden onset right side hemiparesis for last 3 years. BP is 200. All can be done except. So you can see like this CT was given. So you can clearly see a bleed. So it's a case of ICH. So in ICH, what they're asking you, what you will not do. All can be done except. So can we do hyperventilation? Yes, we may. Can we give mannitol? This mannitol will decrease the intracerebral pressure. So that also we can use. BP control also we can do. Thrombolysis absolutely contraindicated because patient is already having bleeding. So it's a case of hemorrhagic stroke. In that case, you will never do thrombolysis. Very, very important. Okay, next one. I can say this was the question. This question came in exam. 51-year-old man with tremors, emotional problem, and cognitive defect. History of trinucleotide repeat disease in father. What is the diagnosis? So there is tremor, emotional problem, and cognitive defect. There is history of trinucleotide repeats. So again, Parkinson will not have that history. So Alzheimer will not have that history. So only 2 diseases which will have history of time not repeat, that is like there are total 4 diseases, like we have Huntington disease, we have Friedreich's ataxia, we have Fragile X syndrome, and we have myotonia dystrophy. So these 2 are not given the option. Now we have only these 2, Friedreich's ataxia or Huntington disease. In ataxia there will be mainly problem with the gait, problem with the ataxia. But patients having tremors, patients having emotional problem, cognitive defect means dementic feature. So that is more towards Huntington disease. So answer for this question will be Huntington chorea. And in Huntington chorea, what you will see? You will see CAG repeat. In a patient with dialysis dementia, what is deposited in cerebral cortex? So understand this, in cortex what you will see? Like different type, A amyloid, it is like dialysis. In dialysis you will see A beta 2M. I think this was the question and this is the answer for this question. A beta is seen in brain, in CNS, and it is seen in a patient with Alzheimer's disease. Transthyretin we see in heart, and it is seen in a patient with restrictive cardiomyopathy, RCMP, or sometimes it is seen in some familial form, like we call this familial amyloidotic polyneuropathy. Is it clear? So again, amyloid beta or A beta is same. So answer will be in dialysis what you will see A beta 2M. This M stands for microglobulin. Microglobulin. Is it clear? Okay, moving to next antibody in AIDP. So AIDP is like acute inflammatory descending polyneuropathy. That is a variant of GBM. So I told you like Green-Berry syndrome, that is GBS. In GBS you will see there are 2 variants, like we call this acute variant and we call this chronic variant. So in chronic what we have CIDP. In acute what we have AIDP. We have AMAN, means acute motor axonal neuropathy. Then we have AMSAN, acute motor sensory axonal neuropathy, and we have Miller-Fisher syndrome. So in AIDP generally what we see like anti-GM1 antibody, and remember like there is like 2 to 4 weeks period before appearance of the symptom. So generally like in that, if you can see like 2 weeks means 14 days, and I can say 4 weeks means it's around 28 days. If you see that much period gap, then antibody will never be acute type antibody. So remember, it's a case of which antibody we can see antibody of IgG class. It will not be IgM, and these 2 are not same. So antibody, this is like a good question came in exam. Antibody will be IgG type. So basically name of antibody is anti-GM1, and anti-GM1 is which class of antibody? Anti-GM1 is generally IgG class of antibody. 13-year-old patient with smoky urine or cola color urine, dysmorphic RBC. This is the biggest hint in the MCQ. Dysmorphic RBC means that is clearly suggesting you of glomerulonephritis. And which glomerulonephritis? It's suggesting you of nephritic syndrome. And you can see cola color urine, RBC is more than 20. WBCs are very little. So bladder calculi means bladder stone. So remember, bladder stone will also have hematuria. But first thing, that will not be smoky. Second, there will be no dysmorphic. In calculi you will see isomorphic RBC. Again, it will not be UTI. Now we have MCD. MCD is having more proteinuria. It is mainly a nephrotic disorder. So answer for this question will be PSGN, post streptococcal glomerulonephritis. Okay, moving to next one. Again, this was a question which was out of the board. I can say this is the only question which came out of my notes. I repeat. But again, if you have slept enough in exam, you can use your brain and still you can make a diagnosis. So remember, it's like a pharmacology medicine overlap MCQ. Elderly male with history of COPD, hypertension, diabetes, or multiple drugs. Which criteria is used to avoid use of certain drugs in old patients? So in geriatric population, they are asking you what is the criteria that we use. So remember, we know Duke's criteria is for infective endocarditis, Light's criteria is for pleural effusion, and we know Jones' criteria is for rheumatic fever. So these 3 are ruled out. So you don't know the answer, I was not knowing the answer, but answer will be this beer criteria. Trust me, I was not knowing this criteria before this question came. But still we can make the answer correct because we are knowing other 3 criteria. Simple. Light is for pleural effusion, Duke's is for infective endocarditis, and rheumatic fever. What we have Jones criteria. Am I clear? Okay, then which drug is least useful in management of patient with thalamic Dejerine syndrome? So understand this. Thalamic Dejerine syndrome. So it is a part of stroke syndrome. We have discussed this. Stroke syndrome. it's the part of stroke syndrome. So when you see it's the part of stroke syndrome, in stroke syndrome what we can see? You can see like neurology, neuropathic pain. So neuropathic pain, so understand this question, try to understand this question. Stroke syndrome means there's neuropathic pain. In neuropathic pain you can use TCA, yes. You can use gabapentin, yes. You can use cannabinoids, yes. There is no role of analgesics. Analgesics are not that effective in a patient with neuropathic pain. That's very, very important. Clear? Okay, moving to next one. Following will help in making diagnosis of bronchial asthma. So remember, in bronchial asthma, how you make a diagnosis, you will see like FEV1. FEV1 will be more than 12% above baseline. Here 15 is given, so that is the best answer. Other option, like some people are saying it was given X-ray, so we do not make any diagnosis based on X-ray. It was CT and something else. So remember, whatever are other option, the diagnosis of bronchial asthma will make when you see like FEV1 is increased by more than 12% above baseline. Okay, then there are a few questions more. So just let me just read this question so that you can get an idea. This is the question number 38. I could not get the time to make this question. So there was a question on Wegener disease. There was a question clinical case. So just I am writing the clinical case in front of you. It was like a 30-year-old with recurrent episodes of epistaxis. So this was the question. You can see epistaxis, right? Runny nose. Then you can see the patient is having hemoptysis. Hemoptysis was there. Cavitatory lesion. In both lungs. So understand this. You can see it is URTI, it is LRTI, and one more thing is mentioned, hematuria. So URTI, LRTI, hematuria, these are features that we see in a patient with Wegener's granulomatosis. And for Wegener's, the question was asked like, what is the name of antibody? So it was Cianca. So remember, Wegener's, the antibody that we use is Cianca. Coming to next question which came in exam. So this will be question number 39. So understand this. In this question, they have asked you about like what should be the dose in a patient of hyponatremia. So understand this. So this it was given like sodium value is given 120. So normal value of sodium is 135 to 145. So we have to calculate. So this was a female patient with sodium value as 120. So question was we need to calculate the corrected sodium. So how to calculate corrected sodium or corrected amount of IV fluid that we should give? So we should calculate this by a formula that is total body water 140 minus the given value, means 140 is expected, 135 to 145, average is 140, and how much is given? 120. So total body water you should know how to calculate. So remember, this is calculated by, you can see like patient weight should be there. So weight was given 40 kg. So total body water, for this we have a formula like weight in kg multiply by 0.5, it's a female, 0.6 it's a male. This is the formula for total body water. So you can see 40 into 0.5 and 140 minus 120. So you can write like this, 40 into 0.5 and this will become into 20. So if you do this multiplication, this will be 200 into 400. This will become around 400. So this was the question came on like correction of sodium or IV fluid that we should give, that is 400 per day, correction per day. Okay, then there was a question on like there is an elderly patient with a case of multiple ring enhancing lesion. Multiple ring enhancing lesion. So this was a question like image based question came in exam, I can say few years before. So it's a case of NCC. The question was all are given in emergency except. So these are the options. So in emergency what we should give? We should give steroid. We should give anti-epileptic drug, AED. Then third option is like we should control edema. And fourth option is what we have, we should give anti-helminthic medication. So understand this question like it's a case of neurocystic sarcosis. So In steroid we can use. Why steroid? Because this will decrease the inflammation, this will also decrease the edema. Anti-epileptic drugs we can give because this will control the epilepsy, this will control the seizure. We can control edema by giving drugs like mannitol, but antihelminthic drugs, these are not needed on urgent basis. Is it clear? So this was the question, these are not needed on urgent basis. Is it clear? So this is the answer for this question about NCC. So I can say this was 39 and this was question number 40. So these were 40 questions. Out of this 40 questions, remember all 40 questions came from our notes, except this one, which you can rule out by ruling out other choices. So this is from my side about the discussion of medicine. Thank you so much. Keep working hard. Bye bye.